Participation, questions, and open dialogue. Once again, we extend our heartfelt gratitude for your presence here today. We look forward to having an enriching and enlightening experience together. Thank you. I now hand over the mic to my colleague, Dr. Hatim, to commence the academic sessions.
Good morning to all the speakers, moderators, chairpersons, and fellow delegates. It gives me great pleasure to extend you a very warm welcome on behalf of KMC Manipal Hospitals. We will commence our first session for the day. The topic is recent guidelines in lipid management in an Indian perspective. I would like to invite Dr. S.S. Iyengar to the dais as the speaker of this session. Dr. S.S. Iyengar is a renowned cardiac electrophysiologist and interventional cardiologist with extensive expertise of more than 48 years. He is currently working at Manipal Hospitals, Bangalore. He graduated with MBBS from AFMC Pune University and acquired his MD in medicine from AMC Pune University as well. He also pursued his DM in cardiology from the same university. He went on to acquire his fellowship from the Royal College of Physicians in the UK. Dr. Iyengar specializes in cardiac ablation, cardioversion, carotid angioplasty and stenting, heart valve replacements, just to mention a few. He is a proud member of the European Society of Cardiology and a lifetime member of the Cardiological Society of India. He earned a fellowship from the Indian College of Cardiology. The President of India awarded him with the Honorable Vishishta Seva Medal for his exceptional contribution to the field. Further, I would like to invite Dr. B.V. Manjunath as a moderator for this session. Dr. B.V. Manjunath is a professor and head of Department of Cardiology at AJ Hospital Mangaluru. Now, I would like to invite the honorable chairpersons of the session, Dr. Suresh G. He is a professor of medicine at K.S. Hegde Medical College, Mangalore. Dr. E.V.S. Mabin, he is a consultant physician at AJ Hospital Mangalore. And Dr. Pawan M.R., he is a consultant physician at KMC Mangalore. This thing. Oh, speaker? Yeah. I would also like to invite Dr. Nitesh Bhandari as a consultant physician at AJ Hospitals Mangalore as a chairperson for this session. Thank you also for gracing the seats.
Hello. Good morning, friends. It is a great honor for me to moderate this session on lipid management Indian perspective. We have the towering personality, Dr. S.S. Iyengar, who has done a lot of work on lipids in Indian, and also he has given some guidelines to the Indian subjects when we look for the dyslipidemia management. And we are very eager to hear you, sir. Please proceed with your presentation.
Thank you, chairpersons, ladies and gentlemen. It is a great pleasure to be here amongst the Mangalore minds, and greetings to all of you on this happy occasion. And my topic is, it's not moving. Yeah, my topic is recent guidelines in lipid management towards the Indian perspective. And let me start with my favorite author, Richard Gordon, who said, ashes to ashes, dust to dust. If the cancers don't get us, the arteriosclerosis must. So prevention of atherosclerotic cardiovascular disease should be our priority. apart from knowing the facts of life, we should know the facts of life because the focus is on management of lipids. Now we'll go through the burden of atherosclerotic cardiovascular disease, global and the local, and ASCVD risk assessment. How do you assess? What are the conventional risk factors? What are the non-conventional risk factors? The focus, again, I'm going to do it on non-conventional risk factors because most of us know what are the conventional risk factors. And what are the lipid goals? LDL cholesterol, that is the target, and what are the other lipid targets, and conclude that. Now, starting with epidemiology, the total CVD prevalence has increased to 621 million. So in 2020, it has gone to 621 from 601 million. Whereas it comes to the DALYs, the total number of disability-adjusted life years, because this gives us idea of both morbidity and mortality, due to ischemic heart disease has risen steadily, reaching 185 million, and 9.4 million deaths, and 250 million prevalent cases of IST, and so is the stroke. Now looking at the other way, the total CVD mortality rates by region-wise, this is South Asian. If you see the CVD mortality is 287 per 100,000 in 2021, as compared to you look at the Australasian on the extreme corner, it is only 102 per 100,000. And if you look at the, again, disability just life years, country-wise, the third slot is India, and again, is mainly due to the ischemic heart disease and stroke. And most of the risk factors are, again, if you look at down below there, metabolic risk, hypertension, and cholesterol. The CVD mortality has been steadily increasing. If you look at this, I don't know, I think this doesn't show. The cardiovascular mortality has increased by 40% from 1990 to 2015. IST mortality has increased by 33%. Compared to Western population, Indians have a higher ASCVD risk. We develop it at an earlier age, and we exhibit a more severe form, and there is a poor outcome. 79% of Indians have at least one lipid abnormality, as shown by this ICMR study, and high LDL cholesterol was seen in about 11.8%. The unique feature of our lipid abnormality is low HDL, high triglycerides, and high or elevated small dense LDL cholesterol. If you look at the state-wise prevalence of high cholesterol, the prevalence of high total cholesterol in 2016 was the highest in the high epidemiological transition level states. They are all quite high up in the ladder of epidemiological transition, states like Kerala, Tamil Nadu, and Himachal Pradesh, and Karnataka follows close second. Looking at the prevalence of dyslipidemia in India, this is a hospital-based study where they looked at about 67,000 patients admitted to the hospital. You see that the LDL cholesterol, second on the list there, it was 35% amongst women and 28% amongst men. To compound this problem, the awareness, treatment, and control of hypercholesterolemia is also dismally poor. The awareness is only between 13 and 17%. This is amongst the urban population. And treatment, only about 6 to 7% of them get the treatment for abnormal lipids. And control is seen only in 3 to 4% of patients. And inter-heart study, all of us are familiar, where India also was a part of the whole study. They looked at 15,000 cases of MI with 14,000 controls. And what they found was the highest population attributable risk was because of dyslipidemia, as shown in the lowest. The ApoB-ApoB ratio had the highest population attributable risk as far as the acute MI was concerned. The prevalence of coronary heart disease in India is about 10 to 12%. So the burden of atherosclerotic cardiovascular disease is an issue of great concern. So prevention, both primordial and primary prevention, need attention. Now, these are the 8 essential metrics which decide the health of your life. So these must be measured, because if you can't measure it, you cannot improve it. One is BMI. Optimal BMI in adults is, of course, Western countries is 25, for us is 23 kg per square meter. 150 minutes of walk per week. Optimal level of non-HDL cholesterol of 130 milligram per deciliter or less. A normal HbA1c level of less than 0.7%. Level of blood pressure 120 by 80 or less. And lastly, they've added this: adults need 7 to 9 hours for sleep each night, not during the daytime. So what we need is action. So first, we must assess the cardiovascular disease risk. Then we must act upon it to improve, and we must achieve the goals. We have reached the moon, so it is not difficult for us to reach the targets. Now let us look at the atherosclerotic cardiovascular disease risk factors. Now we know the traditional risk factors like age, diabetes, hypertension, dyslipidemia. These are called conventional risk factors, and there are non-traditional, non-conventional risk factors, quite a lot of them, and there's an ever-expanding list. But remember, the expanding list of non-traditional biomarker is outweighed by the standard risk factors. So don't forget the standard risk factors for predicting future cardiovascular events, because the non-traditional risk factors or non-conventional risk factors add only moderately to the standard risk factors. And also remember, risk assessment is a dynamic process. So there are many names given to these non-traditional risk factors: non-traditional, non-conventional. Now the new things that are emerged are emerging risk factors, risk enhancers, and risk modifiers. Now if you look at the ACC guidelines, these are the risk enhancers, and you'll be surprised to know that Asian ethnicity, being Indian itself, is a risk enhancer for atherosclerotic cardiovascular disease. Then EAC also has listed a number of them, where they have included the social deprivation, obstructive sleep apnea, NAFLD, etc. to this list. Now, what are the risk modifiers? Basically, there are several clinical, biochemical, and genetic markers may be associated with increased ASCVD risk. However, the strength of their association with the ASCVD, their incremental value or other risk factors, or their applicability in the Indian population is less clear. So here's these factors, we call them as risk modifiers. Now, the presence of one or more of these risk modifiers in low or moderate risk or borderline risk patients will help us to reclassify them to in the higher or a lower group. Now, based on this, Lipid Association have had come out with these risk factors and risk markers, major risk factors, high risk features, and risk modifiers. And based on these factors, you could put an individual into low risk, moderate risk, high risk, very high risk. And we also introduced this term, an extreme risk, because you cannot put all coronary artery disease group into one basket. Now, these are the risk modifiers which I will briefly discuss. The last week, all of us know, has been hectic and historic, socially and politically. So let us also start with ladies first, women-specific risk factors. And let me quote two great women cardiologists. This is their statement. The medical community has viewed women's health almost with a bikini approach, looking essentially at the breast and reproductive system, and almost ignoring the rest of the woman as a part of women's health. So how do we move beyond this bikini health? The other, Dr. Martha Gulati also said, despite recent declines in cardiovascular mortality in women over the past decade, cardiovascular disease remains the #1 killer in women. Deaths attributable to CVD outnumber the deaths attributable to breast, ovarian, uterine, cervical, vaginal cancers, or childbirth combined and put together. So we must remember this fact. So we should forget to continue to focus on the bikini boundaries. Now, these are the sex-specific risk factors for ASCVD across the lifespan. To simplify it, if you see on the other extreme, in younger women, it is onset of menarche, if it is early, if it is delayed. then polycystic ovarian syndrome, then oral contraceptives, then preterm menopause. These are the risk factors. Then pregnancy, gestational diabetes, gestational hypertension, preeclampsia, preterm birth. In older women, it is menopause, hormones, and replacement therapy. Now, just looking at the 31 lakh women in 32 studies, clearly showed that coronary heart disease risk increases, as you see there. The all-cause mortality risk increases, and cardiovascular disease mortality increases. So the findings of this review indicates a high risk for CHD, cardiovascular disease mortality, and overall mortality in women who experience premature or early onset menopause. In the study of about 146,000 first-time pregnant women, follow-up of 4.7 years showed that hypertensive disorders during pregnancy were associated with 2.2 times higher risk for subsequent ACVD. Preeclampsia, 4-fold increase in the risk of future incident heart failure, and 2-fold increase risk of coronary heart disease, stroke, and cardiovascular mortality. Polycystic ovary syndrome, it affects 4 to 24% of reproductive age Indian women. There's increased risk of metabolic syndrome, diabetes, pregnancy complications, and endometrial cancer. They have insulin resistance and dyslipidemia. Prediabetes is another thing I'd like to briefly mention as one of the risk enhancers. This is a study of 10 million individuals followed up for 9 years. Again, clearly shows those who have prediabetes, they increase all-cause mortality, they increase composite cardiovascular disease, increased coronary heart disease, and increased risk of stroke. So what it showed was prediabetes associated with increased risk of all-cause mortality, cardiovascular disease in general population, and in patients with atherosclerotic cardiovascular disease. And impaired glucose tolerance, of course, carries higher risk than the first prediabetes. Thirdly, risk of all-cause mortality associated with impaired fasting glucose are mainly attributed to fasting plasma glucose in the range of higher than 110 milligram. So the prevalence of pre-diabetes also is increasing worldwide, must remember, and reports estimate that about 470 million people have pre-diabetes by 2030. So we should focus even on this group of pre-diabetes, and even amongst diabetes, we see that the risk modification is not all that good. Now, how does it cause increased risk? Is basically the insulin resistance. It causes dysglycemia, it causes endothelial dysfunction, inflammation, prothrombotic state, dyslipidemia, and hypertension. Inflammatory diseases. Now, rheumatoid arthritis, spondyloarthropathies are associated with significantly increased risk. And this is one study of, again, 43 lakhs, where they found that rheumatoid arthritis was associated with same risk as MI as further as diabetes mellitus is associated. So risk assess, the intensity of risk is same as those with diabetes. And that shows the difference between the general population and the rheumatoid arthritis when the incidence rate ratio is concerned. So mechanism, basically systemic inflammation. We all know atherosclerotic cardiovascular disease is an inflammatory disease also, and concomitant presence of ACVD risk factors and long-term use of old steroids and NSAIDs. Hypertriglyceridemia is another risk enhancer, and one study where they looked at the vascular ultrasound, CT, and PET, it showed that people who had higher triglyceride had higher number of vascular arteries involved. They also had higher risk of vascular inflammation. Again, the mechanism is triglycerides cause endothelial dysfunction, inflammation, and oxidation. But it is a contentious issue, always been triglycerides, because one study showed that if you had adjusted with non-HDL cholesterol, then the triglycerides are no longer important. But recent study has, people have studied the content of triglycerides in the LDL, And they found that if it is high, the risk increases, and it is independent of ApoB or LDL cholesterol. Now, in this confusing sort of scenario, what is the message for clinicians? Remember, targets of lipid-lowering therapy will continue to be LDL cholesterol, non-HDL cholesterol, and probably ApoB will come shortly, and probably potentially lipoprotein little a, when specific therapies become available for these LP little a, with awareness that triglyceride is a marker of persistent ASCVD risk. Then there's a polygenic risk score. I will not go into details, but if you use this, you'll be able to identify 20% more in the general population who will need statins. But we need actual incremental value remains under investigation. Is it relevant for Indians? Probably, because we have premature coronary artery disease, because this can be applied at any age, even at birth. But we need to wait for this to become to a clinical reality. Now, what are the influence of environment on genetics? Now, they found that among participants who have high genetic risk, a favorable therapeutic lifestyle was associated with nearly 50% lower relative risk than those who led an unfavorable lifestyle. So what it means is DNA is not destiny. Environmental can influence your genetic risk. Air pollution is another important thing that is coming up. Is supposed to be a major under-recognized risk factor, but air pollution should be considered as a risk modifier in clinician-patient discussion. You should be aware of that. We'll hear more about it. A lot of people are doing great work. Our Public Health Institute in Delhi under Dr. Prabhakaran have done a lot of work in this field. There are many other factors, risk enhancers, including cancer chemotherapy should be kept in mind. Then pet ownership. If you own a dog, probably you'll have less low risk because dogs take you for a walk. Then you have gut microbes coming in a big way. Then last, I won't forget sleep, which is my favorite pastime. And sleep, this is what Aldous Huxley said, that we are not much sicker and much madder than we are is due exclusively to that most blessed and blessing of all natural graces, that is sleep. Now what next? You know all these risk factors, we know all the risk enhancers, so you should identify this in an individual, then identify the goal and achieve it. Now, how do you do this? There are many risk scores. You got the from USA, you got from Europe, you got from France, you got from WHO. And I feel simple one is our Lipid Association. We don't need calculators, I don't need to score, you don't have to be good at mathematics. So based on major risk factors, high risk factors, risk enhancers, you put them into low risk or extreme risk. Now lipid lowering therapy, it comes, remember LDL cholesterol is the target because it has been shown to be the cause of atherosclerosis by experimental studies in animals, by epidemiological studies, human genetic studies, and randomized controlled trials. Americans believe in threshold, they don't have target, they say reduce by 50%. So only when they believe in threshold, whereas the Europeans have come to absolute values, low to extreme risk. Initially, they identified all patients with coronary artery disease as very high risk, but those who had experienced event in the past 2 years, they put them into extreme risk where they have identified LDL goal as the 40 milligram per deciliter. Now, Lipid Association in India has created this category where extreme risk category B should be less than 30 milligram per deciliter. And how was this arrived at? Based on randomized control style Fourier study, the LDL goal achieved was 30 milligram per deciliter, and show the benefit of this when you achieve LDL of 30 milligram per deciliter. And there are about 266 patients from India. So we're part of this study. We can't say that this is not study, it doesn't apply to us. Then the Odyssey study where the LDL target was between 25 and 50 milligram. Again, here there are about 400 patients from India. And this study showed that The lowest mortality is achieved when you achieve a goal of LDL of 30 milligram per deciliter. And seeing is believing. Look at the intravascular imaging studies. There is decrease in the atheroma volume. There's a decrease in the lipid core, and there is increase in the thickness of the fibrous cap. That is, when you achieve LDL from 154, it has come down to 23 milligram per deciliter. So lower the LDL cholesterol, you're more likely to achieve regression atherosclerosis. So based on this, created in a 3 extreme risk group, then you reach the goal, 30 milligram per deciliter. So high cholesterol is bad. That's initially how it started. Average is not good. Lower is better. Even lower is even better. And lowest is the best. Now, this is what Braunwald's corner, if you're interested, read this. And he said, you can achieve a LDL cholesterol of 20 milligram per deciliter, which is safe and effective in reducing progression of ASCVD. And he recommends for primordial prevention, what should be the goal is LDL cholesterol less than 70 milligram, BP less than 120 by 80, diet, no smoking, blood sugar less than 100, 150 minutes of walk, BMI of course should be 23 for us. So in summary, a lot of other things have been covered. Please start routine screening of all subjects at the age of 18 years or at the college of entry, or whenever you come across your patient first. Exclude secondary causes of dyslipidemia. Use LA algorithm, or you could use any algorithm which you are familiar with. Best thing would be Curious because it applies most suitably for Indian patients. Stratify patients in various risk categories. LDL is the primary target, lower the better. Non-HDL is a co-primary target. ApoB estimation should be encouraged. Estimate lipoprotein little a in all your patients. Lipid-lowering armamentarium has statins, ezetimibe, bile acid sequestrant. Now we have bempedoic acid and PCSK9 inhibitors. And we also have lipoprotein apheresis because some patients don't respond to any of these. We don't have evinacumab, so lipoprotein apheresis is another answer. Ensure adherence to therapy. Risk assessment is a dynamic process. And don't forget primordial prevention. Take-home message, the recommendations are designed to inform clinical judgment and not to replace it. Thank you.
Great, sir. It was a very extensive the presentation of the dyslipidemia management. And day to day in our clinical practice, we find a lot of patients who do not stick to the statin therapies. And also, we also find a small percentage of patients who, despite giving the most potent statin tolerable dose, still their dyslipidemia cannot be reached to the goals which we want to achieve. So what is your take-home message as far as the inclisiran, which is going to be released next month to India for the clinical usage? You have any suggestions to make to include inclisiran in those good patients who have resistant to the regular dyslipidemia management?
Yeah, inclisiran is another good drug which is going to be available shortly. This is a miRNA molecule. And so apart from lifestyle measurements, statins, now we have ezetimibe, bempedoic acid. If they don't respond to this, of course, PCSK9 was available. So instead of PCSK9, probably inclisiran will be preferable in the sense that you have to give it less frequently. So apart from giving first one after 1 month, then 3 months, then every 6 months. So every 6 months, patient comes to your follow-up, you give him an injection, is administered in your clinic, you have a follow-up. So it will be a good addition to our armamentarium. Probably it will be better than PCSK9 as far as the adherence is concerned, but it is to be seen.
Panelist, any suggestions or comments from your side?
Good morning, sir. I'm Dr. Nitish Bhandari, physician. As physicians, we see a lot of youngsters coming to our clinic because of this general checkups. We get to see a lot of dyslipidemias, but with the good lifestyle, good BMI, but still the triglyceride or LDL being high. Do we need to target such people or just lifestyle, with all lifestyle modifications?
Yes. That's why I said we must screen as many people as possible right in the early early childhood or early age group. These people, I think we should see, should not forget to ask the family history, which most of our at least, we keep seeing that these are missing in the clinical case sheets. Family history of premature coronary heart disease is important, you must find out. Then improvement in the lifestyle risk factors like diet, then exercise, smoking, alcohol, these should be avoided. And the most important thing is you should do the risk assessment. That is important because the intensity of your treatment is going to depend on the risk you assess. So if he doesn't respond to lifestyle modification and is not achieving the goal which you have set for his risk, then you should use statins. So it should be, don't use in low-risk patient, don't use drugs first, use lifestyle intervention, give him a chance for 3 months. If it doesn't improve, put him on statins after discussion with the patient.
So continuing on the same lines, can we look for HSCRP in those patients?
Yes, HSCRP also is one of the risk modifiers. But isolation, in isolation, no. Particularly in Indian setup, it is a bit, we don't have large studies to tell this, but generally the HSCRP in general population is slightly higher than the Western population. So we don't know exact cutoff. There has been a study done by, again, St. John's Medical, Dr. Prem Pai had done a study on this. It is slightly higher than the Western population. So you could use it in a borderline patient where you are wondering whether to give statin or not, then you could use it and do it.
Thank you.
How much of contribution does diet contribute for dyslipidemia, or it's mainly the hereditary aspect which mainly causes the dyslipidemia, sir?
Yeah, diets contribute, and I would say that if you follow the diet, Mediterranean diet or Indian modified Mediterranean diet, you could bring down the atherogenic lipids by about 10 to 20%. Most of the time, it is genetic. The genetic, maybe if it is a monogenic factor like familial hypercholesterolemia is very clear, they have very high cholesterol, but there are people who have borderline elevation. Some of them could be heterozygous familial hypercholesterolemia, but these patients will respond to diet, exercise, etc. But as you said, it has to be, attack should be from multiple fronts.
Thank you, dear doctor, for that wonderful session. I cordially invite Dr. B.H. Krishnamurthy Rao, sir, to hand over a small token of appreciation to our dear speaker. I now invite Dr. Manish Rai to commemorate our moderators and the chairpersons of this session. The moderator, Dr. B.V. Manjunath. The chairpersons, Dr. Suresh. Dr. E.V.S. Mabin. Dr. Nitesh Bhandari. And Dr. Pawan M.R.
I would like to invite the speaker of the next session, Dr. S.M. Ashraf, to the dais to speak about the topic. The topic for the next session is stable coronary artery disease, medical management compared to revascularization. Dr. S.M. Ashraf is the professor and head of Department Cardiology, Government Medical College, Kannur, Pariyaram. He is a proud alumni of the Calicut Medical College and Trivandrum Medical College and has completed his cardiology training in Mumbai at the TNMC and BYL Nair Hospital. Dr. Ashraf has over 20 years of experience in interventional cardiology, and he is currently doing research on the topic of women and heart disease. Dr. Ashraf has more than 20 original research publications in indexed cardiology journals. Dr. Ashraf has completed 15 interventional cardiology live case transmissions in national and international forums and conferences, including ones at San Francisco and Washington. Thank you, sir. Now, I would like to invite the moderator of the session, Dr. Pradeep Pereira, to kindly take a seat. Dr. Pradeep Pereira is the head of Department Cardiology, Father Muller's Medical College, Mangalore. Thank you, sir. Now, I would like to invite the honorable chairpersons of the session to have a seat. Dr. Chakrapani M., Senior Professor, Department of Medicine, Kasturba Medical College, Mangalore. Dr. Christopher Pies, Senior Professor, Department of Medicine, Kasturba Medical College, Mangalore. And Dr. Jay Prakash Alva, Professor of Medicine and former Dean, Father Muller's Medical College, Mangalore. Thank you, sirs.
Good morning. Medicine and biology are quite fascinating, interesting because they're non-linear and unpredictable. Infection and disease, they're totally different. Similarly, block and the disease in cardiovascular disease also are entirely different. So how do we handle this stable block? Dr. Ashraf is going to throw a light on this very interesting and very complicated topic. Over Dr. Ashraf.
Thank you, sir. Respected chairperson, senior colleagues, and my dear friends. Basically, the stable ischemic heart disease is a hot topic among cardiologists and physicians because we are seeing almost 20% of patients in our population with heart disease are chronic stable angina. And it's very easy that unstable angina and myocardial infarction, early invasive therapy has role, and that reduces the mortality and morbidity. But there is an issue with the stable coronary disease. Here. Slide is not moving.
Doesn't work, huh? You have to keep the pointer over here.
Okay. This is okay. So we'll start with the one case examples. She just did the procedure day for yesterday only. She's 58 years and diabetic and hypertensive and effort angina for the class 1 to 2 for 6 months duration. And okay. And you can see that ECG is not showing any changes, only minor repolarization abnormalities. What, man? Excuse me? It's not working there.
The pointer over here.
Yeah, okay. No. What? Okay. So you can see that TMT showing there is a positivity in the TMT, and she could achieve even up to the stage 4. And there is the exercise tolerance is more than 10 meds. And this only mild positive cases. So subsequently she underwent echocardiogram. The echocardiogram that was showing only normal LV function, no regional abnormality. And this is the angiogram. You can see that this is the left coronary artery, and there is a septal origin. There is a 70% stenosis, this area. And many of the people may think that is severe disease or maybe borderline to severe disease. So this is the right coronary artery what we are showing, and this is the left again. And this is this area what we have seen the prior slide. So there is a borderline to 70 to 80% stenosis in one angle. And what is the approach? And having said that, her TMT is showing the positive TMT, the METs is more than 10 METs. That means mildly symptomatic. So these sort of patients, there is an issue whether to treat or not. The one issue is if the proximal lead, if you are doing angioplasty and the restenosis rate is high. But this patient is on long-term medical follow-up, patient may be asymptomatic for long. So whether to do or not, there is an issue. So these sort of issues is discussed in the ischemia trial. That is the initial invasive or conservative strategy for the stable coronary disease. That conclusion is the beautiful study. They came in New England Journal. That is conclusion. Among patients with stable coronary disease and moderate to severe ischemia, we did not find evidence that initial invasive therapy as compared to the initial conservative therapy reduced the risk of ischemic cardiovascular events or death from any cause over median 3.2 years. So these sort of patients, there is no need of angioplasty, and she underwent angio study only, I said only medical management. So what did the ischemia trial show? The research question is, in stable patient with at least moderate ischemia on stress test, is there a benefit to adding cardiac catheterization and, if feasible, revascularization to optimal medical therapy? And uncertain if PC or CABG is superior to OMT, will revascularization decrease the risk of MI or death? So this trial, this is the eligibility criteria. They studied all over the world, including Kerala also. And they included patients with TMT positivity with a moderate age more than 21 years, and excluded certain patients like heart failure, ejection, ACS within 2 months, and previous angioplasty or bypass. And what they divided these patients into angiogram group, conventional angiogram, and CT angiogram. And they excluded all patients with left ventricular stenosis, and then found that the medical therapy almost equal to invasive arm, either PC or CABG. So this is the subset of patient we had to be should be clear in mind whether to give proper treatment, whether medical alone or angioplasty or bypass. So this need critical analysis of the patient's subset like high-risk group, low-risk group, location of the lesion, all are important. So why many of the trial like Barry trial or Courage or these sort of trial, why these people are telling about no need to do the angioplasty or bypass? Because there is a paradigm that suggests why randomized trial have not demonstrated a survival benefit for revascularization in stable heart disease. If you see, this is the right coronary artery, there is a mid part, there is a tight stenosis. Actually, this is a calcific stenosis. These patients never go into MI. So if you consider the arrows here, the upper arrow, this is a border lesion. Many of these patients, these sort of area, the vulnerable plaque may be there. So we have a tendency to do the angioplasty in a central part, very tight stenosis. Probably it's a stable plaque, it never ruptures, whereas border lesion may rupture. So we can't guarantee which of these patients go into MI or not. So this is the second case, the case 65 years and stable angina for the last patient with history, 65 years to the last 1 year. You can see that this is the left coronary artery, the ostial origin. That will be supplying more than 50% of the heart. And this is another angle. You can see that there is a tight stenosis. Suppose something happens, the patient will have massive myocardial infarction and patient will have heart failure and even death. So how will you approach this patient when compared to the previous case? So that case, there is AHA guidelines, the stable heart disease compared with the medical therapy. That is class 1. In patients with stable heart disease, multivessel disease, appropriate for CABG with a severe left ventricular dysfunction. The CABG recommend to improve the survival. PCA has some sort of also benefit, but this is not the left main case. So left main case, this multivessel case with LV ejection fraction low, this sort of patient might be benefited with the invasive arm. And with the left main also, patient may be benefit with either CABG mainly and PC some patients. So this is not the left main, or this is not the patient with the LV dysfunction. So this is the patient with the proximal lead. The location of the lesion is very near to the left anterior descending origin. So in that case, these 2B means may be helpful. So that means in patients with stable heart disease, normal LV function, as this case, the significant stenosis in the proximal lead, the usefulness of coronary revascularization to improve survival is uncertain. So here again there is uncertainty. So how can you guarantee this patient whether to do or not? Hostel location, suppose this is your father or your uncle, your relative, how to proceed? So another area, no benefit if the patient is having not involving proximal LAD. Definitely, if it is not involving the proximal LAD, osteoproximal, it is the mid location or distal location, no need to angioplasty at all. So that is no benefit doing angioplasty or bypass. So we'll come later how to approach these sort of osteolocation in the end. So in short, the chronic coronary disease or stable heart disease, there are 6 variants, like patient with suspected CAD with stable angina symptom and dyspnea. Second thing is new onset heart failure or LV dysfunction and stable suspected CAD. The third is less than 1 year after ACS or patient with recent PCI or CABG, or more than 1 year after initial diagnosis or revascularization, and patient with angina and suspected vasospastic microvascular disease. Then the last is asymptomatic subject with whom CAD is detected at screen. These are the 6 subgroup, the chronic stable angina. So we'll take the first, the patient with suspected CAD and stable anginal symptom or dyspnea. So why this is important? Because atherothrombosis is chronic disease and residual risk exists even patient is stable and feeling well, and clinical inertia can result in recurrent events. So it may be a silent disease, it can rupture at any time. So we have to track this patient, which is this patient going for future event. So that stable patient remain at risk for CV events. You can see that at 1 year with a established coronary disease, for example, previous patient, and that patient osteolocation, that patient 1 in 7 chance, 1 in 7 patients with established disease may have recurring event in near future. So even go up to almost 20% if there is polyvascular disease. So you should have some sort of risk score to identify high-risk CAD, but Iyengar sir previously demonstrated the high-risk group with AVS-CD risk score. So secondary prevention risk score including the male, the age, smoking, diabetes, just like any other situation. But heart failure is very, very important. Atrial fibrillation also important, and patient diabetes and age is an independent risk factor. If there is more than 3 risk factor, definitely there is high risk. And previous CABG case and also chronic kidney disease. Chronic kidney disease also an entity separately has to be mentioned because there is a trial for the chronic kidney disease also. Conservative arm is having more benefit when compared to invasive arm. So suspect CAD, the symptomatic patient, selective ischemia assessment, majority are OMT, optimal medical therapy. Significant symptoms, class 3, 4, definitely that patient has to go for the coronary angiogram. So coronary angiogram, mild to moderate symptom, normal or non-obstructive, like less than 70%, definitely the optimal medical therapy. Non-obstructive, definitely optimal medical therapy. So with high myocardial geopard index, that means location is in the proximal location and involving major segments of the heart. Definitely there is a role for prompt revascularization plus optimal medical therapy. So now we can go for the second group, that is patient with new onset heart failure or LV dysfunction suspected CAD. So this is the case, 55-year-old male, stable angina for 3 years and dyspnea exertion for 6 months and on conservative therapy, and ECG shows loss of R wave in right precord leads and echo short RW. We can see that this patient, definitely there is some sort of, you can see that this area is not moving at all. This is the location of the left anti-descending artery supplying that area. So these sort of patient, whether if you follow up these patients, definitely there will be event, either heart failure, sudden death within at least survival maybe 60% over 5 years, or this patient can have separate vascular event. So these sort of patients should be aggressively managed, either revascularization or viability test, all these things. You can see this is moving this area, but this area is not moving. So this stable angina and heart failure LV dysfunction, you can send for patient, the preserved thickness is there, definitely with the coronary, patient has to undergo the angiogram and you have to do the revascularization. If you are suspecting some sort of non-viable tissue, you have to go for the cardiac MRA better and other stress echoes. So the LV dysfunction with the stable angina medical management, there is a role for beta blockers, AC inhibitors or ARB or MRA, or ivabrad in selected cases. Amlodipine may be considered if the patient not tolerate the beta blocker, also considered safe, but this is a class 2B indication. So beta blocker, AC inhibitor, ARB and MRA is mandatory for the heart failure patient. So what is the role of myocardial revascularization in this case? The myocardial revascularization is either PC or CAB is recommended when angina persists despite the treatment with anti-anginal drugs. It's a class 1A recommendation. So there is a clarity for chronic stable angina with heart failure. You have to go for the aggressive revascularization policy rather than conservative optimal medical therapy. And third case is patient with stabilized symptom less than 1 year after ACS or patient with recent revascularization. This is a case, 6-year-old female diabetic underwent angiogram for ACS 6 months prior to evaluation and different center. And patient diagnosed as some L6 disease with minor LM plaque, and they did some procedure there. Detail was not there. This was the case that is 6 months prior to our evaluation. You can see that some sort of minor tapering here. And this is the circumflex artery. There is a disease here. You can see that. And this area is okay. Minor disease also. Mainly some disease this area. So after 6 months, the patient again had symptom and troponin elevation. Then angiogram showed the aggression in the atherosclerosis. You can see that there is some sort of cap, that is the ulcerated plaque. And this is also progressive, also here progress. So over 6 months, we are not sure what is it. So there is a previous ACS cases and stabilized for 6 months. These sort of patients may go for further issues. So this is the one subset what you are talking. So these sort of patient, what is happened, what inside happened, you can do what is happening inside. What is the procedure later? So they did something wrong in the procedure, we don't know. So this sort of imaging technology may help. So this is some intravascular imaging showing some, we will see whether calcium or any ulcerated plaque or hematoma. That is the method for the IVS part. So then next is the patient more than 1 year after initial diagnosis or revascularization. This is classically seen post-CABG case. For example, patient underwent bypass and for 1 year or 2 years and came with some sort of reset for 6 months duration of dyspnea exertion. This sort of patient never comes angina. They will come with a dyspnea exertion. So this patient has to undergo aggressive, risk stratification. So this patient had some Lima to LAD issues later and underwent the procedure. This is the Lima course. You can see some stitches here, and there is a curve like this. This is a left-handed descending artery. This is the Lima vessel. So last is the patient with angina suspected vasospastic microvascular disease. This is seen in usually the perimenopausal age group. And asymptomatic patient to whom CAD detected screening. Usually seen in, for example, patient is going for some procedures, for example, non-cardiac surgery, and found to that some sort of heart disease lesion in the coronary artery. For example, patient want to do some Whipple procedure in the abdomen. And ECG shows some changes. They did TMT saw positivity, then did an angiogram because anesthetists want to know about the angiogram. Angiogram, what the issues during the procedure. These sort of the subsets are there. So to do procedure or conservative, these sort of patient definitely conservative has more role than the invasive arm. So the revascularization to improve the survival in stable angina compared with medical therapy, there is no benefit in patient with normal LV function with 1 or 2 vessel CAD not involving proximal AD. The PCA or CABG is not recommended and to improve the survival. So you can see that medical therapy again in stable angina with multivessel disease appropriate for either CABG or PCA. The revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned urgent revascularization or cardiac death. In our case, the proximal AD, what you are showing the posterior location has come this picture because we don't want to do we want to avoid the spontaneous MI or unplanned urgent PCA. So these sort of some benefit may occur if you are a good interventionalist. You can always do that osteolocation. So in refractory angina cases, despite medical therapy, with significant CAD amenable to revascularization is recommended to improve the symptom. So there is an improvement in the symptom, not the mortality reduction. In patient with angina, but not anatomically physiological criteria for PCA or CABG, neither CABG PCA should be performed, and there is role of aggressive medical therapy and including lipid lowering and anti-anginal drugs. So the refractory angina conservative non-revascularization strategy, there are just like aggressive angioplasty, there is an aggressive conservative arm like there is a ECP is controversial, but in brown vault also may benefit. We don't know about that, but it has some anginal relief. A reducer device for the coronary sinus constriction may be considered to ameliorate symptoms of debilitating angina, and also some sort of spinal cord stimulation. So these are all experimental basis, but still there is useful in selected cases. Those who that CABG or PC is not an option, you can always go for this, the last option. So that to conclude, take home message, the stable ischemic heart disease, optimal medical therapy works very well. Revascularization is still useful, but better at angina relief. Medical therapy doesn't apply to heart failure with reduced ejection fraction, especially ejection fraction less than 40%, left main stenosis, previous myocardial infarction or previous ACS case or previous PCI case and unacceptable angina, and I have to include with the previous history of stroke and other diseases. An anatomical study including CT angiogram or cath coronary angiogram to confirm CAD and rule out left main disease may be better strategy than stress testing in high risk stable ischemic heart disease. And thank you for patient attention. Thank you.
Thank you, Dr. Ashraf, for that captivating talk with all those angiogrammic pictures and echo pictures. So after this ischemia trial, the debate is again reignited regarding whether should we revascularize in a stable patient or not. So in medical science, what we have seen is many of the procedures, either surgical or medical procedures, what we do, not all they give a mortality benefit. There are many procedures which we do, even surgical procedures, many of them they are for symptom relief, improve the quality of life, or to reduce the pill burden. So targeting only mortality benefit or not, it should be the criteria to consider a patient for revascularization. And second question is, some of the patients who we have seen, a triple vessel disease patient, where we have done angiogram for stable symptoms, because of the collaterals, he may not have much symptoms. When we do an angiogram, he has a very bad triple vessel disease. Eventually, you put him on medical therapy. After many years, we see that his cardiac function has come down. Overall, there is significant LV dysfunction. In hindsight, would it be suitable for, in such patient, is it suitable to direct them to revascularization at an earlier period of time rather than waiting till he has LV dysfunction, then have a criteria? Is it a right thing to do?
Fantastic question. First question, mortality reduction, morbidity. Definitely that point is well taken, because if you do the procedure, there is a need for the repeat revascularization. That is one issue. And definitely there is a anginal relief. And second question about the triple vessel disease with the collateralization. That was the my third one. That was patient, the location in the proximal part. Definitely there is a, with the proximal LAD and triple vessel disease, there is a role for revascularization. That is the class 2B as per the American guideline, also Europeans. And if the location distally and the triple vessel is well collateral, definitely the medical management has a very good role. And what I have seen, the majority of these patients are going for alternate treatment. Actually, the benefit is because the natural history is like that only. Even if you give statin and beta blocker, definitely this patient will do better than the alternative medicine. So actually, the stable angina as a cardiology and physician, we have to classify these sort of patients. We will be the biggest, the conservative people in the world. Majority of cardiologists are in difference of opinion about this area, this 20% vague area, as you pointed out about the well collateralized case. Well collateralized non-proximal location, many of these patients do better. And how we, as suppose you are almost, myself, all these seniors are more than 20-25 years experience. We are surprised to certain patients, they are coming, they are lost follow-up for 5-10 years, and staying. If you do the angiogram looks same only. So location is more important rather than the, number of the vessels. Number of angio report may show in the triple vessel disease, maybe the branches and all. And if it is location, the ostial or osteoproximal, definitely the event rate is more. That's why the American guidelines say that proximal LAD location with a triple disease, multi-vessel disease, more than 2 vessel disease, class 2A recommendation or class 2B in case. And heart failure, you have to track this patient. The moment there is LV dysfunction, definitely the revascularization. Out of revascularization, CABG versus PCI, CABG has an edge in the heart failure group and complete revascularization. Yes.
Role of the non-invasive methods in evaluation of stable angina. Secondly, when does OMT stop and PCI starts?
Never, first question, the CT angio is better, sir. Low risk group, definitely CT angio is better. CT angio equally, because even ischemia trial, TMT, mild positive, all these patients underwent the low risk group under CT angio and cath also separately in different subgroups. Second, OMT and invasive arm or wife and husband, definitely they have to be, at least just like friends, you can't avoid the OMT. PCA can't sustain without OMT. In case of, stable angina.
How long do we wait?
I have to continue, sir.
Yeah, one last
That's why
question.
in that area, guidelines and all, the medical therapy first, then only lastly they put the PCA and all this.
One question. In patients with stable angina, do we need to do CAG at all?
TMT.
No, CAG, angiogram.
In the stable, that's the last, that was asymptomatic patient. And the TMT is, my majority of seniors OPD, you will see some advice of angiogram. And heavy doctor, they will say no need, because my policy is the TMT is meds is more than 9 meds or 10 meds. I never advise angiogram, because we had a data, the personal data, and also different 25 years retrospective analysis of one data from Chitra during my PG days. That was showing more than 9.3 meds, more than 9.3, the event rate is very less. So the patient is asymptomatic, TMT more than, this case, first case, TMT more than 10 meds at least. Then you can always avoid angiogram. And the ischemia trial, they made a 7.2, so even lower. So I think 10 meds and mild positivity, no issue at all, no need of angiogram. If at all, if you want, then patient is having doubtful and all, then, and especially high risk. For example, strong family history, they will come. The patient is from Gulf and the patient already, one of the sibling died in recent months. They did an TMT, and the TMT technician and the physician or cardiologist suggests mild borderline positive. There is nothing like borderline, mild positive and all. And patient is asymptomatic, meds is 10. These sort of low risk, low threshold patient with background of family history, definitely you can send for CT angio. And to me, personally, I used to send CT angiograph for low risk group and also females. Because females, especially thin built and low, small hand and all, rather than doing the angiogram, spasm, all this issue, you can do the CT angio.
Are there any questions from the audience? Any clarifications or points for discussion? Yes, Dr. Kishore.
Sometimes maybe after primary angioplasty and even coronary, stable coronary artery disease, we have a lot of medical management. And there are some reports that colchicine, low value of colchicine is very helpful in preventing recurrent cardiovascular events, either after primary angioplasty or in a stable coronary artery disease. So what's your comment on colchicine low dose? Because I've not seen any prescription of colchicine in physicians or cardiologists. So what is your recommendation?
Yeah, there is a trial called, I forgot the trial, something like, is still there in the mind. The colchicine is also useful in the chronic stable angina. And like colchicine in cardiology has a very good role. For example, if you give, apart from our gout, especially patients heart failure and chronic kidney disease or mild renal, we are giving diuretic, patient have definitely one gout incident will be there. The colchicine role is there. Second thing is the pericarditis, idiopathic pericarditis, wonderful experience with the colchicine. And post whatever pericarditis, sequelae you can give colchicine. Third is ISR, restenosis. And now the recent guidelines, not guidelines, the lot of trials come with the colchicine stable coronary. You are right, sir.
Thank you, sir. Now I would like to call Dr. Arul Kamath, sir, Professor, Department of Cardiology, to please hand a token of our appreciation to our honorable speaker, Dr. S.M. Ashraf. Now, I would like to invite the moderator, Dr. Pradeep Pereira, and I would like to now call Dr. Rajesh Bhatt, Consultant Cardiologist, KMC Mangalore, to please hand a token of our appreciation. Now, I would like to call the Honorable Chairpersons, Dr. Chakrapani M., Professor of Medicine, KMC Mangalore, Dr. Christopher Pais, Professor of Medicine, KMC Mangalore, and Dr. Jayaprakash Alva, Professor of Medicine and former Dean, Father Muller's Hospital, Mangalore. Thank you, sir.
The topic for the next session is evaluation and workup in recently diagnosed hypertension patients. So I would like to invite Dr. Padma Kumar to the dais as a speaker for this session. Dr. Padma Kumar is a professor and head of Department of Cardiology at KMC Hospital Manipal. He's a proud alumnus of Government Medical College Trivandrum, having done his MBBS, MD and DNB from there. He did his DM from Sri Chitra Tirunal Institute of Medical Sciences Trivandrum. He is a life member of various prestigious physician and cardiology associations. He has more than 10 publications to his name in recognized national and international journals. He has been performing state-of-the-art cardiac interventions and providing excellent care to his patients. He is passionate about teaching, having been a teacher for more than 20 years now, mentoring students from bedside to guiding them in their thesis. Thank you, sir. Further, I would like to invite Dr. Basavaraj Utagi as a moderator for this session. Dr. Basavaraj is a consultant cardiologist at KS Hegde Hospital, Mangalore. Now I would like to invite the honorable chairpersons for this session. Dr. Sudhindra Rao. He's a professor and head of Department of Medicine at KS Hegde Hospital Medical College. Dr. Sunil Kumar Suratkal. He's a professor and unit chief of medicine at Srinivas Medical College, Mukka. And Dr. Haroon, consultant physician, KMC Hospital, Mangalore. Thank you, sir.
Good morning, everyone. I thank organizers for this opportunity. And most of us are seeing hypertensive patients, and most of our patients want the number only to be lowered. And we are also many a time in that bargain, we lose our clinical acumen to our patients. And now we have sir who is once again here to reinforce. It is not just the number. There are many more things to be done in a hypertensive patient. Over to sir.
Thank you. Good morning, senior faculty, colleagues, friends. At the onset, let me thank Dr. Narasimha Pai, Dr. Padmanabh Kamath and their team for inviting me. Dr. Pai wanted me to talk on some topic related to hypertension. When Dr. Pai comes to Manipal, we give him only 10 minutes, so I thought I will talk only on evaluation of hypertension, but he has been magnanimous to give me 25 minutes, so I expanded my topic to evaluation and management of a patient with a newly diagnosed hypertension. I have structured my talk in such a way that I am sitting as a doctor in a clinic, answering the dozen queries of my newly diagnosed hypertensive. Hope it is of interest to you. It should be of interest to you because hypertension is the most important cardiovascular, most prevalent cardiovascular disorder in the world. And 1 in 3 sitting in this hall is either a hypertensive or is destined to be a hypertensive. So you can use this talk. Let it be a checklist if you are doing things right. Hypertension, it's a very multifactorial disease. There is no one way you can solve. There are things which are under our control, things which are not under our control. Your genetics, you cannot change. Your lifestyle, definitely you can change, that you only can change. Then your environment, let us take now noise pollution, air pollution, ambient temperature. It's not in your hand, it is for the community to change, but you can be a part of that community and initiate the change. What do drugs do? They act on so much of molecular mechanisms, pathogenesis, different factors in hypertension, and they are the cornerstay of stay after lifestyle. Let us start with the clinical scenario. We have a 45-year-old male diabetic. He comes to you for an executive health checkup. You record a BP 150 by 100. You record after 5 minutes 150 by 100. He promptly refuses. I have no hypertension. The BP is high because I came climbing stairs. I did not use the lift. And you made me wait for 2 hours in your clinic, so I lost my temper. That is why the BP is high. My BP at home is 120 by 80. Is he hypertensive? Yes, that is what the definition say. If you have a repeated office systolic BP more than 140 or diastolic BP more than 90, you have taken 3 measurements and you neglect the first one, take the next 2, average of the 2. If you have more than 140 systolic or equal to 140 systolic or diastolic 90 or above, you are hypertensive. If you have 2 visits within 4 weeks, that is advisable rather than a single visit. You can, if he is refusing, you can always call him within 4 weeks for one more visit and confirm. But 1 visit is enough. If his recorded value is grade 3 hypertension, that is blood pressure more than 180 by 110, he have already made out evidence of hypertensive mediated organ damage like LVH or CKD. If he is a diabetic, single value is enough. If he is above 65, again white coat is less, so maybe you can label him hypertension straight away. Or if he is already a treated hypertension, somebody has already told him hypertension, you can go by single value. What about ambulatory BP, home BP? Okay, good. They are good to confirm, but they are not mandatory for definition. What is so sanctum about this 140 by 90? That is because all randomized control trials have shown that if you intervene a hypertensive versus no intervention, above this value of 140 by 90, you definitely have benefit more than harm with your drugs. So what are the common queries that a hypertensive patient will ask you? How severe is my hypertension? What is my risk of having heart disease? What all tests should I do? Should I see a hypertension specialist? Is my hypertension curable? Is it genetic? Should I change my lifestyle? How should I take drugs? When should I take drug? What drug? What should my target? Let us try to run through each of this. So how severe is my hypertension? That's the first question that all of you know. There are so many grades in the current European Society of Hypertension guidelines. But anybody 140 to 160 systolic, 90 to 99 is stage grade 1. Grade 2 is 160 to 180 and 100 to 110 and more than 180 or more than 110. Either of this, they will become grade 3. Then there is another important concept of isolated systolic hypertension, especially in elderly, where you have only systolic blood pressure going above 140, diastolic remains normal, and isolated diastolic, where systolic is below 140, diastolic goes above normal. That is more common in youngsters. So not only grade, stage of hypertension also is coming up as equally important factor. What is stage? Somebody who have hypertension alone, no hypertensive mediated organ damage, no established cardiovascular disease. He is the one whom you can take more liberty in delaying drugs. You can stress on lifestyle. But moment he crosses stage 1 and goes to stage 2, that he has either hypertensive mediated organ damage or stage 3 CKD, that means creatinine clearance less than 60, or if he is a diabetic, there is no second thought, you have to put him on drugs. And stage 3 is hypertension with established CVD, like heart failure, CAD, CKD with creatinine clearance less than 30, he is stage 3, he has the worst prognosis. So what defines hypertensive mediated organ damage? Now we have definite criteria. You have left ventricular hypertrophy, more so if you have it even on ECG. Echo is sensitive, but echo is more specific. ECG may miss many LVH, but if you have an LVH in ECG, it definitely means hypertensive mediated organ damage. Then albuminuria in the 30 to 300 range is considered stage 2. If it is more than 300 per 24 hours, it is stage 3. eGFR 30 to 59 is stage 2 and less than 30 is stage 3. If you have evidence of peripheral vascular damage, if you have evidence of retinopathy, and some studies are now using measures of arterial stiffness also as criteria of organ damage. The rough way you can detect at the bedside is if you have a pulse pressure more than 60, especially in an elderly person, it definitely means he has stiff arteries. And stage 3, I said, if you have CVA, if you have any other, somebody you do a carotid Doppler and you show 70% stenosis, he straight away goes to stage 3, atrial fibrillation, heart failure, peripheral vascular disease, symptomatic, and then advanced renal disease. Second question he's going to ask you is, what is my risk of having cardiovascular disease when I am having hypertension? That is the first thing that comes to their mind. There are conventional risk factors like age, sex, diabetes, smoking that everybody is aware of. There are even scoring systems. But you should know that there are so many contributing risk factors of having CVD if you are hypertensive. Like if you have an early onset hypertension, malignant hypertension, resistant hypertension, you have a family history of CAD, you have a resting tachycardia, upcoming risk factor, low birth weight, you have no control over that, obesity, sedentary, hyperuricemia, elevated deficiency of elevated lipoprotein A, bad obstructive history, premature menopause, air or noise pollution, all are accepted risk factors of CV risk now. Comorbidities matter. If you have obstructive sleep apnea, you have higher chance of having CVD with hypertension. COPD, gout, chronic inflammatory disease, very important. So many rheumatoid arthritis patients, you will see on their follow-up, they are developing CAD. Another important new risk factor, non-alcoholic steatohepatitis. You see somebody with fatty liver, some elevated liver enzyme, especially if they are on statins, don't neglect, investigate for NASH. Migraine, depression, erectile dysfunction, important risk factor in male to develop CAD. So not only the grade of hypertension matters, the stage of hypertension also matters. So if you have very much elevated blood pressure, and if you have more evidence of target organ damage, your risk increases. So next question they will usually confront with you is, sir, you check your instrument. Blood pressure is high only in your office. It is normal in all other machines. Of course, the true blood pressure you will know only by a sedated patient with intra-arterial blood pressure. But whatever be the blood pressure instrument that you use, whether it's mercury, aneroid, hybrid with your LED display, everything is reliable. That is what at least the guidelines say, except probably in pregnancy where you better measure the blood pressure yourself rather than using instruments, because where that muffling in stage 4 and the stage 5, that difference is too much. So except in pregnancy, any instrument is accepted. Even calibrated automated devices, if you are using, you ensure that you calibrate. And remember that in extremes of BP or automated instruments may be erroneous. So if you don't use it in your emergency, where it may underestimate your BP. A patient comes in shock, it may show a higher BP. Different types of blood pressure measurements. What is the importance of that? Generally, we all go by office blood pressure. But remember in elderly, when you see a patient for the first time, always measure in both arms. In elderly, remember to take at 1 minute and 3 minutes. A good number of them will be having orthostatic hypotension and your treatment may worsen them. Unattended office BP is supposed to be the best now in many trials. No medical staff will be present. Patient will be made to sit. The cuff will be tied and some recording patient himself can make, which will be recorded. That is what used in SPRINT trial. Home BP recording is a good idea, especially in treated patients. Patients under treatment, they can monitor their BP. Encourage them to take just before the drug in the morning and in different parts of the day. The cutoff, remember that when you are taking blood pressure values at office and at home, in home BP, the cutoff is 135 by 85, not 140 by 90. Ambulatory BP, every 20 minutes it will measure. It's useful in white coat hypertension, masked hypertension, resistant hypertension, nocturnal hypertension. So it has its own role. Again, the cutoff values are different. Awake values, the cutoff is 135/85. In sleep, it is 120 by 70. And 24-hour value is 130/80. It's a good idea sometimes, especially the patient is on treadmill, to note his blood pressure on exercise. If the peak systolic blood pressure can go up to 200 and in males and 180 in females in exercise, if it exceeds more than 220 in a male and then more than 200 in females, it is not a good sign. He is most likely to be hypertensive. He is likely to have exercise-induced hypertension. And if blood pressure falls on exercise, it's a bad sign. Central BP is coming up, more used in studies because it closely correlates with your organ damage, but it's still used only in research settings. Opportunistic BP measurements have been encouraged all over the world. Anybody above 18 years should have his blood pressure screened. If you are above 40, obese, or in high normal BP, you should screen yearly. In fact, Western countries are encouraging unofficial measurements, opportunistic measurements they call. When they go to the pharmacist, they go to the barber shop. But in our country, barber shop is a more costlier place than a doctor's clinic. So maybe that is not a good option. In females, you should have special attention to people who are postmenopausal and who had hypertension during pregnancy. Lot of phenotypes are there for hypertension, like a person having sustained hypertension, patient has white coat hypertension only in office, masked hypertension is blood pressure is normal at office, high outside, isolated systolic hypertension in the young, elderly, isolated diastolic hypertension, nighttime hypertension, orthostatic hypertension, then certain infections, neurological disorders, you can have baroreflex failure and autonomic failure and labile hypertension. They are beyond the scope of my talk. Probably Pai will call me next year. I will talk about some of them. So the next question they will ask is, what all tests should we do when you are detected to be hypertensive? Hemoglobin, PCV, all these things we all do. So what we usually miss out, it's a good idea if you have a young CED patient to look for lipoprotein small a, though the treatment options are limited. Serum creatinine, ideally cystatin C, because that is more sensitive. Blood calcium. Then always we forget about the kidneys, especially cardiologists. It's a good idea in a newly detected hypertensive to look for albuminuria and never forget the ECG. And if you are still doing clinical exam after COVID, H1N1, conjunctivitis, you don't bother touching patients, you can do clinical examination. You do a focused clinical examination, feel all his pulses, fundoscopy if you can, auscultate the carotids for a bruit. We all never forget the heart, but may forget the neck. But remember that severe hypertension by itself can produce bruit. It need not always be carotid disease. Feel his lower limb pulses. He detect peripheral vascular disease early. And sometimes you may get signs of secondary hypertension like a palpable kidney or some skin markers. Advanced tests, they are mainly meant for screening for hypertension-mediated target organ damage, which is a mandatory indication for, which mandates treatment of hypertension with drugs. So moment you look you have found out hypertension-mediated organ damage, you have to put them on drugs. So that is the importance of detection. So if you have an echo, you should look for LVH, coarctation, aortic sizes. LA size is important because it may predict atrial fibrillation in future. LV mass is the most important predictor of mortality and morbidity in a hypertensive. Carotid ultrasound, you can look for intermedial thickness and you can look for plaques. Carotid plaque is a better predictor than increased intermedial thickness in a hypertensive. And of course, you can look for measures of arterial stiffness. Coronary calcium score, which you are using left and right, especially in youngsters who are having borderline lipids, to encourage them to take statins. Everybody is most people are allergic to statin even with an LDL of 200. So especially in that 160 to 190 range of LDL, we use coronary artery calcium as a test to convince patients. If they have calcific deposits, it is more easy to convince them to put on statins. Abdominal ultrasound in elderly smoker, never forget, you may pick up an aneurysm. Then in resistant hypertension, look for ultrasound Doppler. And if you don't have renal artery stenosis, you look at what is the renal resistance index. If the index is high, patient may be having intrinsic renal disease. Then the hypertension is an upcoming risk factor for people who develop dementia. So people say that if you treat hypertension early and you treat hypertension elderly, you may delay the issues of demanding brain diseases like Alzheimer's. So why assess for hypertension-mediated organ damage? Higher measures, higher cardiovascular risk, and you can follow them up. If you show improvement, maybe a patient is drug compliant. If it is worsening, maybe is drug non-compliant, or therapy may be inadequate. So next question, should I see a hypertension specialist? Not everybody should need to see a hypertension specialist unless you have secondary hypertension suspected, or young age hypertension, malignant hypertension, treatment-resistant hypertension. So only the certain specific hypertension need be referred to a specialist. Another question they may ask you is, what is the reason for hypertension? We know that only a secondary cause can be found out only in 10%, but there are certain situations where we should definitely screen for them. Again, almost the same thing, less than 40 years, sudden onset hypertension in an individual with a previously documented normotension, somebody who is well-controlled hypertension suddenly losing blood pressure control, hypertensive emergencies. Every stage 3 hypertension, better you look for a secondary cause. Then there may be some clues in your examination like a renal artery bruit or certain biochemical tests which point. Common secondary causes. In youngsters, it is usually coarctation. And if you suspect coarctation and you don't see coarctation in echo, you always remember a condition called mid-aortic syndrome. Maybe it is very common in our country. At least we see 1 or 2 cases at least in a year. And in elderly, usual cause is a renovascular hypertension. If you have an elderly secondary hypertension, the others are all in the mid-age. Renovascular disease, usually they present as resistant hypertension, flash pulmonary edema, rapidly declining renal function. The first choice test is definitely renal artery Doppler, but if you are suspecting, don't stop with Doppler, you go for an imaging like CT, because the yield may be higher. And it's a curable hypertension. Like this boy, who is a young male, 20-year-old male, he came to us with recurrent pulmonary edema and hypertension. He has bilaterally absent renal artery. You can see we could hook the renal arteries only because we knew which vertebral level it is by CT. And it will be gratifying that once you stent these renal arteries, you may be able to stop most of these drugs. This fellow was on 5 drugs, now he's only on beta blocker. Sleep apnea, another common condition cause for hypertension, especially in obese. If they have daytime somnolence, they are complaining of excessive fatigue, never forget to do a sleep study. Primary aldosteronism, not very common, but remember that it's to screen for it, especially if you see unprovoked hypokalemia. What we do is correct the potassium first. Once potassium is corrected, you do an aldosterone-renin ratio. If it is abnormal, send to the endocrinologist. Pheochromocytoma, again, urine metanephrine better than urine VMA to screen. Because of lack of time, I won't go into details. Cushing syndrome, you know better than us. In a obese hypertensive, never forget, especially if they're diabetic, screen for Cushing syndrome. Query 6, is my hypertension genetic? Only few are genetic. And they will have some dysmorphic features like brachydactyly. Pheochromocytoma, sometimes they can have a genetic this thing. But the main clue for genetic cause of hypertension is this, the list of genetic cause of hypertension. You see, most of them will have some defects in your acid-base balance or potassium balance. So if they have a hypokalemia or hyperkalemia, metabolic alkalosis, metabolic acidosis, that is the situation where you can think of genetic causes and go to the books and see which syndrome it matches. Next query, how should I change my lifestyle? Weight reduction definitely, but caution in elderly, because if they start reducing their weight, their functional capacity may decrease because of a factor called sarcopenia, because they lose their muscle mass. So don't stress too much on weight reduction in elderly. Reduce the salt intake. Again, caution in elderly, especially if they're on thiazide diuretics, they may come to with severe hyponatremia. Mostly advise them to avoid processed foods, and added salt should be avoided. Now, there is a lot of stress in current guidelines on increasing dietary potassium in the form of fruits, vegetables, nuts, etc. Again, caution if the patient is on RAS inhibitors, especially if they're diabetic. Sometimes it may lead to hyperkalemia. Moderate intensity aerobic exercise. Moderation alcohol. Remember, hypertension plus alcohol is a good recipe to have intracranial hemorrhage. No smoking. DASH diet, Mediterranean diet, all you can read in books. Query 7, why I should take drugs? We can tell that there are so many trials in the world, randomized trials, which have been done till the age of 90 years, and as low a blood pressure reduction as 7 millimeter has been shown to reduce cardiovascular risk. So you treat hypertension, the main protection is from stroke, next protection is from heart failure, and third, coronary events. And you may trouble less your relatives when you are old age and demented. And benefits are more if you are, irrespective of the blood pressure level, if you have more cardiovascular risk. So if you have high CV risk, you better treat your hypertension. Can you manage without drugs? That's a question that they ask. Definitely not if their blood pressure is 150, more than 150 by 95, you should put on drug. In that 140 to 150, 90 to 95 guidelines say that if the patient has no target organ damage, no CVD risk, then probably you can try diet, but keep them on close follow-up. This applies even to elderly above 80 years. Some people will keep 160 as the cutoff in elderly, more than 80 to start therapy, but 140 to 160 also we have data now. What if systolic BP more than 140 and diastolic less than 80? Common scenario in elderly. Again, we have trial data. HOPE 3 step trials all showed benefit. HIVET trial showed benefit even above 80 years in this group. So isolated systolic hypertension needs treatment, but always look for orthostatic hypotension in this group. And if a patient is well controlled on drugs, just because he crosses 80, don't go on try to reduce the drugs because it can produce a rebound increase in events. We have data on that too now. Query 9, what should my treatment target? As I said, less than 140 by 90. If patient is tolerating drugs well, 130 by 80 is the best target. There is no extra advantage of targeting less than 120 by 70 because the evidence have been inconsistent. And in people with CAD, low diastolic blood pressure can decrease your coronary perfusion pressure, especially in people with CTO and collateralized circulation. A low diastolic blood pressure can theoretically worsen ischemia. Though there is difference between office BP, home BP, ambulatory BP, any measurement is acceptable as a measure of hypertension control. And try to achieve your target as fast as possible. Don't wait for years to get a hypertension control to a target. Query 10, what drug should I take? The commonest drug to start with now is a single pill combination of 2 drugs. So you have 5 drugs to choose from: AC inhibitors, ARB, calcium channel blockers, thiazide, like diuretics. Now beta blockers have also been added off. They have made a comeback as the 5th drug in the European guidelines. So any of these 5 you can use, but commonly we we combine as first choice a RAS inhibitor with a calcium channel blocker or a RAS inhibitor with thiazide. But it is better always to start with a combination of 2 drugs. Quad pill is a concept coming up, quarter dose of 4 drugs so that you don't get adverse effect of any drugs. Again, we have to wait for more data. Polypill, a combination of hypertensive drugs, statin and aspirin in people with hypertension with elevated CAD can be used if the patient doesn't want to take many drugs. When should I take my drugs? They may ask you. 24-hour control is important. They can take any time they want, but time study showed that compliance is more if you take in the morning, but efficacy is equal. But if the patient has nocturnal hypertension, it may be better to take at night, but patient can make his choice. Can any device cure my blood pressure? That's my last query that I'm addressing to. Studies have come up in renal denervation. It has made a comeback to our country. It is recommended in people with uncontrolled blood pressure. If blood pressure drugs not tolerated, provided GFR is more than 40. But again, the problem is the cost is 7 to 8 lakhs. So I don't know how many people will be willing to spend for that. Other devices coming up are certain devices which are meant to stimulate your carotid baroreceptors. People who do carotid stenting know that once you put a carotid stent, the patient's blood pressure falls rapidly. That is because the baroreceptors of the carotids get stimulated. So in resistant hypertension, that is made use of, and you constantly stimulate the carotids by putting a self-expanding nitinol stent, or you put a pacemaker-like device. That is, studies are coming up. The initial trials are promising. There was another treatment tried called iliac arteriovenous fistula creation to treat resistant hypertension, but that is going down because of problems of venous stenosis and ipsilateral venous edema. So I think time is up here, set. Thanks. But it's a must-read document. All of you should try to read it. It's a 50-page document, 2023 European Society of Heart Disease Guidelines. It covers most of the what you want to know about hypertension. Thank you.
Thank you, sir, for such an enlightening talk. I think you have covered most of the clinical scenarios that we encounter in our practice. It's not often that we encounter now patients with hypertension in young, sir. So especially in patients who are in stage 1 and stage 2 without any organ damage, how aggressive should be in workup for secondary causes? Should we go for endocrine workup in all these patients? So how to go about in such a subset of patients, sir?
You're saying less than 40?
Yes, sir, less than 40, especially in the 30s.
Yeah, I feel we should not screen everybody for pheochromocytoma or everybody for hyperaldosteronism in this thing, unless you get certain specific clues, like you have a potassium abnormality or an ECG showing U wave, or the patient has labile hypertension. So a good physical examination, and maybe at most I may restrict myself to an ultrasound abdomen with renal artery Doppler. Of course, I look for coarctation, but the moment I'll echo for everybody, because the moment I see LVH, then I may go for more aggressive screening.
the clinic reading is high and home reading is less. Whether you have to, any practical knowledge, sir, about that, practical guidelines.
I did not get your question.
If the clinic reading is above 150, 190, and then we say that they're hypertensive, they say my home reading is around 128. What do you do then?
Good question. What you should probably do is if they are not agreeing, you call them after a week and then again check. And if still your reading is high and he is adamant, you connect him to an ambulatory blood pressure monitor and show him the 24-hour graphic recording where you are not involved in the measurement at all to convince him.
Sir, how to proceed with evaluation and management of patients having isolated diastolic hypertension?
Yeah, isolated diastolic hypertension, it's mainly seen in youngsters. It doesn't need any separate evaluation and management as long as it is not fitting into the resistant hypertension criteria or secondary hypertension clues are there. Mainly in elderly, they tend to have isolated systolic hypertension, and youngsters to start with, like a 40-year-old man, or when they develop essential hypertension, they tend to have isolated diastolic hypertension 10 to more. It per se that these guidelines, I went through these guidelines also, they don't recommend any separate line of evaluation for them.
Thank you, sir. Thank you for the wonderful talk. I would now like to invite Dr. Sukripani M., Senior Professor Medicine, KMC Mangalore, to hand a token of appreciation to the speaker, Dr. Padma Kumar. Now I would like to invite Dr. Kishore, Consultant Physician, Kanangad, to please hand a token of appreciation to the fellow moderators, Dr. Basavaraj Utagi, Associate Cardiologist, Case Agri, Mangalore. And to the Honorable Chairpersons, Dr. Sudhinder Rao, Professor and HOD Medicine, Mangalore. I would like to invite Dr. Kishore to please
This is the pointer. RHT KMC, right?
One by one.
Slide changer.
Dr. Sunil Kumar and Dr. Harun H. Dr. Harun H.
Second talk ಅದು ಅಂದರೆ ಇಲ್ಲಿ ಟೈಮರ್ ಸ್ಟಾರ್ಟ್ ಆದಮೇಲೆ ಅದು ಇಲ್ಲಿ ಪಾಯಿಂಟರ್ ಇಲ್ಲಿ ತರಬೇಕು ನೆಕ್ಸ್ಟ್ ಮಾಡಲಿಕ್ಕೆ ಹಾಗೆ.
Okay, okay.
Thank you, sir. I would now like to invite the speaker of the next session, Dr. Prabhavati, to the dais to speak about the topic. The topic of the next session is Rheumatic Heart Disease in India, Current Scenario. Dr. Prabhavati is a professor in the Department of Cardiology, Jayadeva Hospital, Bangalore. Dr. Prabhavati is a proud alumni of Bangalore Medical College, where she did both her undergraduate and postgraduate degrees and has completed her cardiology training from the prestigious Sri Jayadeva Institute of Cardiology. Dr. Prabhavati is also the recipient of multiple awards for her work. To name a few, Dr. B.C. Roy Award from IMA Bangalore, as well in both international and national index journals. Thank you, ma'am. Now, I would like to invite the moderator of the session, Dr. Padmanabha Kamath, to kindly take a seat. Dr. Padmanabha Kamath is Professor and Unit Chief, Department of Cardiology, KMC Mangalore. Thank you, sir. Now, I would like to invite the honorable chairpersons of the session to have a seat, please. Dr. Murlidhar Yadiyal, Professor and Unit Chief, Department of Medicine, KMC Mangalore. Dr. Harish Rao, Department of Medicine, KMC Mangalore. Dr. Satwik Jain, Senior Physician, SDM Hospital, Ujire. Thank you, sir.
ಇಲ್ಲ ಅದು ಅಡ್ಡ ಬರುತ್ತೆ ಅಲ್ಲ ಹೈಟ್ ಓಕೆ ಕಾಣಲ್ಲ ಅಂತ
ಅಲ್ಲಲ್ಲ ಅವ್ರಿಗೆ ಅಂದರೆ
ಕಾಣಲ್ಲ
ಇಲ್ಲಿಲ್ಲ ಇದು
ಹಾಂ Start. Good morning, everybody. At the outset, I would like to thank Dr. Hatim and his team for inviting me for this beautiful program. And after the 3 talks on coronary artery disease, lipids, and hypertension, I'll be talking on rheumatic heart disease in India. What is the current scenario? As all of you know, rheumatic fever and rheumatic heart disease sore throat, but in some populations like Australian aborigines, it can occur following skin infection also. Most of the pharyngeal infections are not gas infections, they are viral. Only 10 to 30% result from streptococcal sore throat. So here again, up to 2/3 can be asymptomatic or mildly symptomatic. All these are again important for primary prophylaxis. The environment, the poverty and overcrowding contributes to the transmission of the disease, that is the streptococcal sore throat, and poor access to health care and the lack of awareness results in rapid disease progression. Pathogenesis is exact mechanism is unclear. We all know that it's an autoimmune response due to molecular mimicry resulting in cross-reaction with human antibodies. So what is the epidemiology and global burden? Here I would like to there are 4 epidemiological patterns over the 150 years. A, the pre-antibiotic era. There is a significant fall in the incidence of acute rheumatic fever in the industrialized countries because of the improved socioeconomic status. B, there is a persistent high incidence like in South Asia and Africa. And the third pattern is in the post-antibiotic era, the rheumatic fever incidence dropped because of institution of comprehensive program for primary and secondary prevention, as seen in Cuba and Costa Rica. But the fourth one, there is a fall. Again, there is a rise. This happened in formerly Soviet Republic countries of Central Asia. So the worldwide prevalence is still, there is the highest prevalence and disability of mortality in South Asia and Sub-Saharan Africa and Pacific Islands, whereas the lowest prevalence is seen in Europe and North America. So how it improved in developed nations? You all know it's because of the improved socioeconomic status and the improved access to the medical care. Even in high-income countries, RHD continues to be a major problem in indigenous populations. Like in Australian Aborigines and in New Zealand, there are epidemics of rheumatic fever. And also in immigrants from high-risk settings. So the burden is not uniform. It is variable among the countries, within the states, and within the regions, which depends mainly on the socioeconomic status and the state of the health systems. Why there is persistent burden of rheumatic fever and RHD in developing countries? Apart from poor standards of living conditions and overcrowding, there is lack of strong population-based surveillance system for the pharyngitis, rheumatic fever, and RHD. And there is lack of effective implementation of the primary and secondary preventive measures and a weak health system. Moving on to burden in India. Is there a decline of RHD in India? It's widely perceived that with economic transformation, there is an epidemic of lifestyle disease like coronary artery disease, which we are discussing all this time, and the prevalence of RHD is declining. Is it true? It's partly true. Systematic review of data on epidemiological studies conducted in different points of time using clinical screening with echo confirmation across the country suggests that there is a declining trend of rheumatic fever and rheumatic heart disease, especially after 2000. So for example, RHD accounted for 30 to 50% of the total hospital admissions in 1980s. But in recent survey across the various tertiary care hospitals showed that RHD admissions have declined to 5 to 26%. School surveys are an important epidemiological method of detecting the disease. The reported prevalence was around 1.8 to 11 per thousand, but now in 1990s it has declined to 1 to 3.9 per thousand. And further, studies using echo validation show much lower prevalence because it rules out other causes of the murmur. For example, in Vellore and Gorakhpur, the incidence was 0.67% and 0.5 per thousand, not it is percent, it's per thousand. So a large study in Vellore by Dr. Jacob Jose showed that between 6 to 18 years in the school children, the clinical evidence of suspected RHD was 1.63, but echo study, it came down to 0.67. So these are all the various studies which showed the prevalence to be less than 1 after 2000. There is an interesting study in Shimla 1992 and then in 2007. So it declined from 3 per thousand to nearly 0.5 per thousand. So more robust data comes from the ICMR, 3 school-based surveys in children 5 to 14 years from 40-year period between 70 and 2010, mostly in cities. So there was a progressive decline in RHD from 5.3 to 2.9 to 0.9 between 1970 to 2010, as shown here. It was a large study at 3 periods, multiple centers, and there was a significant decline from 5.3 to 0.9 in 2010. And And population-based surveys done by ICMR study between 2000 to 2010 under Jai Vigyan Mission Mode project to prevention of rheumatic fever and rheumatic heart disease in 10 different, mostly urban locations showed that the prevalence is less than 1 per 1,000. Most of the cities is less than 1 per 1,000. So, is this true decline throughout India? It's a difficult question. Now we come to a disturbing data by Dr. Karthikeyan et al., which is published in NEJM 2017. It says that India is home to 40% of the people living with rheumatic heart disease. Out of the 33 million people with RHD, 13 million live in India. And the mortality due to rheumatic heart disease is contributed by India by 1/3 of the mortality occurs in India. And the reduction in prevalence and mortality is below average pace compared to the worldwide fall, which is 48% between 1990 to 2015, but the reduction in India is mere 18%. Why is there such a difference? This is because there are lack of studies from the most of the underdeveloped states of India like Bihar, Jharkhand, where prevalence of RHD is likely to be high. Like tribal populations in Chhattisgarh, Maharashtra have a very high burden of rheumatic heart disease and rheumatic fever. So the results of few studies from states with declining trends of RHD cannot be extrapolated to whole of the country. The differences occur because of various methods of detection, source of data, criteria used, socioeconomic status, and availability of healthcare system. How do we detect? It's challenging because detection is most often based on the symptoms, murmurs, and the echo. The ability to detect murmurs and differentiating functional from pathological murmurs depends on clinical skills and the clinical skills of the physician, which is decreasing nowadays. So the auscultation-based methods have limited sensitivity and specificity. However, echo has a high sensitivity and specificity. It's more objective, but it detects subclinical RHD, which is 7 to 10 times more common than the clinical RHD. So we do not know the clinical significance of this, which needs to be validated. So we have various data sources like hospital admission data, population survey, and school-based surveys. Hospital and population-based registry data are very useful, but we have not heard of that in India. It's not available. Hospital admission data, how accurate it is. It is subject to changes in the incidence of other diseases. Like with the emergence of epidemic of coronary artery disease, there is less interest in the rheumatic heart disease, and it also depends on the hospital admission policies. So there is a scary data from hospital admission data from Cuttack in Orissa. There was no decline during the last 20-year period. It was as high as 45% between 91 to 2000. So population survey is likely to give more relevant data. The prospective active surveillance of the population is the only method to determine burden in any given disease and their trends. But we do not have such data, either in the country or in any state. So available data is based only on estimation performed in cities or rural areas of certain regions of states in different points of time by individual investigators. For example, a study done in Kanpur showed a high prevalence of 4.58 per 1,000. And in Himachal Pradesh, it was 5.8 per 1,000. So what about school surveys? Are they useful? They're considered ideal, but there are a lot of methodological issues. What are the modality used? What type of population? And what about the absentees? Because of the sickness or various reasons, they may not come to the school. Another problem is RHD peaks around 30 to 40 years, and the prevalence reported during school age group may be underestimation. So echo screening survey in school children done in showed such a very high prevalence rate of 52 per 1,000 school children by BIA. So what is the role of echo now? Now, after 2015 guidelines, echo is a must. The most of the studies, initial screening by clinical evaluation, followed by echo of those with suspected RHD. So this excluded false positive cases. That is why it explains the difference in prevalence. That is, for example, one study showed RHD clinical screening was 16.7 per thousand, which decreased to 0.67 with the use of echo. Suppose you do a routine screening of echo, it shows unexpectedly high prevalence of RHD, as seen in Rheumatic study done by Madam Dr. Anita Saxena, rural schools of Ballabgarh and Haryana. Between 5 to 15 years, the clinical prevalence of 0.8 per thousand, but the echo prevalence was 20 times more. What is the significance of the subclinical RHD? The same study at 2 years follow-up, there was no progression of lesions in 68%. Majority, there was no progression. It regressed in 28% and worsened only in a small percentage of 4. The most recent data by, again, Dr. Anita Saxena, school survey of children 5 to 15 years, 16,000 and odd children between June 2010 and October 2013, 4 states, Haryana, Goa, Gujarat, and Manipur, used both clinical and echo. Echo used World Health Federation criteria. What is this World Health Federation criteria for rheumatic heart disease? It is the currently gold standard for diagnosis of rheumatic heart disease. It includes both morphologic and Doppler criteria. It's more specific in differentiating pathologic lesions from physiologic. And Anita Saksena's rheumatic study is the largest study worldwide using World Health Federation criteria for RHD screening. This showed a clinical RHD of 0.36 per thousand and subclinical RHD 7.7 per thousand, which was highest in Goa and lowest in Manipur. A small data from our institute, an ongoing survey of school children in urban Bangalore showed a prevalence of 1 per thousand. Rheumatic heart disease total echoes contributed to 2.5%, that is average of 24,000 echoes per month. There were 600 rheumatic heart disease. However, valve surgeries constitute still 30% of the total surgeries because they come from various other states. Hospital admission, nearly 4,000 admissions per month. The RHD contributes around 4.2%. When we discuss with our pediatric colleagues, they still see acute rheumatic fever 3 to 5 per month, mostly from North Karnataka, and they present with severe MR, heart failure, who may need early surgery. Our data of balloon mitral valvuloplasties from 2005 to 2023, there is a gradual increase till 2010, then a steady decrease after 2010. We cannot draw any conclusion from this. So is there a changing epidemiology? RHD has actually declined in some regions, but continues unabated in most underdeveloped parts. Why is this? There is a growth and development are not uniform. Education and basic health amenities are not universal, and the primary health care is different in different parts of the country. So we have a dual epidemiology. There is a declining trend which reflects better half of the dual epidemiology. If you collect data from most underdeveloped parts, there is a surprising result which contributes to 50% of the rural total population. So data available from school health studies and hospital database, they reflect only statistics from those who can afford. The poor people, sick people, underprivileged, cannot attend schools, cannot come to hospital, do not contribute to these statistics. So we do not have a uniform data collection. So some states, like our neighboring state Kerala, there is a dramatic decline in the incidence of rheumatic fever. In 2016, it was 0.1 per thousand, and there are only 45 new cases reported in 2019. So moving on to what are the challenges in the diagnosis and prevention. Diagnosis is depending on the Duckett-Jones criteria. All patients may not meet this criteria. There may be atypical presentations. Premature use of aspirin and anti-inflammatory agents can lead to misdiagnosis. So many other diseases can mimic rheumatic fever, and diagnosis of recurrence is again difficult. The primary prevention is the treatment of streptococcal pharyngitis within 9 days can markedly decrease the risk of rheumatic fever. The single injection of benzathine penicillin is the most effective, but what are the challenges? 1/3 to 2/3 of gas pharyngitis can be subclinical, And there is lack of awareness among the population. There's treating this can prevent rheumatic fever. Again, 80% of the sore throats are viral, and diagnosing gasopharyngitis is not an easy job. And even if you diagnose gasopharyngitis, only 0.3 to 3% develop acute rheumatic fever. So to prevent one rheumatic fever, we have to treat large number of streptococcal pharyngitis. This is center criteria to diagnose pharyngitis. What about chronic RHD? So the chronic RHD depends on severity of the initial carditis, which is the most important prognostic factor. With patient comes with severe MR, heart failure, unlikely to regress. The other risk factor is the recurrent rheumatic fever. Here, by preventing the recurrent rheumatic fever, by preventing the recurrent gas infection, we can prevent chronic rheumatic heart disease. This is the only way to prevent progression to chronic rheumatic heart disease, and is cost effective. Benzathine penicillin intramuscular injection is the most preferred. The recurrence rate with injection is 0.45%, without is 11.5%. Benzathine penicillin is better than oral. The recurrence rate is 10 times less common with benzathine penicillin in the Irving House study. So with prophylaxis, it is shown that in the earlier studies, almost 70% of the MR murmur disappeared within first 6 months. So what are the challenges to secondary prophylaxis? Low level of education of patients and families, and their poor understanding of importance of secondary prophylaxis. They will take for a few years and then stop. They may not have, they may be difficult to afford the medicine or cost of travel. They may not have faith or go for alternate therapy. And above all, there is no national policy for prevention and control of rheumatic heart disease and rheumatic fever. And even limited knowledge among physicians that the rheumatic heart disease is still existing in our country. What are the problems with the injectable penicillin? It's not available. Sometimes it disappears from the market. It's painful. Many centers refuse to administer injection, and even some centers have banned this because of fear of prophylaxis. Is the anaphylaxis. It's a fear of anaphylaxis. So is it true? A large international study evaluated nearly 1,800 patients from 11 countries. The anaphylaxis was seen in 0.1%. We have recently published a data on this benzathine penicillin injection in 2,878 patients. Only 5 had anaphylaxis. There was no mortality. So it is still a safe drug and effective. So with all this, how to reduce the disease burden? Providing better living conditions and education about rheumatic fever and rheumatic heart disease. Access to affordable and quality health care. And more important, making the rheumatic heart disease a notifiable disease like in Australia, New Zealand, South Africa. Establishing a population-based surveillance system which can detect rheumatic fever and rheumatic heart disease. And starting a national program for primary and secondary prevention, and making benzathine penicillin injection freely available. So I would like to end my talk quoting this story of tremendous success. I have copied this from Dr. Anita सक्सेना's recent talk on rheumatic heart disease. In Bangladesh, there is a declining trend of rheumatic heart disease and rheumatic fever significantly in the last 91 to 97. This is because of the comprehensive control program consisting of aggressive primary and secondary prevention strategies. So to conclude, rheumatic heart disease is not gone but forgotten because of preoccupation with the ischemic heart disease. The incidence is decreasing but not uniform across the country. Only in developed regions it has come down, but in most of the parts where there is poor socioeconomic status, there is no decline, there is insufficient data, so we do not really know the correct incidence in these parts. Thank you for speaking here.
Thank you, madam. It was an excellent talk on current scenario of rheumatic heart disease in our country with a global perspective added on to that. For those who don't know who Dr. Prabhavati madam is, I think most of you know, but She is from our own place. Whenever she visits here, she visits Saligrama. And I want to take 1 minute. 2005, when I was in Manipal, one patient came from that part, Kundapur. And patient was in the 20s, late 20s. And patient had severe MS, large LA. Patient was in AF. And many people had suggested mitral valve replacement. And they had immense faith in madam, and I had given a letter to madam. Patient went to Jayadeva. I saw the data of balloon valvotomy in the 2005. That was the time patient went there, 2005. And after explaining the risk, madam took a decision to cardiovert the patient, make the patient stay in the hospital for 2-3 days, did the balloon mitral valvotomy, and send the patient back. Of course, with the caution that in case it progresses or if the patient develops severe MR, she may have to undergo mitral valve replacement. Patient has come for follow-up 2 months back. Patient is perfectly fine, gone through marriage, has got 2 children now, and immensely faithful and loyal to madam. Every time she comes to my clinic, she says, Prabhati madam has saved my life and also saved a surgery, a risk of surgery. So she is a towering personality in the field of rheumatic heart disease. She is not only an academician, she is also a great interventional cardiologist. There is people always think that she gives lectures on theory. No, she is a great interventional cardiologist, and I have seen her work, in the last 20 years. And madam, we are privileged to have you in Mangalore once again.
Thank you, sir.
You have come always whenever we are invited.
Words.
I am so happy, and I request if there are any questions, we can take one question. Saurav, we can take one question, 1 or 2 questions. Yeah, I think we can take questions because it's going to be, and also my colleague, 3 chair people are there. I want them also to contribute because they also know Dr. Prabhati madam closely. So let us just have an open discussion.
I think it is less in this part of the state. It's coastal belt
Coastal belt,
declined.
it is,
Incidence is declined here. Like Kerala, it is less common.
Coastal belt, it is reducing. There is no doubt about that. We are in Venlock. We used to see myocarditis regularly in even the pediatric section and the adult section. It has reduced, but of course, in the other part of the lesser privileged part of the Karnataka itself, it is still there. Mangalore, we have really reduced. In Venlock, where we have the underprivileged who are coming, where I work there. Sir, Arul Kamath, sir, what is your comments? Far less. Arul Kamath has been with us for nearly 40 years now, sir.
Yeah, and we are border to Kerala, and the development is phenomenal in Dakshina Kannada and Udupi. I don't know,
North
my
Karnataka.
colleagues here in Bombay. So what is your opinion, sir? Bombay, let us hear.
Good evening. See, when Narasimha was there with me at JJ Hospital, we were doing 450 balloon mitral valvuloplasties per year. But now we are just doing about 100, 110. So certainly there is a decline in the chronic rheumatic heart disease. And my pediatric counterpart also sees much fewer cases of acute rheumatic fever. So certainly there is a downward trend, and I only hope that this continues.
Thank you. I don't think I know other 2 chairpersons, nothing to comment. It was a wonderful talk, and I hand over the mic back to the team.
Thank you so much, ma'am and sirs, for the informative session. Now, I would like to call Dr. Ramesh Pai, Professor, Department of Medicine, AJ Medical College, Mangalore, to please hand a token of our appreciation to our honorable speaker. I would now like to call Dr. Srinath, Consultant Physician Kanyangad, to please hand a token of our appreciation to our honorable moderator and chairpersons. Our moderator is Dr. Padmanabha Kamath, Professor and Unit Chief, Cardiology, KMC Mangaluru. Chairpersons, Dr. Murlidhar Yadiyal, Professor, Medicine and Unit Chief, KMC Mangaluru. I request Dr. Srinath. Yeah. Dr. Harish Rao, Professor Medicine, KMC Mangaluru. Dr. Satvik Jain, Senior Physician, SDM Hospital, Ujire. Thank you, sirs. As we begin the next session, participants who wish to have tea and refreshments can get the same on the other side of the same hall. We will begin the next session now.
The topic for the next session is evaluation of ventricular ectopics. I would like to invite Dr. Jayaprakash Shenta to the dais as the speaker of this session.
Forward, backward.
Dr. Jayaprakash Shenta is a senior consultant electrophysiologist at Fortis Hospital, Bangalore. He completed his MBBS from JJ Medical College, Davangere, where he was the best outgoing student of his batch. Successfully, he did his MD and DMB from Karnataka Medical College, Hubli, and NB in New Delhi, respectively. He pursued his DM in cardiology from TNMC and BYL Naya Hospital, Mumbai, where he in his field, helping start various programs, performing one of the first leadless pacemaker implantation in India, and conducting virtual training opportunities. He has 77 publications to his name in national and international journals. As an avid teacher, he has written chapters in various textbooks and a cardiology update. He is an assessor for medical courses of India for recognition for DM cardiology courses. He has been mentoring students for years now, one of his students being Dr. Manish Rai. Welcome, sir. Further, I would like to invite Dr. Purushottam as a moderator for this session. Dr. Purushottam is a professor in cardiology at AJ Hospital, Mangalore. Welcome, sir. Now I would like to invite the honorable chairpersons for this session, Dr. Venugopal, Professor of Medicine, KMC Mangalore, and President of IMA Dakshina Kannada Chapter. Dr. Rajesh Bhatt, Consultant Cardiologist, KMC Mangalore. And Dr. Suresh Putturaya, Consultant Physician, Mahavira Hospital, Puttur. Thank you, sir.
Okay, let me, just before I start, I would suggest people who are on the right side to move over to the left so that you can see the screen where I'll be showing you some ECGs, because part of the screen is obliterated by this table. I'll start by thanking the cardiology department of KMC, with whom I have been closely associated for many years, for inviting me here for this talk. When Dr. Narsimpai and Manish actually asked me to give a lecture, initially Manish suggested that I do something like conduction system pacing, which I thought might be too difficult for this group to understand. Then I thought over for a while, and then I decided that we will talk on something which is quite common, but it causes a great deal, there is a lot of misconception and myths around this arrhythmia, which is rather commonly seen initially by the physicians or the general practitioners. And it causes not only agitation amongst the patients once it is detected, but it also causes a bit of agitation in the physician who detects it and sends it off. There are three or four scenarios which I would like to put forth. The first is the patient goes to a physician for fever. The physician touches the pulse and says that you have got bradycardia. Fever is forgotten. The patient is referred to the cardiologist / Dr. Manish Rai, Dr. Jayaprakash for evaluation of bradycardia because fever is forgotten. The second scenario is patient comes to with chest pain, they do an ECG. There will be some signs of acute coronary syndrome, but there is an ectopic seen, ventricular premature beat seen that. Refer again to the electrophysiologist for evaluation, forgetting about the chest pain. The third and the greatest and the most common scenario is that it is fashionable to have what is called as a full body checkup these days. So this man who is completely asymptomatic, he has no symptoms whatsoever but wants to get his body checked up. It's a complete body checkup karo. So the patient goes and gets a body checkup, and lo and behold, on the 12-lead ECG you pick up an ectopic. And it is like an atom bomb falling on his head because this man is, now he goes around, meets 3 physicians, 4 cardiologists, does a number of Holters, and is now a mental wreck. So these are the scenarios in which you see this, because this, there is a lot of misconceptions about this. So I thought I'll give this talk to take away these misconceptions for some of you. I have no disclosures to make. So let us look at what is this premature ventricular complexes. They are also called as ventricular ectopics or premature ventricular depolarizations. These are abnormal depolarizations of the myocardium. Abnormal depolarizations of the myocardium. Let me, where is this? Where's the pointer? Okay. Abnormal depolarization of the myocardium of the ventricle, which is below the AV node. It comes earlier than expected, unlike the escape beat, which comes later than expected. Since it arises from the ventricular myocardium and it is not conducted through the His-Purkinje system, the QRS complex is very broad because the ventricle, the muscle-to-muscle transmission is rather inefficient, unlike the His-Purkinje fiber conduction. So the QRS complex is broad and there is a secondary STT changes. Now what happens is, since the ventricular ectopic does not reset the AV node because it cannot go up and reset the sinus node, it causes what is known as a compensatory pause. When you mean compensatory pause, the normal QRS complex, the 2 normal QRS complex which are there in between the ectopic is equivalent to 2 RR intervals. Now let us say, for example, the ectopic is able to reset the sinus node. Then what happens is it resets, the compensatory pause is lesser, that is, it is less than 2 RR intervals. So that is called as a non-compensatory pause. So most PVCs do not produce a pulse. So that is very important, because when you touch the pulse and say patient has bradycardia, the physician usually forgets that he has got a stethoscope around his neck. He sends the patient for an ECG. All you have to do is take your stethoscope and put it on the patient's chest. The bigeminal rhythm which is there, maybe the heart rate is 36. When you check it, actually the heart rate will be 72, because bigeminal rhythm, this ectopic beat does not produce a pulse. Why is it so? Because it comes earlier than expected. So when it comes earlier than expected, the ventricle is not filled up. Number 2, it misses the atrial pump function, because the atrium is like a pump which pumps and fills the ventricle, so it does not have a P wave in front of that. So because of that, it is unable to produce a peripheral pulse, but it will give you a heart sound. So in a patient with bigeminal rhythm, the auscultatory heart rate is always double the pulse rate. So this is very, very important in your clinic. If you find a patient who has got so-called bradycardia on the pulse, just do an auscultation and count the number of heartbeats on the chest. Now, how common it is? PVCs are very common. When we do a ECG, a 12-lead ECG, it's usually about 4 to 6 seconds of ECG. You may see it in about 1% of the patients. But if you go on doing prolonged ECGs, like maybe you can do it for 24 hours, 48 hours, nowadays 7 days. Now we can do it for years also using a loop recorders. You can, the prevalence of PVCs are more frequent because it's quite common. Frequent PVCs, which are approximately more than 60 per hour or more than 1 per minute, and complex PVCs are seen in about 1 to 4% of the general population. The PVCs can either be tachycardia or bradycardia dependent in 80% of the patients, and some patients with high burden of PVCs, even though they have structurally normal heart, can develop a small percentage, which I'll discuss with you later, can develop what is known as arrhythmia-induced cardiomyopathy, which is a reversible condition. Whenever a person has an underlying structural heart disease, which I'll discuss, the incidence of PVCs increase. So we have to be aware of that. Now, when we look at the etiology of PVCs, you can group them into 3. One is you don't have any structural heart disease. That is, PVCs without structural heart disease are called as idiopathic PVCs. It is not uncommon, seen also in very young patients. You can have cardiac causes like the acute coronary syndrome, myocardial stretch due to hypertension or pulmonary hypertension, valvular heart disease like mitral valve prolapse, cardiomyopathies, either hypertrophic, dilated cardiomyopathy or arrhythmogenic RV dysplasias, inflammatory cardiomyopathies, which we are seeing more frequently like cardiac sarcoidosis and cardiac tuberculosis, myocarditis and myopericarditis. All these can give rise to ectopics. But we also have to remember there are so-called reversible causes, which are non-cardiac causes, which are seen during electrolyte disturbances, seen due to drugs or medications, anesthetics, surgery, systemic infection, stress and anxiety. So all these can give rise to ventricular ectopics. So we should be aware of all these etiologies when we look at a patient with ventricular ectopics. Now a few definitions, because when we say premature ventricular contractions, some of us say unifocal ectopics, multifocal. Let us try to understand what it is. If a single point in the ventricle keeps on depolarizing from the same place, then you get a unifocal PVC. Here, the PVC is of uniform morphology because it is coming from a single place from the ventricle. It could be either from the right ventricle, or it could be from the left ventricle, or it could be from the septum. So these are unifocal because they have this absolute same morphology with no difference whatsoever. The second thing is, one thing I forgot is, every PVC which is unifocal has what is called as a coupling interval. The preceding sinus beat and the ectopic, they have a uniform coupling interval because they remain the same. If you see this ectopic, this coupling interval and this coupling interval are the same. So when because they have some tonic interaction in between, so the coupling interval remains the same. Then you can have multifocal PVCs where PVCs of different morphologies are there. There are more than 2 morphologies of PVCs, and these are called as multifocal PVCs. This can happen in 2 settings. One is the PVC is arising from 2 different places. Then you can have multiple morphologies. Or you have a PVC, a focus in the ventricle. It exits from one site on one time and the second site on the other side. So you can have multifocal. So once it can exit into the left ventricle, the other time it can exit into the right ventricle, then you can get 2 different morphologies. So you can get multifocal VPCs due to 2 causes. When 2 PVCs occur together, it's called a couplet. If it occurs, 3 PVCs occur together, it's called a triplet. Anything more than 3 in a row is called as a ventricular tachycardia. Now, by and large, PVCs stay away from the T wave. However, some PVCs, especially in some genetic syndrome, fall exactly on the top of the T wave. This is the vulnerable period, the top of the T wave, the 80 milliseconds. Here, a low threshold ectopic can induce a polymorphic VT or a VF. These are short coupled. The R on T, what we call it, is the top 80 milliseconds of the T wave. So this is a vulnerable period where even a subthreshold impulse can produce a VF. So one should watch out for this. It is very important to look out for this because it is seen in some of the genetic syndromes called, short coupled PVC induced VF or focal VFs as we call it. Then some PVCs can fall in between 2 QRS complexes, which are normal. These are called interpolated PVCs, and they produce no compensatory pause whatsoever. If you have one PVC coming immediately after a sinus beat, repeatedly again and again, it's called a bigeminal rhythm. If it occurs after 2 sinus beats, it's called trigeminal rhythm. If it occurs after 3, it's called a quadrigeminal rhythm, so on and so forth. Now, there is a peculiar PVC called parasystole. Here, there is what is known as it's in a protected zone. So it keeps on firing. So the coupling interval keeps on changing because the sinus beats or any other beat cannot enter that focus. So it fires independently of each other. So it is usually in multiples of the basic RR intervals of the PVC. So it keeps on changing with the coupling interval keeps on changing. So when you see a changing coupling interval on a serial ECG, then you should suspect a parasystole. Now, few things about PVCs. It can arise from many areas of the heart. The most common idiopathic PVCs arise from the outflow tract of the ventricle, either from the left outflow tract or the right ventricular outflow tract. It can also occur from the mitral annulus or the tricuspid annulus. It can come from the Purkinje fibers or it can come from the papillary muscles. So there are many areas. Any PVC which comes from the right side of the heart, that is the right ventricle, has a left bundle branch block morphology. Any PVC which comes from the left side of the heart has got a right bundle branch block morphology. You will see right and left bundle branch morphology only in lead V1. If everything is upright in lead V1, it is a right bundle branch block. If the major deflection is negative in lead V1, it is a left bundle branch. So you don't have the normal bundle branch classification for PVCs. If it occurs from the outflow tract of the ventricle, the outflow tract is at the top, so the electrical force goes downwards, so you have a right axis deviation. If it comes from the apex, the activity is reversed, so you get a left axis deviation. So you can make out from the 12-lead ECG, if you sit and study, you can find out whether it's left or right sided, whether it's from the outflow tract or the apex. Now, whenever we talk about any condition, disease condition, we should be aware of the natural history, what happens. Fluctuations can happen because in a single day, it can change because of the autonomic influence. So one day you might have a high burden of PVC, the other day you can have a low burden of PVC. So it keeps on changing. Now we also have to know the natural history, what happens in a patient with a structurally normal heart if you do not treat these PVCs, if he has got normal ventricular function. There is usually a significant decrease in the burden of PVCs over a course of time, especially over 10 to 15 months. Almost 50 to 60% of the patients see a remarkable decrease in the number of PVCs. However, a small group of these patients can develop left ventricular dysfunction, seen in about 3 to 4% of these patients who have high burden PVCs can develop left ventricular dysfunction. In children, when you see in infants and neonates, PVCs are extremely uncommon. However, in children, you can see them. Even in children, those who have a high burden of PVCs with a structurally normal heart, if they don't have any heart disease, it resolves over time. And most of them, most importantly, the symptom development is very few. There is no need to restrict sports activities for these people, which you should be aware of. And the left ventricular dysfunction is very low in this, no hospitalization, no deaths. So idiopathic PVCs in pediatric patient is has a very benign course. Now, what is the burden of PVC that causes left ventricular dysfunction? If you have more than 20 to 25% burden of PVC over 24 hours, these are the patients who may develop left ventricular dysfunction over time, and we should carefully keep on monitoring these patients as we go along. Now, we see PVCs in two different situations. One is in the consulting room, you are sitting, patient comes to you with an ECG, or second, you are in the ICU setting or in the ER. The dilemma is this PVC benign or malignant? Whether I should treat this PVC or not to treat this PVC? If I am going to treat this PVC, am I going to give these patients medication or do a catheter ablation for these patients? When we approach a PVC, we have to critically evaluate the symptoms attributable to PVC, because many of these patients would have been asymptomatic until the PVC is detected in these patients, and they become symptomatic after that because they become cardiac neurotics. They develop palpitation, they develop dizziness, they develop fatigue, they develop lots of symptoms because this has been put in their brain. And they do this, they contact this famous doctor called Dr. Google. They'll Google that, and when they Google that, they go completely mad. And especially if they are in the IT industry, they come to you, then they'll even make the doctor mad. So one has to be very careful and critically evaluate the symptoms. The red signs are history of syncope, history of resuscitated sudden cardiac arrest, a family history of premature cardiac deaths. So if you have any three of this, you should send these patients without even thinking of anything to Dr. Manish Rai. Look for structural heart disease. So structural heart disease is very important. I'll tell you why, how to treat. And also assess the left ventricular function. You do the echo and find out. We also need to use a Holter to assess the burden of PVCs and the morphologies of PVC. Now, there are certain red flags which I'll tell you. In clinical history, history of syncope, I've told already, family history of premature sudden death in the first degree relatives. Past history of heart disease, congenital heart surgery or heart surgery. On physical examination, evidence of structural heart disease like murmurs, S3, S4s, heaving apical impulse, cardiomegaly, right or left heart failures. 12-lead electrogram, pathologic Q waves indicating a myocardial infarction in the past, right ventricular, left ventricular hypertrophy, and long QT, short QT, Brugada syndromes. These are genetic syndromes. These are primary electrical disease of the heart. They do not have any structural heart disease, but these are the patients who have the highest risk of sudden cardiac arrest. Epsilon waves, if you can detect, it's usually seen in lead V1 and V2. These are small deflections of after the QRS, which you can see. And this indicates that the patient probably has got arrhythmogenic RV dysplasia. And also, when you're looking at a PVC, I told you about the short coupled PVCs. On ambulatory monitoring, look for multifocal PVCs, the non-sustained VT, polymorphic non-sustained VT, and sustained ventricular tachycardia. There are certain factors which may point to worse prognosis, which includes structural heart disease or electrical heart disease, which I've discussed before. More than 20,000 PVCs, you keep a watch, monitor them to look for worsening left ventricular function, complex PVCs, increasing morphologies, non-outflow tract PVCs, short coupling interval PVCs, and PVCs which are very broad QRS complex, extremely broad QRS complex, usually are intramyocardial PVCs. When we do a PVC workup, if you have this sudden cardiac arrest, syncope and all that, please do not bother to do a detailed workup. Send them to an electrophysiologist who will look at various other things. But if a patient comes to you with absolutely no symptoms or minimal symptoms, you detect on, do an echocardiogram. If it is normal, by and large, it is an idiopathic PVC. If it is abnormal, it could be ischemic structural genetic heart disease, will require further workup, sent to the cardiologist, do a 24-hour Holter. If you, on a 24-hour Holter, you get a high burden PVCs, we do a magnetic resonance imaging to look for inflammatory cardiomyopathies and other structural heart disease. We classify PVCs into three groups. One is low burden PVCs when they are less than 10,000 per 24 hours. Second is 10 to 20,000 is intermediate burden PVC. And if you have more than 20,000 per 24 hours on a Holter, it is called high burden PVCs. Management of idiopathic PVCs will be reassurance in asymptomatic patients. So many a times you have to convince them, look, nothing is going to happen to you. These PVCs will not kill you, and nothing needs to be done to this. You come for follow-up once a year or once in 2 years for an echo, we'll see. Education of the benign nature of the arrhythmia should be the main form of treatment in these patients. In symptomatic patients, you can give a trial of beta blockers. Now, here, beta blockers, the most go-to drug which I have seen by everyone is metoprolol succinate at 25 milligrams OD or BID, the most useless drug. It is even worse than a placebo. It does nothing to any arrhythmia. The arrhythmia always recurs. There are only 2 or 3 antiarrhythmic drugs which work, beta blockers, which is, one is propranolol, which is good antiarrhythmic. The second is carvedilol. The third is sotalol. These are the only 3 antiarrhythmic drugs, and it should be given in a proper dose, not in a homeopathic dose. Even then, suppression of PVCs is by and large rather dismal with beta blockers. The more than 90% suppression is seen in only 10 to 20 to 15% of the patients. And please do not treat these patients with amiodarone and do not frighten the patients out of their wits. If you have a high burden PVC, we approach them like this: look for evidence of heart disease. If you have an idiopathic PVC, look for LV function normal. Don't give any drugs. Just say, go and come back to me after a year. Let me assess your ventricular function. By and large, 50 to 60% of the time, these patients' PVC burden would have come down. So periodic assessment is more than enough. If they have mild LV dysfunction, you can use antiarrhythmics, beta blockers, or dihydropyridine calcium channel blockers. If they have significant left ventricular function, we do catheter ablation, which I'll come to next. When is catheter ablation indicated? It is indicated in patients with very high burden of PVC with left ventricular dysfunction, because this is an arrhythmia-induced cardiomyopathy. How do you detect this as an arrhythmia-induced cardiomyopathy? In arrhythmia-induced cardiomyopathy, one thing you will see is there is no thinning of the ventricular wall, number one. Number two, there is no ventricular dilatation. So when you see these two, you should suspect, and there is nothing in the myocardium. There is no speckling of the myocardium. There is no abnormal myocardial scarring, which you can see. So if you have a patient who's not responding to drugs but is highly symptomatic, then we consider catheter ablation, and it has got a very high efficacy of more than 80%. It can restore left ventricular function back to normal even if it is only partially successful. Now we come to approach of the PVC in the ICU. You look and assess the complexity and frequency of PVCs. Look for the underlying substrate, especially ventricular function and acute ischemia. If it is there, acute ischemia is there, correct for it. Look for metabolic abnormalities like acidosis, hypoxia, azotemia, hypokalemia, hypomagnesemia, correct it. Management, treat ischemia, correct metabolic abnormalities. Consider beta blockers if indicated, that is carvedilol or propranolol. In future, please do not use metoprolol succinate. The most go-to drug, I'll mention the drug Prolomet XL, Met XL 25 mg OD, no use. Please don't do that. I'm not against it, but it is pretty useless. Suppression of PVCs with lignocaine, even in acute myocardial infarction, has got no mortality benefit whatsoever. Antiarrhythmic drugs, including amiodarone, should not be used. In structural heart disease, for coronary artery disease, the go-to drug is beta blockers. LV function is down, carvedilol. LV function is normal, propranolol. Dilated cardiomyopathy, carvedilol, of course. Hypertrophic cardiomyopathy, propranolol and disopyramide can be used. Arrhythmogenic RV cardiomyopathy, you can use propranolol or sotalol. Finally, do's and don'ts with PVCs. Please do reassure the patient that PVC is not going to kill them immediately at any time. Number two, do a thorough workup of these patients if they have a significant burden and multifocal PVCs. Do a regular follow-up of these patients, where don't call them every month and just like they're on payroll in a police station, they need not come every month to pay your consulting fee. They can come once a year, once in 2 years. They're absolutely perfect. Refer a patient to the electrophysiologist if the LV function deteriorates or you suspected genetic or other heart diseases. And do not frighten the patient. Okay, do not frighten the patient. Do not do an inadequate or improper workup. Do not give amiodarone in this patient. Do not try to manage high-risk patient. Do not do a coronary angiogram in a young patient with no evidence of ischemic heart disease, because PVC is an electrical problem, not a plumbing problem. Now, in conclusion, ladies and gentlemen, PVCs are common, often asymptomatic. We make them patients by making them symptomatic because not understanding the PVC. A systemic workup is necessary. Asymptomatic high burden idiopathic PVCs need regular follow-up only, and most of them resolve spontaneously, do not require therapy. In those patients who have left ventricular dysfunction, catheter ablation is a good way of restoring their LV function to normal, and high-risk patients require EP referral. And thank you all for a patient hearing.
Thank you, Dr. Jayaprakash. I think it's a very, very concise and fluid presentation of a topic that's quite challenging and complex. I mean, goes on to further emphasize the fact that evaluation and management of ventricular ectopy is quite challenging and sometimes complex, and the prognostic assessment of this modality is best interpreted based on the underlying clinical condition. Another point you stressed on very effectively and very importantly so is that there is no sense in chasing these ventricular ectopy. It can be hazardous as proven by various arrhythmia suppression trials. The session is now open to questions. Dr. Venugopal?
Thank you very much, Dr. Jayaprakash. He has emphasized a very important thing that as a physician, you need to examine properly the patients. Believe me, sir, there are very senior physicians here who are MD physician and a cardiologist. They used to treat all kind of arrhythmias, MI, but short of intervention. So my question is, now a patient comes with a history of sibling sudden death, heart attack. This is a common layman, young age. And on routine examination, cardiac examination is normal, ECG is normal. And now the commercially Holter is available. 3 days you get the report, Holter report is normal. Now can we label him as, okay, you are fine, go, or referral to a cardiologist? If referral to a cardiologist, how do you approach this evaluation of this patient?
Okay. Now, first thing is, whenever you are going to assess the family history, we just take the history. Anybody died? Fell dead. Now, whenever we talk about sudden death, now if you are looking at patients who are in their 30s and 40s who have fallen dead, most of the patients who have had, we have to take history. Did the patient have chest pain before he fell dead? We have to take all that history. So patients who die suddenly without coronary symptoms, they just fall dead, either during sleep or during sports activities, or they're just walking and then they fall dead. So if you have such a symptom, such a history in a first degree relative, then don't send them. Evaluate them, and if necessary, even long QT. This is not a form for me to discuss. The QT interval is very dynamic. It's extremely dynamic. In fact, long QT patients can come to you with normal QT interval when you are examining them. But you make them lie down and stand up, suddenly the QT can increase. Even in one day, the QT interval can change. So there are lots of long QT patients in and around this part of the world. I think Manish has got quite a few. And there are another group of patients who come to me from North Karnataka. They have consanguineous marriage, and in patients whom you suspect a long QT, you should do a full examination, including what we do is called as an epinephrine challenge test, which brings out this QT prolongation. Exercise also can bring out QT prolongation. Then there are conditions such as CPVT, which is everything looks normal on ECG, but you put them on a treadmill, they have bidirectional ventricular tachycardia. So these are all things which an electrophysiologist need to be addressed. So family history of sudden death, which is not preceded by chest pain, patient goes to the hospital sweating, then you have to send them. If they have had chest pain 40 years, 50 years, chest pain, clear-cut ischemic heart disease, then family history of premature coronary artery disease need to be addressed.
Is T-wave alternance a clinically usable tool, sir? I mean, possible to...
See, if T-wave alternance has not stood the test of time, but however, let me tell you this. When you have a patient who comes to you with a long QT syndrome with a T-wave alternance, then be warned, this patient is very high risk of sudden death. T-wave alternance is very commonly seen with long QT syndromes. It is less useful in using the computerized T-wave alternance is not very useful. However, in long QT, if you see a T-wave alternance, then take it from me, this patient is going to die suddenly.
fact, a negative T-wave alternance test is also considered to be an excellent tool to differentiate people who are at risk of developing arrhythmias, also as someone
But it is not, unfortunately, it has not stood the test of time because there are lots of T-wave. See, these are all, see, most of the deaths, let me tell you on the ECG simply. There are only two components in the ECG. One is the depolarization and the second is repolarization. Most of the arrhythmias which happen is the repolarization abnormalities. It is not the QRS complex. It is what is happening between the ST segment and the end of the T wave. That dynamics is something which is going to decide the arrhythmia part of it.
Hello, one last question, sir. Sir, you have elaborately told about the isolated ventricular contract. For the note of the students here and everything, I would like to question, any history of caffeine and smoking induction has to be taken and reassured. Second, any note on short QT intervals?
Okay, now first question. Caffeine has been shown to have no effect on this ectopic whatsoever. New studies have come out. So whenever a patient comes to you with ectopics, don't say don't drink coffee, don't drink. That is the only thing the poor fellow is going to enjoy 3 times a day or 4 times a day. I mean, you are denying that fellow of a cup of coffee. So don't do that. Unless he's drinking espresso coffee, which is very strong, or Arabic coffee, 10 times a day, which can give rise to increase in ectopy. Our coffee is hardly, it's mostly milk and sugar rather than coffee. And most of the times when you get it in the shop, it is decaffeinated coffee, so it doesn't make a difference. Second is smoking can increase the ectopics. Smoking also can kill due to coronary artery disease. You should ask them to stop. Number 2 is short QT syndrome. Short QT syndrome is extremely uncommon, but nevertheless I have 1 or 2 patients, they can die suddenly. We can use quinine in these patients. Unfortunately, we don't have quinine. We use quinidine in these patients because quinine and quinidine are diisomers, you see. So we deal with it that way.
Before we conclude the session, one more question, sir.
Absolutely.
Why not beta blockers? Like you said, any particular reason why you mentioned drugs like metoprolol should better be avoided?
See, it is not
just out of curiosity.
No, it's not. Yeah. There are large trials which have come out where they have looked at ventricular ectopic prevention and ventricular arrhythmia prevention with comparing metoprolol with carvedilol, comparing metoprolol with propranolol. Even in a patient with arrhythmic storm, you should use propranolol because it's got a wider spectrum of action. Even carvedilol is not a cardioselective beta blocker, it's got a broad spectrum of activity. That is what makes it. Sotalol has not only is a broad spectrum, it has also got class 3 activity. These are the only ways in which you can, because all the adrenergic stimuli is blocked by this broad spectrum activity, whereas in metoprolol it can't do it. You understand? Because it's cardioselective only for that small one.
Sir, one
You
question.
ask all the questions you want because before I leave, let me answer all the questions.
Sir, quite often we see these days that people with, especially these hemorrhagic fevers with inflammatory markers, raised inflammatory markers, they will have some subtle ECG changes, sometimes ectopics. So in today's era of litigation-based medicine, should we really chase those ectopics or?
No, you should not change the ectopics. The only place where you can look at things differently is in a patient who has got a suspected Brugada. If you develop RBBB, because fever brings out Brugada. So if you do an ECG and you get ST elevation with this thing, which is not myocardial infarction, this is Brugada syndrome. So in that patient, it's very rare, but it can bring out. And these patients have family history of patients dying with fever. If you have a patient who dies suddenly with fever, suspect Brugada in these patients because Brugada can be brought out with fever. However, if you have a patient with ectopic during fever, just wait for everything to settle down and do an ECG much later, nothing happens.
So, sir, the other thing is nowadays we have a lot of these fitness enthusiasts who have got obsessed with muscle building and a lot of bro science. So there is a lot of unregulated stimulants that are available commercially these days. And the dose of caffeine is quite high in those commercially available preparations. So when these people come for a health check, should we really, because these are the 2-3 scenarios you started off with. One was the scenario of fever, the other was health check. So generally as a physician, we encounter these situations repeatedly. So in those situations.
Yeah, see, many of these people who are obsessed about building their body, they are rather narcissistic, I would call it, because they want to stand in front of the mirror for no rhyme or reason and spend hours together in the gym other than doing some better work. But nevertheless, these people are not only on this whey proteins, these are called whey proteins with other something like lysine, everything being added along with caffeine. So these things are very dangerous. Many of them, we do not know what drugs are added to this bodybuilding drugs, so you should tell them to get off those drugs and bodybuilding drugs. Otherwise, you will say that it will catch up. And the second thing is you have to realize, just like carbohydrates, high dose of proteins stimulate insulin. So it can lead to hyperinsulinemia. Hyperinsulinemia is toxic. Hyperinsulinemia causes coronary atherosclerosis. They can have a plaque rupture.
Thank you, sir.
Thank you, sir.
Thank you so much, sir, for the informative session. Now I would like to call Dr.
Suresh, want to ask something? Suresh?
Yes,
sir, in many of the slides you have mentioned that amiodarone should not be used. Is there any indication for amiodarone?
Unless you are going to manage a patient with an arrhythmic storm, or you want to send the patient to an electrophysiologist to buy some time, you can use amiodarone. Suppose patient has got an implantable defibrillator and has got multiple shocks, we use amiodarone. But even in those patients, we would prefer to do a catheter ablation because with amiodarone, the risk of toxicity is 35%. So 35% is not a small, and it's got toxicity on every single organ in the body, including pulmonary fibrosis. And in EMIAT and KMIAT trial, it has been shown that it can cause death also. Okay.
Thank you, sir.
Thank you so much, sir, for the informative session and taking your time to answer all our questions. Now I would like to call Dr. Narasimha Pai, Head of Department and Professor, Department of Cardiology, KMC Mangalore, to please hand a token of appreciation to our honorable speaker, Dr. Jayaprakash Shentar. I would now like to call Dr. Manish Rai, Consultant Electrophysiologist, KMC Mangalore, to please hand a token of appreciation to our honorable moderators and chairpersons. Dr. Purushottam, Professor Cardiology, AJ Hospital Mangalore. Dr. Venu Gopal, Professor Medicine, KMC Mangalore. Dr. Rajesh Bhatt, Consultant Cardiologist, KMC Mangalore. And Dr. Suresh Putturaya, Consultant Physician, Mahavira Hospital, Puttur. Thank you, sir. Now we'll be moving on to our next session.
Esteemed dignitaries, thank you for gathering here today as we come together to remember and celebrate the life of a truly remarkable individual, Dr. A.V. Shetty. which they were able to upgrade the facilities in Venlog and soon would go on to put up the second floor of the OPD block, where neuro and thoracic OTs were created with the likes of Dr. S.S. Solal and Dr. Kodandraman. It was in this OT in 1974 the first open heart surgery in the state was performed by a team headed by Dr. Ulal, in which Dr. A.V. Shetty played a major role as the primary cardiologist. This milestone was earmarked as the beginning of cardiology services by KMC. Although he retired as a professor in his 60s, Dr. Shetty never stopped practicing. He was a proud member of clubs like the Freemasons Club, the Rotary Club. He enjoyed playing golf and bridge during his free time. He had traveled to many countries, but he always made it a point to visit his patients in his clinic, till around the time COVID became rampant in the country. While his professional achievements are awe-inspiring, it is equally important to acknowledge the impact he had on his students. His legacy lives on in the hearts and minds of the countless students he had mentored. His impact extends far beyond the walls of the lecture hall, and his teachings continue to ripple through the generations of doctors he had inspired. Dr. Shetty is survived by his wife, Mrs. Chandralekha Shetty, and his children, Dr. Sarita, Dr. Suprita, and Dr. Aravind. Mrs. Chandralekha has accepted to attend this event. Thank you, ma'am, for gracing this event with your presence, and also for reminding us of Dr. Shetty's remarkable and inspiring contributions. We now move on to the next session of the day, Evolution of Cardiology from Clinical to Intervention over the last 5 decades. I have the privilege to introduce our speaker for the session, Dr. Narendra Bansal, who is an interventional trained over 100 DM cardiology students, has around 200 research publications to his name. He has done more than 10,000 coronary angioplasties, 1,000 pediatric interventions, 1,000 peripheral interventions, including renal stenting and coarctation stenting. Welcome, sir. We are grateful for your presence here today. I also would like to call our first moderator for the session, Dr. Al Kamath, who is our professor extraordinaire, our former head of Department of Cardiology, the first alumni of KMC to get DM cardiology, as well as the first in the state. He has been an exceptional teacher and mentor, training innumerable undergraduates, postgraduates, and postdoctoral students in cardiology, spanning over 4 decades. He has published research papers in over 80 national and 1 international journal, and he is a proud Rotarian, being the president from 2000 to 2001. He's also a lifetime member of the Indian Medical Association, Association of Physicians of India, and Craniological Society of India. The second moderator for the session is Dr. Ramesh Pai, who is an alumnus of KMC, served as the professor of medicine in KMC for over 30 years, professor and dean in AJ over 10 years. He's married to Dr. Mukta Pai, the professor and HOD of pathology at Mangalore Institute of Oncology. Thank you, sirs, for coming. The chairpersons for the session are Dr. Prabha Adhikari, ma'am, professor of medicine at Yenapoya Specialty Hospital, Mangalore. She is also an alumnus of KMC, been practicing since 1984, with her field of interest being geriatrics, diabetology, and endocrinology, as well as palliative care. She is also the president of API Dakshin Kannada chapter. The second chairperson, Dr. B. Sham, he is a consultant physician at at Adarsha Puttur and did his MBBS from KMC Hubli and completed his MD medicine from Banaras Hindu University. Thank you, ma'am and sir, for being a part of this session.
Yes. Respected chairpersons and the dignitaries and all the attendees in this hall on a Sunday morning. Good morning to all of you all. I'm here at the request of Narasimha Pai, who gave me a call. Sir, you have to come to Mangalore to deliver A.V. Shetty oration. I said, there cannot be a better occasion for me. I have shared the dais with Dr. A.V. Shetty on a couple of occasions, particularly in the examination hall. What a gentleman he was. He would take the exam and tell the chief examiner, you give the result. I have done my job. Giving the result is not my job. He used to be kind to the students also. Not that I mean to say he passed any duffers. But he was an absolute gentleman, and you just heard the ode that was shown on the screen. So Dr. A.V. Shetty memorial oration was really, I thank Narasimha Pai, one of my brightest students from JJ Hospital, to give me a call to deliver a talk. You know, but I'm very sorry, Pai. You gave me a talk which is not available on the Google. Otherwise, these days making a lecture is very easy. You put the topic on the Google and you get it. Of course, most of my slides are from the Google, but you have to really dig out each one separately. And there are almost about 80, 90 slides, so you believe how much time we had to spend in making this philosophical lecture. So with that introduction, I will be talking to you how cardiology has grown over the last 5 decades. You just heard how Dr. A.V. Shetty started the process in Mangalore. So therefore, my job is to deliver to you basically history of cardiology. This is the man who started the ball rolling for cardiology. Until him, not much was known. People did not know what the heart was doing, what the blood vessels were doing. So Sir William Harvey, of course there have been anecdotal autopsy experiences prior to him also, but he is the first man who introduced that there is a heart which beats and the blood circulates. Until then it was not known that way. We have Laennec, the man credited to the development of the stethoscope. Now, how to go clinically? Just listening to the patient in cardiology practice is not enough. You have to auscultate him, you have to palpate him to get the physical signs out. So Laennec started with the anecdotal, very primitive stethoscope, just a paper roll, and then he used a bamboo, and that is how the beginning of the stethoscope was in the 18th century. So you can see in this picture, this is his stethoscope. He spent further time in developing and refining his technique. Of course, this is the modern stethoscope that we use, but this was his stethoscope which he developed over the 3 years. He used a tube and a diaphragm which we are using in a modern way. The 1800th century also saw the development of the blood pressure. Until then, nobody knew what is a blood pressure. So Stephen Hales was the first one to conduct an experiment by putting a cannula into the carotid artery, and he showed that the blood would rise and it would come down with the respiration. So these are the initial people who have worked to show that there is a heart which beats, there is a blood circulation, there is a blood pressure, and then how to measure this blood pressure clinically. Riva Rocky was the first person to do it, but with the long sphygmomanometer tubes. With the sphygmomanometer that could be developed at that time. And then it was only the systolic pressure which was known to be measured by the sphygmomanometer. It was Korotkov in 1905 who showed and gave us what is called as the Korotkov sounds, which we recognize, and we call the pressures as systolic and diastolic. And all through the last century, we have been talking of systolic hypertension, diastolic hypertension, mixed hypertension, etc. The 1900s also saw the development of the electrocardiograph. Initially, it was a very, very primitive one developed at the St. Mary's Hospital, London by Augustus Waller. But it was fluid-filled capillary tubes with dilute sulfuric acid and electrodes connected to the patient. The tracings which were obtained were very poor quality to make any impact in clinical usage. The ECG recorded by him was the one which you see at the base, the black one. I'm sure none of us can interpret this and say whether there is ischemia, infarction, hypertrophy, arrhythmia, whatever, compared to the ECG that we record nowadays. But that was the beginning of getting some deflections until in the 1900s, William Einthoven, he started with his experimental work and he gave us the first kind of the electrocardiograph. That was his big machine that he used to use. It was a string-based galvanometer. He improved upon it further. Look at the size of the ECG machine that was used in the early days, and the ECG was recorded. But Einthoven is credited to the development of the ECG, giving us the first initial leads. Lead 1, 2, 3. That was the beginning of the electrocardiograph, where some meaningful clinical discussion could be organized. And then we have further development of the ECG by Goldberger, who brought in the concept of the chest leads, and now this is the modern ECG that we continue to use for the last almost about 80 to 90 years. So this is how the ECG developed over the period of time in the 1900s. Of course, I could not get one slide. There is the beginning of the stress test described by Master. So I'm sure sir must be knowing that there used to be a master's test which we used to do over a step. So climb the step from one side, go to the top, go down the other side and come back again. So it was to just give exercise to the patient, record a single lead ECG and then make some conclusion that this man has got ischemia or not. But today's modern one is the treadmill, or some people also use the bicycle, and this is being used, recommended by Goldhammer and Scherf. Use the exercise testing to provoke angina, to get the STT changes, and to confirm the diagnosis by a stress test that this patient has ischemic heart disease. And here comes the father of the stress testing, that is Elsted and subsequently Bruce. And we continue to use the Bruce protocol. So every 3 minutes you have the change in the elevation, you have a change in the speed on the treadmill. That translates into increase of work of exercise, and you record the ECG along with that simultaneously. The hemodynamics are recorded, and that is what the modern stress test is. And this is a fully computerized 12-lead stress test nowadays, used as recommended by Bruce. Of course, after that, there have been many, many protocols which have come into practice. Evolution of the echocardiography, even though in the 19th century, it was known about piezoelectrical characteristics of the crystals when stimulated by the electrical current. But however, it was in the 1950s that Helmut Hertz and Edler started with the echocardiography the first time, and Edler was the person who produced an echocardiogram on the M mode, and he showed that in a mitral stenosis what changes can be there. Simultaneously, the Japanese group was working aggressively on the Doppler technology, and then came in the father of the textbook of echocardiography, that is Feigenbaum, as we recommend even today to most of our postgraduate students that you must read the textbook of echocardiography by Feigenbaum because it deals with the basics, the M mode, and then of course the textbook has been upgraded several times to give you the entire information. So this is how the echocardiogram looks. The initial one was the M mode only, and now we have the 2D echocardiogram, and we have further evolution of this in terms of the Doppler and the color Doppler. So it was Christian Doppler. It was Christian Doppler who showed the Doppler effect first time in 1969 to assess valvular regurgitation across the valves. These days, whenever you hear a murmur, systolic murmur or a diastolic murmur, it is customary and probably legally mandatory also that you have an echo Doppler study done to find out whether the valve is stenotic or the valve is regurgitant. Is there a second valve involvement? Is there only one valve involvement or three valves involvement? The major discovery in the Doppler was in the 70s when the pressure drop across the valve was measured by a simple Bernoulli's equation. In fact, today, even in the latest procedure that I'm going to tell you, that is the tower, we do an echocardiography to show how much is the gradient across the aortic valve to take a decision what to do further next. In the early 80s, color flow imaging was developed by Kitab Bate, who introduced the pulse wave Doppler in 1982 across the mitral valve to assess the diastolic function, and then subsequently the Japanese workers developed the transesophageal echocardiography. So we do have some problems many a times from a thoracic poor window that we can't get good adequate imaging. We need sharp images. The transesophageal echo, which can be done very quickly at the bedside of the patient, comes very handy. Subsequently, there was development of the contrast echocardiography by Dr. P.M. Shah, an Indian, and this is how the echocardiography has progressed. This is the chart, how echo has progressed over the years, right from simple M-mode echocardiography to 2D echocardiography, use of color Doppler, use of transesophageal single plane, biplane, multiplane, etc. Side by side, there was evolution of the cardiac surgery. Till about the 1940s, there was not much of cardiac surgery that was being performed. In the 40s and the 50s, people did cardiac surgery but without any cardiopulmonary bypass. So patent ductus would be closed, a BT shunt would be done, or a mitral commissurotomy could be done. Nothing beyond that could be done. It was realized that unless and until we have an alternate method of circulation and stopping the heart, we cannot proceed with any complex surgery or even a valve replacement. So Lillihai's laboratory was the most aggressive. Lillihai developed the first system that was called as cross circulation, and he operated the cases and he showed that the patients could be operated. But there used to be a lot of disasters. In spite of his development, there used to be a lot of disasters until the oxygenator came into the being by Gibbon et al., who did the ASD surgery in 1953, and he showed that using the cardiopulmonary bypass, you can operate a patient. That time ASD was considered a complex surgery when the beginning of the operative work began. Further, you have these different kind of oxygenators coming in. The bubble oxygenator, which is the most simple and the inexpensive one which is used. Even today, the bubble oxygenator is quite commonly used in the cardiac surgery practice. So Lillihai was again involved in this, and he had a whole list of innovative contributions to the development of the cardiac surgery, early cardiac pacemaker, valve replacements, and other surgeries. By the 1950s, Gibbon and a great man from cardiac surgery, living legend, Kirkland. They developed the techniques of cardiac surgery in the 1960s. Many companies came forward to give the heart-lung machine, slowly evolving to the present ones, which have got the heat exchange systems, the hollow fiber micropore membrane oxygenators, which are the in thing nowadays. The bubble are less commonly used. The membrane oxygenator is the most commonly used ones. So during the next 10 years, in the 80s, there was a whole list of cardiac surgeons who were carrying out active cardiac surgery in the United States and in the European countries. One of the commonest surgery even today is CABG, as far as cardiology practice is concerned. Even though we are doing so many angioplasties, but there are enough number of people undergoing CABG because the other kinds of cardiac surgeries are becoming less with the angioplasty techniques being taken over. In the 1964, the first time the experimental surgery was carried out, but the first person to be credited to the CABG performance is Dr. Favalaro, who carried out the aortocoronary bypass surgery, and then the procedures became slowly more popular, and this is the whole list of events. First CABG procedure in 1967, Carpentier started using the radial artery. There was the use of the cardioplegia solution subsequently, and then Gibbon et al. And we have the various trials, the American CAS study, followed by the European CAS study, with the use of the Lima-Rima grafts, with the use of the Lima-Rima Y graft, etc. The cardiac surgery has evolved. And now, the surgeons even talk of a mini surgical incisions, small incisions. The further advance has been with the help of the laser techniques. Just put 4 holes in the chest wall and carry out the cardiac surgery through a mini thoracotomy. This is what is interventional cardiology era. Unfortunately, it is a very wrong thing that we believe that I can solve everything with intervention. And anyone who has come to me is a case for intervention, which is not true. You have to use your clinical judgment, take help of the non-invasive, the biochemistry, and put all information together and take a call whether he needs an intervention, which will help him or not, or do you think that he will do well, equally well with the medical therapy, or should I refer the patient to surgery? So anyone who gets a DM degree gets a license to practice the interventional cardiology the next day. It is not so simple. It has gone through a very hard way of 20-30 years in the development, those who have really evolved. So William Forsman is the first man who entered the field of invasive cardiology. I'm not saying interventional, invasive cardiology. And believe me, he was debarred from the medical college. I'll just tell you a short story about William Forsman. He is the person credited to monitoring the right atrial pressure by cutting his own cephalic vein in the middle of the night, taking help of a nurse, put in a urinary catheter, the Foley's catheter, down into the right atrium, go from the surgical unit to the radiology department, open the radiology department himself, and under the fluoroscope, he used to see the position of the balloon catheter that he had put in. He made 3 such attempts on himself. Once he cut his left cubital, once he cut his right cubital. When the administration came to know that he is practicing this kind of a medicine, he was debarred from the medical college. Look at that. This is a catheter which has been pushed up. It has gone into the right atrium. But he led the world that you can measure what is called, now we call hemodynamics. And hemodynamics mean a lot to us in any acute care patient, forget whether cardiac or non-cardiac. So William Forsman was the first person. Subsequently, diagnostic catheterizations have been carried out by Andre Cournard and Dickon Richards. And then, these were all cut-down techniques till this gentleman, Seldinger. He made our life very easy. Take a needle puncture, pass a wire, pass a sheath, and through the sheath you can get into the cardiac system, arterial or venous. Accident. Aortography was being performed by Dr. Mason Sones from a right brachiotomy. He connected it to the injector and he injected 30 ml of dye to do an aortography. The catheter slipped into the right coronary artery and it gave a cardiac arrest. Of course, the patient was revived, but he discovered that he had done a coronary angiogram by injecting the dye into the coronary arteries. So the accident proved to be one of the commonest procedures to be performed today in the diagnostic cardiology. And then subsequent evolutions have taken place. Of course, fortunately, he could revive the patient with repeated coughing, etc., which we even carry out today if the patient has a bradycardia or a cardiac arrest. This man still lives in our fingers, Judkin's catheters. He wanted the cardiology procedures to be more and more safe. So Melvin Judkins used to take plastic tubes, put it over a wire, put it into the hot water and shape it as required. And that is what produces the cardiac catheter. Of course, nowadays it is done in the factory. Before the factory is ready to manufacture that, this is how he started. And we use the Judkins catheters even today to do routine catheterization and coronary angiography. Subsequently, there were many more people who came in like Amplatz, who gave more shapes of catheter. The father of interventional radiology, Dr. Charles Daughter. In 1964, he saw a man with the occluded limb. Here is the narrowing in the limb artery, and the patient was having intractable claudication. He had a foot which was infected. He put in a catheter and he broke open that lesion to give relief to him as far as pain is concerned. This is the beginning of the interventional cardiology by Charles Daughter. Subsequently, many people worked in this field until Andreas Grundzig. Until Andreas Grundzig, this man, who is really credited with doing the first coronary angioplasty in 1977 in a full hall filled with people to watch what is he going to do. So he carried out the coronary angioplasty using a balloon dilatation catheter. He opened the artery in the theater, showed that there was a narrowing, passed the balloon and the wire down, opened up the lesion, took him to the cath lab, demonstrated that the lesion had opened. Of course, subsequently he did it percutaneously in 1977. And then the good part is his procedure remained successful even after 20 years. This is the man who underwent the angioplasty in 1977. First time in the history of interventional cardiology and the first case. He survived, even though Dr. Grundzig died in a plane crash. So his angiogram was done in 2015 and his artery was shown to be patent even after more than 20 years. So what a brilliant success he had achieved. Though he did not live to see this result, I wish he should have. So here are the pictures. This was the narrowing. This was the post-dilatation, which was shown in the follow-up angiogram. After his first case, he made the presentation. This is just a photograph of that. He was not offered a platform presentation. He had to make a poster presentation. So when you do good things, they don't get accepted very easily in the world. It takes time. Subsequently, of course, this was a bad year, 1985. So many great men died in 1985 due to various reasons. Of course, Grundzig was one of them who died very young and due to a plane crash. The others died due to various illnesses, etc. So 1985 lost 4 very, very important persons who owe a lot to today's interventional cardiology. The major milestones in the interventional cardiology itself is a very big subject. We cannot go over it. So you have the guide wires, the atherectomy, the stents, you have the imaging system coming in, you have, when I was a student, acute myocardial infarction meant bed rest, pethidine, Finargan, and some laxatives. Don't move. How much bed rest? 4 weeks, 6 weeks, 8 weeks, depending on how you do it. Today, where is your cardiologist? There is an acute MI. Call him immediately. If he is not in the hospital, give him an emergency call. Shift the patient to the cardiac cath lab. So there has been a total dynamic change from a resting disease, sleepy disease, to an active disease where you intervene. And this is how the things have evolved over a period of time in the field of interventional cardiology, that you have the balloon angioplasty, first generation stents of the drug-eluting variety, drug-eluting second generation, third generation stents. This is all a part and parcel of our evolution, that we have better and better quality stents and better results. So this is what a stent would look like. The first stent, the wall stent, the GR stent. These are the stents which have been used, but they are history. We have much better stents now. This was the first stent subsequently to be developed by Palmers and Schatz from the USA. And these are the trials, the stress and the Benestent trial, which showed that stenting was superior to carrying out a plain balloon angioplasty. One of the problems that remained with the balloon angioplasty was restenosis, and also it continued with the bare metal stent. So subsequently we developed what is called as the drug-eluting stents, and the drug-eluting stents of the current generation give very low restenosis rates. Various methods were thought what could solve the problem of restenosis. Brachytherapy, that is giving radiations to the localized site, use of the anti-proliferative drugs which we continue to use, and that is the part and parcel of the drug-eluting stents to solve the problem of the restenosis. I shall skip this. This is a whole lot of stents which are available in the market, and probably this slide may not cover all of them. There are many more, and each day some new company comes in with a new stent with a slight modification. Regarding the wires, initially the wire was a small piece attached to the balloon, and ultimately the wire was developed which could pass through the lumen of the balloon catheter. So these are technical things which have been developed. Wide variety of wires. Again over here you can see that so many kinds of wires are available to us to carry out the angioplasty. This was not enough. People wanted to see what they are doing during angioplasty is adequate or inadequate. And this is what is called as imaging. So you are literally peeping into the artery by calling it imaging. And we have two such techniques, intravascular ultrasound technique and ocular coherence tomography techniques. So IVUS and OCT, these are the two techniques which are currently in practice, by which we look at the morphological plaque we look at the stent and we assure ourselves that I have modified the plaque, I have stented it adequately, and also look at that there are no complications of the angioplasty procedures. Should there be calcium? This is a handy device called as rotablator or rotational atherectomy, where we debulk the area. And the latest to be added in the armamentarium is the laser angioplasty and the lithotripsy. These are the two new devices which are used. The laser evaporates the part of the plaque, makes it soft and supple so that the stent can be implanted very easily. Earlier, we used to have a lot of complications. So when we had complications, we had to depend on the surgeon to carry out urgent bypass surgery. The rates were more than 5%. Today, the emergency CABG surgery is required in less than 0.5% of the patients. So the procedure is not only safe, it is effective, and it is lasting. Of course, all our stents are metallic stents, but in between, there was an era where the Abbott company introduced a plastic stent which was absorbable. So you can imagine that I put a stent in the artery, and within 1 year that artery will have no stent, all material is gone. So that would improve the vasomotion of the artery, the blood flow of the artery, and you don't have to give blood thinners to the patient. But unfortunately, trial-wise this failed, therefore these stents are withdrawn. Sorry for the interruption. This is now going back to the electrical system. You just heard Dr. Saab talk about the VPCs. So this is how the recordings have been carried out by the EP people. Understanding the heart blocks, Morgagni, Adams, and Stokes, so-called Stokes-Adams, they recorded the ECGs to be known as bradycardia or complete heart block ECGs, Stokes-Adams attacks. And the credit goes to Wenckebach in 1800 for describing the Wenckebach's blocks, which we recognize on the ECG. Of course, it was described by him even before the ECG was developed. Subsequently, cardiac pacemakers were developed for the bradycardias. I'll just run over it quickly. Dr. Lidwell from Australia is credited to the development of the first pacemaker in the 1900s. And the pacemaker was such a big thing. It was only an external pacemaker. Today we are using pacemakers which are implantable, which are just about 2 coins of 1 rupee fixed to each other, weighing 20 grams only. So this was varying in kilos and kilos. So that was the external pacemaker which we still continue to use in the ICU, which was attached to a cardiac surgery patient having bradycardia. This is the implantable pacemaker which was used first. In fact, I have myself started doing the pacemaker. It used to weigh 80 grams. Today I am using pacemakers which are 1/4 the size. The pacemaker which was weighing 80 grams used to last 5 or 6 years. Today, the 20-gram pacemaker gives you a life of almost 15 years. So the technology has kept pace. Side by side, there was development of the defibrillator, very important equipment in the 60s, which was life-saving, which we still continue to use. Not only that, the defibrillator has now been miniaturized to an implantable defibrillator. You just heard Dr. Saab talking of R-on-T phenomenon causing ventricular fibrillation. If you treat the patient with the ICD device, such a person will not die, and there will be an automatic diagnosis and shock given by the device. These are the various trials of that. We shall not go through it. This is the biventricular pacing, which is used, what we call as a CRT, various trials with that. And then sometimes we do what is called as the ablation therapy, patients having ectopic beats, patients having AV nodal tracts. We burn those tracts so that the patient's arrhythmia problems can be solved forever. So this is the pacemaker that I'm using today, which weighs hardly about 20 to 25 grams, and it has a long life. It's a pacemaker. Even a CRT has a life of almost about 8 years or so. I'll just hurry up with the next few slides. Side by side, cardiology has seen the development of valvular therapy also. So the first valve to be dilated was mitral commissurotomy done by the surgeons using the finger, followed by the Tubbs dilator, and subsequently with the balloon that we are doing nowadays. Nobody does surgical valvotomies these days. Grunzig is also credited to carrying out a peripheral intervention that is in the renal artery. The holes of the heart have now routinely closed by the cardiologists, not by the surgeons. These are some of the earlier devices called as the Rashkin's device. Across the hole, that is the ASD, VSD, etc., you place this device and the patient is virtually cured. Not only symptomatically relieved, this is one of the latest devices which are used, the Amplatz devices. These are the devices which we use currently in practice. And then coming to what is the latest is the development of what we call the transcatheter aortic valve replacement, or the TAVR as we call it. So elderly people with the degenerative aortic stenosis are a high risk for surgery. So they are taken up for these procedures, which have a mortality rate of hardly about 1% or so, and people are living a comfortable life thereafter. This is the man who carried out the first TAVR or TAVR or TAVI as we call it, and the patient did very well. He had aortic stenosis. Many a times we have a case of aortic stenosis and we have a dilemma whether to operate him with the surgical valve or to give him a percutaneous valve. So that will depend upon the comorbidities, the LV function, etc. LV function is very poor. The patient has multiple comorbidities related to the lung, related to the kidney. Your operative risk will be very high, because you are going to cut open the chest, you are going to give him anesthesia, you are going to put him on the ventilator, etc., etc. In such cases, TAVI comes very handy. And now it is almost 15 years of experience that people have that TAVR or TAVI as it is called. It's slowly gaining popularity. So this is the patient. You can see he is sitting up very well and enjoying his drink. This is one of the kinds of the valve that is used, a self-expanding valve in the TAVI. And now it has got an FDA approval also. These are the various valves which are available in the world market which can be used. Similarly now, there is a treatment for mitral regurgitation using what is called as the mitral clips, and also percutaneous mitral valvuloplasty is carried out. Those who have got a tendency to embolize again and again and develop strokes and peripheral complications due to clot in the left atrial appendage can be fixed up using a device, and the patient can be free from anticoagulant. So we call that as LA appendage closure devices. In the heart failure, I'll skip over this. You want me to end over here, Narasimha? Intervention part is over. Side by side, medical therapy has also kept pace. I will not rush into that because it's a big topic by itself. And the patients who were hopeless cases, particularly in heart failure, in case of refractory angina, difficult to control hypertension, the drug therapy has advanced so much that we hardly ever say that we cannot control this in the patients. The antiplatelet therapy, use of the statins, use of the anticoagulants, the thrombolytic therapy, where you're in an area where there is no possibility of doing a PAMI, you can use thrombolytic agents like streptokinase. Lipid lowering therapy with the help of the statins and now with the PCSK9 so that the cholesterol should be lowered. Mechanical support to the ventricle with the help of IABP, and now we have devices called as LVAD. Side-by-side cardiac imaging with the help of the PET scan, CT scan, MRIs. Increasingly, we are using more and more of the CT scans and MRI in cardiology practice also. Thank you very much for your patient hearing.
Thank you, sir. This is an oration.
Yes.
And hence, no questions.
No questions.
Yes.
No, but if there are any doubts, I'll be happy to clarify.
I take the liberty. If there are any questions for anybody, please ask. You have seen the entire 50 years of advance, and I was one of the lucky person to see the entire development. Professor is another example, lucky. And we were trained under Professor A.B. Shetty. What else you want? We have seen the latest developments. Thank you once again, sir, for giving us the bird's eye view of the 50 years of development in the field of cardiology. Now over to Professor Ramesh Pai and other people.
Good morning, sir. It was a very lucid talk. I would like to, as an old student of Professor A.V. Shetty, I would like to say some things about him. He was one of the pioneers in Mangaluru, did the first catheterization, cardiac cath. He was the person responsible for first open heart surgery. And I would call that era between 1955 and maybe up to 1995. We had three great cardiologists in the department. First one was to come from Bombay, Dr. K.P. Ganesan, who was my mentor, my teacher, my guide, and he was the head of the department. Then entered Professor A.V. Shetty in 1965. Great teacher. We loved him. And he called a spade in all aspects of life. Straightforward, upright. Teaching was his passion. And I would like to have one photograph. Could you put that one photograph on the slide screen, please? Old photographs. Just like the Guy's Hospital, London, had three great guys, Bright, Addison, and Hodgkins, between the era of 1790 and 1860. We had three great guys in our department, Dr. K.P. Ganesan, Dr. A.V. Shetty, and Dr. B.I. Megde. All three practiced cardiologists. This is the man. This is the man. He would start our clinics around 12:30 in the afternoon, would go on till 2 o'clock. He didn't bother about his practice, didn't bother about the running there. And this is the department which shows all the stalwarts there. First, Dr. Shankar Bhatt, Dr. K.R. Shetty, neurologist, Dr. Keshav Pai, Dr. Ganesan, and Dr. A.V. Shetty, along with postgraduates and students. So we had a fantastic time, fantastic teachers, and we are what we are today because they taught us. I humbly bow down to Dr. A.V. Shetty and other teachers that in the middle, Dr. Keshav Pai, he was also a fantastic teacher, a very knowledgeable person, very widely read, topper in FRFPS and DTM in London, gold medalist. One anecdote about him I would like to add here, that he received a letter from the Royal College of London saying that if he has to keep the degrees, he has to pay £25 every year. He sent back the degrees and said, "You keep it, I don't want to pay £25, I am practicing." So those were our teachers. They were supportive, helped us grow, not only in the department, but also human beings outside. Thank you, sir, for your nice talk.
I am also privileged to have been with Dr. A.V. Shetty on 3 occasions as co-examiners. So I know a little bit about him.
Yeah, I think even I would like to bow to Professor A.V. Shetty, who was my mentor, I would say. The cardiology that he has taught us is still in our minds, and we pass it on to our students. Because clinical cardiology was taught by him as if it's a picture. It was a movie. Like we could get into the heart and see how circulation was happening. Yes. That was Professor A.V. Shetty, and he made it so simple. Anything you take, he said, what is there? This is very simple. The most complex congenital heart disease, he would make it very simple. So that was Professor A.V. Shetty. On 15th of August, every year we do remember him. Even, I think, just few days back, I remembered him a lot because he was born on 15th of August. And Professor did full justice to Dr. A.V. Shetty oration because even Professor Shetty saw cardiology in its infancy to what is happening today. I remember I still had preserved their first ECGs that they had taken, which Ganeshan had preserved. They had brought some bits and pieces of ECG machine from Bombay, and they had recorded together the first few ECGs. I had preserved it in the Department of Medicine.
I must congratulate the speaker, Dr. Bansal, for having gone through the evolution of cardiology. I still remember as a student when the ECG was being done in KMC Hubli and the patient being tied to the bed for 3 weeks, only pethidine, Phenergan, and sometimes oxygen, no aspirin even. And to the days where in Varanasi, I saw the first echocardiogram, M mode, which was being traced on the revolving drum. That was the day of early echocardiogram, and from to the modern days of 2D, even 3D echo, the intervention cardiology and all. And with regards to Dr. A.V. Shetty, I am not his student, but I had the occasion, several occasions to consult him over the phone or personally for complex cardiology problems which I used to face in the periphery. I would call him and get a solution, instant solution for all the problems which we faced in the periphery. I congratulate the present speaker and Dr. A.V. Shetty for all the work they have done in cardiology. Thank you so much.
Thank you, sir, for taking us through the journey of the world of cardiology.
Thank you so much, all of you all.
I now humbly request Dr. H.S. Balal to commemorate Dr. Narendra Bansal. Thank you, sir. I now invite Dr. Dilip Naik, Pro Vice Chancellor Mahe, to comment our moderators, Dr. Aril Kamath and Dr. Ramesh Bhai. Now I invite Dr. Unikrishnan, Dean of KMC Mangalore, to felicitate Dr. Prabha Adhikari. I also invite Dr. Shyam to be felicitated by Dr. Dean Unikrishnan, sir. Thank you, dear distinguished guests. We now move on to the inaugural ceremony. We have gathered here today to mark a significant milestone in the Department of Cardiology, KMC Mangalore. We celebrate 50 years of the department and 20 years of interventional services by the department. As we commence this event, let us all join together for a moment of prayer. I call upon Mr. Pratham to recite the prayer.
Krishna ni begane baro Shri Krishna ni begane baro begane baro Mukhavanne toro begane baro Mukhavanne toro begane baro Mukhavanne toro Krishna ni begane baro ತಾಯಿಗೆ ಬಾಯಲ್ಲಿ ಜಗವನ್ನು ತೋರಿದ ತಾಯಿಗೆ ಬಾಯಲ್ಲಿ ಜಗವನ್ನು ತೋರಿದ ಕೃಷ್ಣ 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 ತಾಯಿಗೆ ಬಾಯಲ್ಲಿ ಜಗವನ್ನು ತೋರಿದ ಜಗದೋದ್ಧಾರಕ ನಮ್ಮ ಜಗದೋದ್ಧಾರಕ ನಮ್ಮ ಉಡುಪಿ ಶ್ರೀ ಕೃಷ್ಣ ಕೃಷ್ಣ ನೀ ಬೇಗನೆ ಬಾರೋ ಶ್ರೀ ಕೃಷ್ಣ ನೀ ಬೇಗನೆ ಬಾರೋ.
I now cordially invite the Head of Department of Cardiology, KMC Mangalore, Dr. Narsimpai, to address this august audience.
गुड मॉर्निंग. ज्ञान से बड़ा कोई दान नहीं, ज्ञान के बिना कोई सम्मान नहीं, गुरु ही जीवन का आधार है और गुरु के बिना कोई ज्ञान नहीं. I bow my head again to the revered teachers who have made cardiology what it is today. It was a humble beginning way back in the year 1972 when Professor Dr. K.R. Shetty and Dr. A.V. Shetty started the Medical Relief Society in Government Venlock Hospital, where they had an inception of doing something for cardiac diseases. Now looking back, it was the foundation stone which was laid for beginning of the cardiology department, what it is today at KMC Ambedkar Circle. Honorable chief guest of today's function, Professor Dr. H.S. Ballal, who has been more a Mangalorean than a Manipalian. If Dr. T.M.A. Pai and Dr. Ramdas Pai can be called Brahma of the present Manipal, I call Dr. H.S. Ballal as the Vishnu, because he has been the person who has seen, nurtured all the doctors who are there in Mangalore to see what they are in today's shape. I am extremely delighted that today, when we celebrate 50 years of cardiology services at our government Venlock Hospital and 20 years of interventional services at KMC Ambedkar Circle, I just could not think of anyone else but Professor Dr. H.S. Ballal. I was scared to call him because I know that it's difficult for him to travel from Manipal to Mangalore, but I thought that I will try my luck. Never has he declined any invitation to come to Mangalore for any function, and extremely obliged on behalf of the department to have you this noon today, sir. It has really made today's function meaningful because of your presence. I also thank Dr. Dilip Naik, Pro Vice Chancellor, Mangalore campus, Dr. Unni Krishnan sir, who had repeatedly told me in college council meetings, please do not keep any function on Sunday, but I'm sorry I had to violate you this occasion and I had to force you to come on a Sunday to be a part of this function. But I'm deeply obliged that all of you have made it. When we decided that we need to do something to mark the 20 years of interventional cardiology, my mind went back to cherish those people who have worked in very difficult circumstances to see that the beginning of cardiology took place at Venlock Hospital. When I spoke to Madam Shetty and Professor Al Kamath, both of them shared the distress and the troubles that they had to work and begin cardiology services. Dr. R.L. Kamath, who was heading the department, was the first qualified DM cardiologist in the state of Karnataka. And it is fortunate that he has laid down his entire career for the well-being of Kasturba Medical College. It's 40 years. It's not common for somebody to work at one place for continuous 40 years. Dr. Mukund, who was the assistant to Dr. A.V. Shetty right from 1976, who then went on to complete his DM in Manipal from 86 to 88 and served Venlock Hospital till 2005. So I welcome Dr. Mukund sir, who is also here today, and Dr. A.V. Shetty is no more with us. But all of us have been benefited by his teaching, his blessings, his encouragement, and his guidance. So I couldn't think of a more apt occasion to felicitate these three teachers who have meant everything to cardiology. Dr. H.S. Ballal was also instrumental, along with Rajan Padukone, to start the interventional cardiology services at KMC Ambedkar Circle. And on that note, also it makes meaning to have sir here to celebrate the 2 decades of interventional cardiology practice at KMC Ambedkar Circle. It was Dr. Yusuf, I place on record, and Dr. Venkatesh from Bangalore who started the cardiology services way back in 2003. And today we are a big team. We are a formidable team of 6 cardiologists, the only electrophysiologist in coastal Karnataka, that is Dr. Manish. We have a big team of 4 surgeons. We have 2 cath labs. We have more than 100 staff members. We have started the cardiovascular technology course. And it is a moment of pride for me today to say that 20 DNB students have passed through the portals of our institution. It is really heartening to know for a teacher that your students have done exceedingly well, and 5 of the people who have passed from our institute are entrepreneurs. I mean, they have begun their own setup in the cardiology field. So with this note, I welcome the guests again, and let us get to the core of today's business. जिंदगी की असली उड़ान अभी बाकी है, जिंदगी की कई इम्तिहान अभी बाकी है, अभी तो नापी है मुट्ठी भर ज़मीन हमने, अभी तो सारा आसमान बाकी है. With that note, I will end my talk and we will go on to the felicitations. Thank you.
Now, I request our distinguished guests, Professor H.S. Ballal, Pro-Chancellor Mahe, Dr. Dilip G. Naik, Pro-Vice Chancellor Mahe, Dr. Unnikrishnan, Dean of KMC Mangalore, to come forward and join us for the lamp lighting ceremony. As they light the lamps, let it signify the illumination of our path towards medical excellence. I also invite Mr. Sagir Siddiqui, Regional Chief Operating Officer, KMC Hospital, Ambedkar Circle, Mangalore, to come forward for the lamp lighting ceremony. I also invite Dr. Alil Kamath sir for the ceremony, please.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय
Thank you, dear revered guests. I now cordially invite Mrs. Chandralekha Shetty to accept a humble token of gratitude in loving memory of Dr. A.V. Shetty for his revered commitments towards healthcare and society. I call upon Professor H.S. Balal, Dr. Dilip Naik, and Dr. Unikrishnan to felicitate her on this occasion. On this momentous occasion, we would also like to felicitate our dear Dr. R.L. Kamath, sir. Sir, it is an honor and pleasure to felicitate you. You have been an astute physician, a great cardiologist, a scholar, a leader, and most importantly, a teacher of teachers. You have been inspirational for many generations of doctors in your long clinical and academic career of 40 years at Mahe. Your passion and kindness have been a boon to the society. Your service to the needy in the community as a cardiologist in Government Venlock Hospital is commendable. You are a brilliant example of the sort of leadership we are supposed to embody now and in the future. You leave behind your legacy in all the medical students, doctors, and cardiologists of Kasturba Medical College, Mangalore. Words are certainly not enough to express our gratitude for how responsive, dynamic, and supportive you have been during these times. On behalf of all the doctors, staff, and management, we would like to thank you for your guidance, leadership, dedication, commitment to the Institute and to the community at large. We invite Mr. Sagir Siddiqui onto the dais, please, to be a part of this ceremony. We also humbly invite Dr. Mukund. He took his undergraduation from Mysore Medical College. Subsequently, in the year 1974, he took his MD in KMC Manipal. He then became an assistant professor in the Department of Medicine and worked under Dr. A.V. Shetty as his assistant. He then went on to do DM Cardiology in the years 1988 under Dr. S.G.S. Prabhu, and he has been a visionary in the field of cardiology. Thank you so much, sir, for your contributions. I humbly request our Honorable Chief Guest, Professor H.S. Balal, Pro-Chancellor, to speak a few words to this esteemed gathering.
Few words, is it, MC? Because you don't want me to speak for long. The head of the Department of Cardiology of Kasturba Medical College, Mangalore, Dr. Narsim Pai, whom I know for a very long period of time, Padmanabh Kamath and other team members of Cardiology Department of Kasturba Medical College, Mangalore. As a matter of fact, coming to Mangalore is like homecoming for me because I served in Mangalore for more than 30 years, prime time of my life, you know. I strongly feel whatever achievements I have made in my life so far is definitely due to my long association with Kasturba Medical College, Mangalore. I always say that repeatedly. So when Narsim Pai told me that they are organizing this CME in cardiology, 50th year, Golden Jubilee year, and also 20th year of interventional cardiology at KMC Ambedkar Circle, I readily said I will come. Though it is a Sunday, you know, it's difficult to come on Sunday because family pressure will be there. Why is smiling at me? And also, I was told that our illustrious cardiologist from Mumbai, Professor Bansal, is delivering the memorial, A.V. Shetty Memorial Oration. A.V. Shetty, as was told earlier, was a very respectable cardiologist here in Mangalore. If at all cardiology has any foundation or anything, is because of Dr. A.V. Shetty. I was told he was a very good teacher, extremely good teacher. My brother Sudarshan Balal always used to say, I have never seen a teacher like Dr. A.V. Shetty, especially in cardiology. He makes it so simple and understandable. That was A.V. Shetty. I knew him from very close quarters, and of course his wife is here, Chandralekha Shetty. We knew each other because, as I told you earlier, I was in Mangalore for a long period of time. As Narsim said, in 1972, Dr. K.R. Shetty, he was responsible for this Mangalore Medical Relief Society and started the super specialities in Mangalore. That concept was not there at all. They started neurology, neurosurgery, cardiology, cardiothoracic surgery. S.R. Ullal was there at that time. So this was started. Dr. Ariga was the medical superintendent or DMO of Government Venlock Hospital. So it started and it took shape so that the concept of super speciality or subspeciality came into existence at that time. And they promoted it. All these were people of very high caliber in their respective fields. A.V. Shetty in particular, as I told you, was a very practical cardiologist, very much liked by everyone. And I had a long association with him because Chandralekha Shetty and her sister, Amrita is a very close friend of my wife. So we knew each other. And when Narsim said, you must come, because any KMC Mangalore function, I normally don't miss if I am invited, as I told you earlier, because of my long association. And Kasturba Medical College, it started as a single college in 1953 by our founder, the late Dr. T.M.A. Pai. Later, it became two separate colleges. When it started, only the basic sciences was held in Manipal because we didn't have a hospital at that time. But clinical specialties, that is 3.5 years of MBBS course plus 1 year internship used to happen in Mangalore. So it started as one college and later it is separated into two in the late 1970s. And Kasturba Medical College, Manipal and Mangalore are the flagships of our university, MAHE. MAHE is an institution of eminence, a reputed university as all of you know, but Kasturba Medical College, Mangalore is considered as the flagship of our university, which we hold in very high esteem. And that is because, you know, today ours was the 29th medical college to be started in 1953, first self-financing medical college in the private sector, other than missionaries. And today we have more than 700 medical colleges in this country, 707 to be exact. And I am very happy and proud to say that KMC Manipal is consistently ranked within the top 10 medical colleges and Mangalore within the top 20 medical colleges. See, I always say reaching the top is difficult, but to remain in that position is still difficult. And basically that we strongly feel is because of the quality of the faculty, like Dr. A.V. Shetty and others, Dr. K.P. Ganesan, who were there in the past, who were of very high caliber. Because of them, this institution has reached such top heights. I always say reaching the top is difficult, but to remain in that position is still more difficult. But we have been able to do that basically because of the quality of teachers that we had in the past, and we have. Prabhadikari also was one of our faculty in the Department of Medicine in the past for a very long period of time. Her husband, a pathologist of great repute, and also was the Dean of KMC Mangalore. So all these people I consider are responsible for the reputation, the name and the fame that Kasturba Medical College has got, both Manipal as well as Mangalore. Cardiology is a very strong department of both Manipal and Mangalore. And basically because of Narsim Pai, Padmanabh Kamath and other people who are responsible for building this name and also reaching it to the zenith. And this year being the Golden Jubilee, 50th year, is an important milestone, and 20th year of interventional cardiology. So I congratulate the Department of Cardiology, KMC Mangalore, for taking this initiative of organizing this very important event. Because continuing medical education is very important. All of us, because they say learning is a continuous process. Mahatma Gandhi has said, you live as if you are going to die tomorrow, but you learn as if you are going to live forever. Live as if you are going to die tomorrow, learn as if you are going to live forever. And also, continuous learning is very important because today science and technology is advancing at such a rapid pace. Unless you keep pace with what's happening in your respective areas of specialty, you will not be respected by anybody. Not even your peers or even students. That's the reason you have to update yourself. How you can update yourself? Not by reading textbooks or even journals are outdated. By attending these CMEs, continuing medical education programs, you can update yourself. So I take this opportunity to congratulate Narsim Pai and his team for organizing this event, where interventional radiology is a very, very important event. And not only that, heart people, cardiology people, means people, nimge salpa heart problem, they'll get scared. So you are very important. You should not scare them because already people with the, cardiac problems will have a weak heart, they say, in the layman's term, So you have to treat them properly, compassionately, and for that, updating yourself with the recent advances is very important because by that you can provide the patients with the latest and the best possible medical care. And you should see that it is provided at the affordable cost because in our country a lot of people are below the poverty line. They should not be denied these facilities. So with these few words, ladies and gentlemen, I wish this CME, continuing medical education program, every success, and I thank the head of the Department of Cardiology of KMC Mangalore, Narsim Pai, for inviting me to be part of this event. And also, I'm very happy that I could participate in the Dr. A.V. Shetty Memorial Oration. Congratulations to you, Narsim, and your team. And I wish the CME every success. Thank you very much for the opportunity.
Thank you, sir, for those lovely words and also for taking the time out of your busy schedule to be a part of the celebration. I invite Dr. Narsim Pai to hand over a small token of gratitude to Professor H.S. Balal. I also invite Dr. Padmanabh Kamath, sir, to commemorate Dr. Dalip Nayak. I also invite Dr. M.N. Bhatt to commend Dr. Unikrishnan, Dean of KMC Mangalore. I also call upon Dr. Manish Rai to commemorate Mr. Sagir Siddiq, Regional Chief Operating Officer of KMC Hospital Ambedkar Circle. On behalf of Dr. Manish Rai, I invite Dr. Narsim Pai to hand over the token of appreciation to him. Thank you to all our revered dignitaries for joining us in this momentous occasion. We now invite everyone gathered here to break for lunch.
Regarding that quiz thing, please come to this thing.
Anyone who is willing to
For the postgraduate quiz. Attention all the postgraduate The session will begin now. The topic of the next session is the utility of imaging in coronary intervention. I would like to invite the speaker of the next session, Dr. B. Girish Navasundi, to the dais to speak about the topic, please. Dr. Girish Navasundi is a senior interventional cardiologist in Apollo Hospital, Bangalore. Dr. Navasundi is a proud alumni of JSS Medical College and JNMC Belgaum. Dr. Navasundi has many feathers to his cap, a few of them being the first cardiologist to implant a bioabsorbable scaffold stent in the private sector in Karnataka, and he's also the first to implant an MRI conditional AICD in Karnataka. His area of special expertise includes image-guided optimization of angioplasty with OCT and IVUS, TAVI, and AICD. Dr. Navasundi is also active in the field of research and has published many papers in index journals. Thank you, sir. Now, I would like to invite the moderator of the session, Dr. Tom Devasya, to kindly take a seat. Dr. Devasya is a professor in the Department of Cardiology, KMC Hospital, Manipal. Thank you, sir. Now, I would like to invite the honorable chairpersons of the sessions to have a seat. Dr. M.N. Bhatt, Consultant Cardiologist, Kasturba Medical College, Mangalore. Dr. Jostol Pinto, Consultant Cardiologist, Father Muller's Hospital, Mangalore. Dr. Krishna Shetty, Consultant Cardiologist, Yenapoya Hospital, Mangalore. Thank you, sir.
Thank you all, and it is nice to be back with you all, and we are starting the afternoon session with a great speaker, Dr. Girish Navasundi, who is the director of Apollo Hospital, Bangalore, a great friend of mine, wonderful, highly skilled operator, great speaker, and above all, a great human being. We know that present-day interventional cardiology is incomplete without the use of additional imaging facilities, because we get better idea, better knowledge about the lesions we are going to tackle, the anatomy, and we have a picture in our mind as to what kind of strategy we would be following to tackle the lesion and have a good immediate and late outcome. Dr. Navasundi is an expert in both all forms of imaging, including intravascular ultrasound and OCT. So let us hear from the master what he is going to explain to us. Welcome you.
Thank you. Thank you, Dr. Tom, for that very sweet and kind introduction. And at the outset, I would like to acknowledge and humble appreciation for a great institution like KMC Mangalore to have concluded 20 years of interventional cardiology practice. You've been a beacon of education for the region. And my dear chairpersons, Dr. Shetty and Bhatt, I'm very glad to share this podium with you and a lot of dear friends in the audience. Today, the commonest disease that causes morbidity and mortality is cardiovascular disease. And we have moved in terms of diagnosis from non-invasive tests such as ECGs, echocardiograms, stress ECGs, to more invasive diagnosis. When it comes to coronary artery disease, the gold standard for diagnosis has always been a coronary angiogram. But angiogram has always been a luminogram. That would just tell you how much area is available for blood flow, but it did not speak anything about what is causing that obstruction. So when you treat coronary artery disease, you don't treat the lumen, but you treat the disease in the wall, which is called a plaque, atherosclerosis. We all know that. As we have progressed in treating other diseases, such as diseases of the spine and brain, moving on from X-rays to CT scans and MRI, today we have diagnostic imaging tools very precise in giving you more comprehensive idea about the pathology, which will help you to treat the disease process, not just the lumen. So to begin, I will speak on why do I need to image? I already have great results by doing an angioplasty through angiogram, what I have been doing for decades. Why should I image? I think that's the first question most cardiologists and physicians ask us. So let me just tell you why image is important. When you do an imaging for the interventionalist, you need to look inside the vessel. That's why it's called intravascular imaging. What it helps is first to understand what the disease is. That's called pre-intervention assessment. Then, while you're doing the procedure, that is intra-procedure, you will understand how to deploy the stent. Then you realize, after you deployed the stent, what are the complications that could have happened in the vessel? Can I have the precise outcome details? That would be visible much better on intravascular imaging. So when you come to pre-intervention assessment, you can look at the plaque composition, whether it is fat, whether it's a fibrotic tissue or a calcium, which it could be a combination or isolated. When you implant a stent, and also you identify the reference segments, means where the disease begins, where the disease ends, so that how long do I need to cover with the help of this scaffold called stent. And then also choose the diameter of the vessel better than what is just visible on angiography. These are the pre-intervention assessment that imaging will help you with. And then comes during implantation, you deploy the stent normal to normal so that you don't land up in a diseased segment. You want a very healthy segment. I'll show you some videos. And then you also want to determine the expansion. Means if the vessel is 3 millimeter, if I use a 2.75 millimeter diameter stent, you would get under expanded stent, or the mean stent area is going to be much smaller. So once you image, you have precise information about what is the diameter of the stent and length of the stent. Post-stenting, some complications can happen which can worsen the outcome or increase the event rates post-procedure. What are these problems? The stent could be malapposed, means it is one part of the stent is floating, not touching the wall of the artery. That's called malapposition. Then there could be tissue prolapse. That means if there is a lot of shaggy material like thrombus or a highly lipid-rich plaque, when you implant a stent, through the stent struts, tissue can come into the lumen called tissue protrusion. You also can identify one of the major problems that's called edge dissection. When you land the vessel in an unhealthy area which is diseased, when you inflate it, the media may get injured, cause dissection. Media will get torn between the end of the stent and the non-stented segment. Or you could have a reference segment disease. That means an area where you have landed the stent still has high amount of lipid that can cause a restenosis of future events. All these can be understood even before you take your first balloon. That's why imaging gives you a much comprehensive idea of what you're dealing with. For example, what have you seen in angiogram is nothing like this. You have now two tools called an ultrasound-based imaging. It's called intravascular ultrasound, and the other one is based in the light. It's like a CT scan, what we call optical coherence tomography, OCT. These catheters are inside in the coronary artery. You can see that. That's the catheter. This is the catheter. They go inside the vessel and they take 360-degree images and come back while you pull back. And with this precision, they depict the vascular architecture. You can see here, this is the thin intima. We all know vasculature is triluminar. Innermost is the intima. And this is the interelastic media. And then you have the media, which is seen as dark circle. And then you have adventitia. You can see all three with the help of an ultrasound. But if you use light, it's much more precise. You can see here, this is the endothelium, which is a single cell layer. Beyond that is the internal elastic membrane. And beyond that is the external elastic membrane. Between them is the media. Once you understand that this is the healthy vessel, wherever that triluminal area is not there, you know there is disease, something like this. I'll show you. Now, when you put in a camera, you clearly understand from a normal to an abnormal vessel. Here you can see nice 3 luminal area. This is the intima, media, adventitia. But look at this area. From here to here, this is the intima, and between the internal elastic lamina and the external elastic lamina, the thickness has significantly increased. This is what the plaque is. And that plaque is pretty orange, bright orange. Anything that reflects light too much is like your nail tissue. We all know atherosclerosis begins as an inflammatory process filled with lipid particles. And these lipids, when they go through the media, intima and get settled in media, macrophages try to eat it up and become foam cells die and cause a lot of inflammation. It is initially very dark and lipid rich. When it is fully fat, it becomes dark like this. When it gets transferred into fibrotic area, it is bright. When you leave this fat and fibrous tissue for long, it hardens. It becomes like calcium, like your tooth or bone, when you can see it like this. Both the anterior edge of the pathology and the posterior edge, both are clearly visible. So with this precision, you can understand what is the disease in the wall, and this decides my strategy. If it is just simple fat, you don't have to pre-dilate the lesion, just stent. If you pre-dilate, you cause slow flow. If it is fibrotic lesion, then you need to cut this using cutting balloons, or we call, bladed balloons, or what we call wired balloons, which cut into the tissue, because by just expanding, it will expand but recoil. It is like nail. Unless you cut it, it will not become patulous. Your stent will expand and recoil. You need to break the integrity of this contiguous fibrous circle. And calcium looks like this. When you have thrombus, there are 2 kinds of thrombus. Red thrombus means which has been there for a while. Platelet, when it forms a thrombus, it is white. It is just white, because platelets don't have color. You can see both anterior and posterior border. This is called white thrombus. But when the thrombus starts getting more organized, it traps the RBCs and becomes red thrombus when the posterior margin cannot be seen. So you put in a OCT, you can differentiate between whether it's a fresh clot or has been there for a while. And then here we are putting a stent. How do we know there is a stent? You can see these dark lines, which are shadows of the metal struts. And there is tissue prolapsing inside the stent. So this will tell you that he will have slightly more events than a stent where there is no tissue prolapse. So all this greatly helps you to strategize your therapy. The same thing can also be seen on an intravascular ultrasound, but with much lesser clarity. You need to interpret it like an ultrasound. So the same thing, fibrous plaque looks like this. Here is the fibro fatty plaque, and then the calcium. You can see that. Similarly, you see that tissue prolapse here, white thrombus. I will play you a few cases. This 71 years old gentleman presented with shortness of breath on exertion 3 months, treadmill positive. Symptom used to relieve on rest. He's got a good LV function. So you can see on the angiography, when you look at it, in the LAD, this is called the left anterior descending artery, there is some haziness. It's very easy to estimate the severity and just put a stent. But you do not know what you are treating, where the disease is beginning, where is ending, where should I start my stent and where should I end. Just run an OCT. It goes through, can you see that white dot? It tells you at each point what is the disease that's happening. This is a live image. You can see the plaque here, getting into the lumen. This is the largest diameter is out here. This is all narrowed segments. And again, there's another plaque on the ostial side. Look at the diameter area, luminal area. See, there is a hematoma, already ruptured plaque and a hematoma. Now, that's the left main that's coming up. If I ask a couple of my colleagues here on the platform, how many would have how many would have just stented only the mid to distal versus would they have come to the ostium? Most would not have brought the stent to the ostium. But here if you see, in the proximal part of the LAD, proximal part of the LAD, there is a large intramural hematoma that's happened at this segment, which was not visible on an angiogram. That's why when we used to treat through angioplasty, then further cardiac events, 50% of the time are not related to the stented segment. Next, among all the myocardial infarction, 50% are not related to the treated segment from the other segment. Why? Because we fail to recognize that there is another ruptured plaque or an unstable plaque. See, you can see here, it's all hematoma and ruptured plaque. So I'll show you those segments again. Yes. You can see that there is a 180 degree calcium, but not too much. But you can see here there's a plaque rupture that has happened, entry point. Then there's an extension. I don't know. All these information, look at that thin, very thin cap. And that's where the ruptures are. So all this is, I will repeat that pre-run. You can see that once the plaque rupture begins, you can clearly see that's the tightest area. And that's where the stenosis is. Can you see with so much clarity? So you know how long to cover. So there's one stent covers from ostium of the left anterior descending artery till where disease ends. And you repeat the OCT, it'll clearly tell you very spherical lumen, not much significant plaque protrusion, no malapposition, no stent edges dissection. There's some mild plaque stent malapposition was there, but now it looks far better. But largely, you have covered. Now look at all of that. Can you do it for me? Okay. So this is how the final result looks. Had I not imaged this patient, I would have left him with vulnerability for another myocardial infarction in the proximal segment. Even an acute myocardial infarction who was thrombolized, you can still do an imaging. You can see here the same disease. The pre-OCT runs, I won't take too much time now. You can see that tightest lesion. You look at the plaque rupture. I hope you can appreciate the ruptured plaque there. And then you have two plaque ruptures, one after the other, not at the same site. And there's another area of rupture. There's an intimal tear and then plaque erosion. All were seen, and you knew that this was all very lipid rich, and this is how we could just take a direct stent and finish. But if it was fibrotic or calcified, if you do direct stenting, stent does not expand. The job of the stent is not to open the block. It is to scaffold, keep it open after you have broken the stenosis, created a large lumen. The duty of the stent is to keep the lumen scaffolded, pressed, and deliver drug. Most people think just implanting a stent would give you all the result. No, you have to modify the plaque, gain maximum lumen, then only implant the stent. And once you implant it, you optimize it by post-dilatation depending on what you see on an imaging. So this is how beautiful it looks in the end if you have understood and strategized. Now, the greatest challenge for cardiologist, interventional cardiologist, or what we call the graveyard, is calcium. We didn't have too many tools to treat and how to quantify the challenges that you would encounter while treating. Here you can see that there are three things that a cardiologist considers when it comes to calcium. Looking at the vessel, if the area subtended by the calcium, is it more than 180 degree, then we give it 2 points. And the thickness of the calcium, if it is more than 0.5 millimeter, you give it 1 point. And the length of the calcium, if it is more than 5 millimeter, you give 1 more point. As the number of points increases, the stent expansion or stent related problems go on increasing. If you have 4 points, then be sure that stent is not going to expand. You need to pre-treat very, very well. So that's why we have something called Schlosser OCT algorithm for managing calcified lesions. Here, you do an angiogram, then look at the algorithm I said, whether it's 1, 2, or 4, what is the amount of calcium that you would see. And look at the arc, whether it's more than 180 degrees thickness. Tightly? Yeah, thank you, okay. Look at the arc, whether it's more than 180, whether the thickness of the calcium from here to here, is it more than 0.5 millimeter? Arc is more than 180, and then look at the length of the vessel. If it is more than 5 millimeter, then you need to check whether the lesion can be crossed with a balloon, then use an intravascular lithotripsy. It's a new technology to treat calcified lesion. You all have heard of lithotripsy, which is an ultrasound created wave which breaks the stones, which has been used by urologists for a long time. Now the same technology is used in coronary arteries to break the integrity of calcium. If you cannot cross the balloon, then you use a rotablation atherectomy devices, either rotational or orbital atherectomy, and then go ahead. I'll just show you. So now, when you do image, you will realize that whether the calcium is deep calcium or very superficial calcium. Superficial calcium is amenable to atherectomy, but if it's deep-seated, it's not amenable, you need to use a lithotripsy. If the calcium is nodular, means not there in other segment, but it protrudes. It's like in a cave, icy cave, if you see the ice that comes from the, the ceiling of the cave. It's something like that. You can see here the nodular calcium, and on that side, there's an eruptive nodule. I'm sorry, this is the eruptive nodule. It's like a cone getting into it. It's the most difficult among the calcium to treat. If you don't clearly shave off this and don't expand, a stent cannot take this morphology, and there'll be underexpanded area, malopposed area, which is highly prone for stent thrombosis or restenosis. So exactly what you see on the pathology, you can see on an OCT. That's the beauty of imaging, which clearly tells you how to go forward. You can see precisely with intravascular imaging. That's a big nodule which is protruding inside. Again, this is a deeper calcium, you can see here, and that's a more superficial calcium. All that is for the understanding of the cardiologist. When you look at the thrombus, again, you can see a red thrombus where you can't see the away margins, but in a white thrombus, you can see on both sides. What is the influence of calcium on stent expansion? When you look at it, the rule of 5, I told you, more than 0.5 millimeter thickness, more than 5 millimeter in length, more than 50% of the vessel covered. As the points increases, you can see here, the chance of stent failure significantly increases. It doesn't give you a good expansion at all. Stent is not going to expand. You'll have a lot of events. Which are all tools available? CT angiogram, coronary angiogram is the least sensitive to detect coronary calcium, location of the calcium, whether it is, superficial, deep, length, nothing you can understand, and quantification of calcium is also not possible on coronary angiogram. So many places where there is imaging is not done for a calcified lesion, they would have high event rates and poor outcomes. CT scan is a good tool. IVUS, again, very nicely depicts, but it cannot quantify IVUS. But when you do an RF IVUS or an OCT, you get the maximum information regarding calcium. This is a 67 years old man, diabetic hypertensive. He had a stent to LAD in 2006, recently presented with severe epigastric burning. Strangely, TMT negative, very, very influential person. everybody is treating him for they thought gastric reflux, but unfortunately, this is what his angiogram shows. TMT is negative with this kind of a stenosis. And look at the amount of calcium that is even visible on an angiogram. How do you approach it? If you do anything less than imaging, you would be substandard in your outcome. The first, no imaging catheter could go inside. So firstly, it was rotablated, the whole length, and then you do the imaging. You realize that you choose the landing zone, widest portion with least disease, and then you start seeing the disease. Severely narrowed, long segment disease. At one point, it is very critical. I'm sorry, my pointer is not working. Now you can see it becomes very, very critical, subocclusive. This gentleman is TMT negative, and he is an ex-member of parliament. And people are scared to do unnecessary tests, and this is what it turns out to be. And we had to go back and analyze again, and had a strategy that unless you do road ablation and IVL, you're not going to get, because it's all circumferential calcium that he had. OCT, soon after IVL, just an intravascular lithotripsy balloon, look at the amount of dilatation you have, and so many fractures you will start seeing in the wall. Can you see that? Fractures are created by intravascular lithotripsy, and then you stent it, and after stent, you realize that there's another lesion proximal, and that did not yield. I'm sorry, I'll go back and show you. I'm sorry, my pointer is not working as good as I want. You can see here, although we have stented this segment, the proximal area is still narrow. So we had to go and use something called OPN. These balloons can go to pressures of 40-45 millimeters of 45 atmospheres to give you a grasp of it. In a car tire, the pressure is about 4 atmospheres. Here, we are inflating that balloon at 40 atmospheres, 10 times the pressure in your car tire. And this is how broad it becomes. And the gentleman is free of his gastric problems after so many years. He's done many favors to me. Thank you. So it's very important also to understand the reference, means from where to start, where to end. Angiography has a very, very limited information about where the normal segments are. Thank you. Where the normal segments are. Look at that. In a diffuse disease, diabetic people, elderly, you don't know where it begins, where it ends. How to choose a landing zone? You have to choose a landing zone where there is a triluminar artery is visible. If you land in an area like this, the chance of edge dissections, restenosis, and another acute coronary syndrome is going to be much higher. So this is why it's important to choose the right landing zone. Although both of them look broad. Here also it's broad, here also it's broad. But if I choose that area, if I choose the first area, I'll have more events compared to the second. So this is why imaging is so crucial. So measurements we use when you're implanting a stent, if you're using an IVUS, it gives you a slightly higher diameter. You can choose it. Between the media to media is what you use, mid-wall or a lumen. Lumen is the orange line, yellow line is the mid-wall. That what we use is actually a mid-wall. You should never cross the external elastic laminar diameters, otherwise you'll rupture. That's the information that we have. And our OCT and IVUS measurements the same. They both don't appear to be same. Look at angiogram shows the lumen to be this size. If you take the OCT external elastic lamina to external elastic lamina, it's almost similar. Lumen in IVUS is slightly larger. Now, why is it important? Whenever you stent and achieve a minimal stent area of 5.3 millimeters or lower from, these are the drug trials. The minute the minimum stent area falls down less than 5.3 millimeters square, event rates are significantly higher. You can see here. The event rates significantly go up. This can be calculated by stent areas. So now, I won't bore you too much. It's a very safe technology. Always deploy normal to normal. Between here and there, it doesn't look much different, but choose the most healthy region. And this is what expansion, what we call minimal stent area. More than 90% of the mean of the proximal and distal reference area has to be met. That's when you call it the lumen area. And then I come to the expansion limits. You see here the area. You see in the proximal the area. If you cross both of them, you add, and 90% of that if you can achieve, that's good enough for us. So determine your minimal stent area across proximal and distal references and then achieve that. This is the last case I'll show you. It's a post-bypass case. You have to do a very hard calcified lesion, do an ultrasound. Here we didn't use contrast at all. Many of them, when renal failure, patients are denied angioplasty because kidney function would worsen. Today we do zero contrast angioplasties. Maybe 5 ml for one final, because of medical legal issues, we need to give them an angiogram. But otherwise, everything can be done only on intravascular ultrasound, zero contrast. Okay, so the edge, I told you, you can have an intimal tear, you can have a medial tear. A big intramural hematoma. All these can be visualized. Why is it important? Dissections, which dissections need to be treated? If it's more than 60 degree in arc, more than 3 millimeter in length, or if there's an intramural hematoma or an inadequate minimum lumen area of less than 4.5 millimeter square, you need to treat them along with TIMI flows. Whether stent is completely opposing or not, you assess and then dilate them. You can see the tissue getting prolapsed inside the vessel. So now, I don't know when and when not to use an imaging, but these days, the patients in whom the risk of target vessel failure is the highest, means younger people, complex lesions, diffuse diseases, diabetic, end-stage renal disease, previous stent failures, comorbidity necessitating the use of bare metal stents, those who have hemophilia, then all those situations. What are the independent risk factors for stent failure? When you really look at it, if it's diabetes, about 16% higher chance versus CTO is just 5%, instant restenosis about 14%, but what is worse, a vessel of less than 2.5 millimeters is the highest risk of restenosis. So in these lesions, these days we avoid stents and use a cutting balloon followed by drug-eluting balloons. So eventually, when you image, in 57% of the cases, you will land up changing your decision about the length of the stent, diameter of the stent, pre-treatment of the plaque with rotablation, IVL or cutting balloon. And when you look at it, OCT identifies suboptimal features, means your stent has not been optimal in about 1/3 of the cases, 34% of them. And look at 12-month follow-up. What happens to death? Cardiac overall, that is all-cause mortality, cardiac death or MI, or cardiac death MI, or repeat revascularization. If you do with only angiogram, if the incidence is 6% for death, when you do OCT plus angiogram, it comes down to about 3%. So 50% reduction. This was published in European Heart Journal. You can see there in 2012. If you do it in cardiac death MI, everything gets halved if you do in this complex subset. The same in the, you can see here pre and post in the Optico study, which is a landmark trial for imaging, in 52% of the cases, OCT changed the decision post-angioplasty versus angiographic assessment. Means whether you had to post-dilate, was there a complication stent edge, you had to cover it. So when you look at intravascular imaging, it has role both pre-intervention and also for guiding the PCI and post-intervention. It can be used in ACS, it can be used in complex lesions, it can be used in choose the landing zones for stent length and stent diameters, and PCI optimization. That means if there is a malapposition, you need to expand, or a geographic miss, you have to put another stent to select a vulnerable plaque. What is a vulnerable plaque? Which is highly lipid rich and very thin cap. Then choose the reference segment. All these can be done with one intravascular imaging. And now I knew how I should have imagined, and my PCIs have become better even when I don't use, because the knowledge I've gained from imaging. Thank you, chairpersons and audience.
Thank you, Dr. Girish, for your wonderful and elaborate talk on imaging in PCI. So the take-home message for the young interventional cardiologists sitting here would be, do almost as close to 100% of your PCIs with an imaging modality, be it IVUS or OCT, based on the financial preference, your preference, and the availability of the IVUS or OCT. You can do that, but as far as possible, as close to 100%, please use an imaging to help you in the PCIs. I do 100% of my PCIs with an imaging, either an OCT, IVUS, or both. And I'm very sure all these expert and people who do complex procedures, including Girish and others sitting in the front here, they are all using maximum number of imaging modalities in their PCIs. So just for the understanding of the group sitting here, what are the situations where you would give preference of IVUS in your clinical setting to use, other than the financial considerations, and what are the situations you would say, okay, I'll do only OCT for this case? Can you just elaborate on that?
Great. I think you just have to get good at one, and you can treat 90% of the lesions. I think my center is predominantly an OCT center. It gives all the information that IVUS gives with much more clarity. But only challenge is contrast usage. And second one, the catheter, you cannot multiple users are slightly challenging. IVUS, the greatest strength is when you want to use zero contrast or minimum contrast. So I choose for those with increased creatinine, or what you call decreased GFR, IVUS becomes my preferred choice. But for everything else, it is OCT. And in about 40% of the cases, we do saline OCT. We don't even use 1 ml of contrast. And that gives you as much information as a contrast OCT. People say that left main interventions, which is area of diameter of more than 4.5 millimeters or 5 millimeters, difficult to visualize on OCT, preferable to use an IVUS. Yes, for a young operator, but somebody who's experienced, who can use the guide appropriately, coaxially positioned, you can get beautiful 5 millimeter diameter images also by OCT. For us, it's predominantly OCT. IVUS happens in CTOs, in decreased GFR, and if I want to use multi-vessels, there are 3 or 4 vessels that I'm going to image, I think IVUS becomes easy for me at that point in time.
Thank you very much. And for the Dr. Subramaniam, some question from your choice.
Mike, please.
Good afternoon. It was a wonderful presentation.
Thank you.
I have one information from you. Recently, in that Euro PCR, Illumin 4 data was published. And the results were not reached the expectations of all the interventionists. And you know the results. So what is your take-home message on that?
This is, the conflict at this point is like, if you use in all of them, are you going to get statistically significant benefits in terms of death and repeat revascularization. If you apply for type A lesions, I don't think you will get it. But the minute you are into type C lesions, anything you do without imaging, I think there are going to be higher event rates. Problem that happens is when we try and generalize the use for every case. But if you and me have to undergo an angiogram, even if it's a type A lesion, I'm sure I do not want to undergo without imaging. Because as I showed you, there are going to be lesions which are not visible on the angiogram. Second, as we all know at this point in time, compared to balloon angioplasty, stenting has not reduced the death rates or myocardial infarction rates, but it has improved quality of life and reduced repeat revascularization. To really get very hard endpoints, I think you need to study for much longer duration and be selective in what population you are applying that technology for. Currently, conclusively known that ultrasound IVUS guided angioplasties have consistently shown reduced mortality and morbidity in all the trials. Now we are trying to see whether IVUS matches OCT matches morbidity, mortality benefits of IVUS. I do not think that there should be a difference, but it will take time to see that outcome differences. But imaging is very crucial. No, that. Can we give the mic? Yeah. No, sir. It is like, I respect you, but a community like an Indian community, if we say something, it's because of cost, we are not doing the right thing. It is not acceptable in today's India. I mean, people buy a television worth 2 lakh rupees. And we are talking about an OCT which will cost 50,000 rupees. I don't know how much. I was 50,000 or 75,000, 1 lakh. How much are we charging? And this is a heart. And unfortunately, as investors into healthcare, when we can put in a cath lab, why can't we put in an IVUS and OCT along with it if I'm going to do that kind of a case? If I'm doing a left main bifurcation, if I'm going to do a very calcified lesion, how justified am I in just putting in a stent? What I meant to say is, it is the perspective of the operator and communicating with all the sincerity to my patients that I can definitely put a stent, no doubt. But do not expect me to give you global standard of outcome if I don't have imaging, if I don't have a rotablation, if I don't have all the tools, right? It's like telling a patient who has a myocardial infarction, I have technology for thrombolysis, I can't do an angioplasty. But if I'm doing an angioplasty, I think it's imperative that at least I have one imaging tool in my lab. So I would request all the cardiologists, physicians, general physicians to tell their patients that luminogram dependent PCI is inferior to image guided PCI in more than 50% of the patients. It's important that as a community we believe, transmit and invest into it because that's the right thing to do.
Thank you so much, sir, for the informative session. Now, I would like to invite Dr. K. Nityananda Chowta, Professor, Department of Medicine, KMC Mangaluru, to please hand a token of our appreciation to our honorable speaker, Dr. Devasya. Sorry. Dr. Girish. I would now like to invite Dr. Dinesha, Professor, Department of Medicine, KMC Mangaluru, to please hand a token of our appreciation to our honorable moderator and chairpersons. The moderator, Dr. Tom Devasya, Professor, Cardiology, KMC Hospital, Manipal. Chairperson, Dr. M.N. Bhatt, Consultant Cardiologist, KMC Mangaluru. Dr. Jostol Pinto, Consultant Cardiologist, Father Muller Hospital. And Dr. Krishna Shetty, Consultant Cardiologist, Yenaboya Hospital, Mangalore.
Okay. A very good afternoon, everyone. I hope everyone is enjoying the CME so far. The next topic for the session is minimal access surgery and recent advances. So for this session, I would like to invite Dr. Arul Furtado to the dais as the speaker of the session. This topic is one of his special interests, so he will be sharing his knowledge with us. Dr. Arul Furtado. Dr. Furtado is a consultant cardiac surgeon at the CMI hospitals in Bangalore. He's a KMC alumni and did both his undergraduation and post-graduation in general surgery from KMC Mangalore. He then went on to do a DA in Feb 2019. He's also a member of the European Board of Cardiothoracic Surgery. He did 3 fellowships in the USA in world-renowned hospitals across Boston, Atlanta. His special interests are off-pump CABG, minimal invasive cardiac surgery, robotic surgery, and heart transplantation, just to name a few. Dr. Furtado has 12 publications under him and is striving for greater success in the field of minimally invasive surgery. Now, I would like to invite Dr. Musa Kunni as the moderator for this session. Contribution to the field. He has been involved in more than 16,000 open heart surgeries, including many rare surgeries. Now, I would like to invite the honorable chairpersons for this session. Dr. Sidney D'Souza. He's a professor in medicine at Yenapoya Hospital, Mangalore, an alumnus of KMC Mangalore, and former HOD of medicine. Please welcome, sir. The next is Dr. Sadananda Nayak. He is a professor in medicine at Alva Hospital, Moodbidri. Please have a seat, sir. And Dr. Joe Verghese. He is a professor in medicine at Omega Hospitals, Bangalore. Welcome, sir.
Yeah, good afternoon, everyone. Thank you for the opportunity, and I would definitely like to thank the Department of Cardiology, KMC Mangalore, for getting me across over here. I would say it's nothing short of a privilege to come back to an institution that has given me so much, not just me. I think it's my brother too, who both of us have done our basic degree in KMC Mangalore, so also our masters in general surgery from KMC Mangalore, and what little we have achieved in life is thanks to this great institution. And also all the people in the Department of Cardiology, they've been near and dear to me, both in professional and personal ways, taking care of my family in various aspects. With that, I would like to start off with this talk of mine. So cardiac surgery is, more or less saturated. We have got a few basic operations in adult cardiac surgery, what we call as coronary artery bypass surgery, the CABG, valve repairs, replacements, ASDs, aortic surgery. So a few years back, I think we realized that we were not able to meet up with whatever the cardiologists are throwing at us, with all their fancy left main bifurcation stentings and TAVRs. So there became a concerted effort to try and make the surgery less invasive and much more appealing to the patient. Not just appealing, but enabling them to get back on their feet faster while offering the same advantage as conventional surgery. So with this, let me just start off. Like I said, cardiac surgery, adult cardiac surgery especially, has got four main divisions. One is the coronary artery bypass, or commonly called the cabbage, valve surgery, that's either the aortic valve or the mitral valve, adult AST closures, and aortic surgery. So coming to the most frequently performed operation, that's the coronary artery bypass surgery. And I think most of us in practice, either in the government sector or in the private sector, this happens to be our most common operation, the bypass surgery. And I would say that most of the world, bypass surgery is done via conventional stenotomy, and that holds true for about 95 to 97% of cases worldwide. There are certain instances where this can be performed using a minimal access approach. And what does this minimal access approach provide? So a regular bypass surgery involves a division of the sternal bone, and that itself takes about 2 to 3 months to fully heal. So that places some restrictions on the patient. So by avoiding a stenotomy and going through an incision on the left side of the chest in between the rib spaces, usually the 4th or the 5th intercostal space, the pain of the stenotomy is avoided, and the patient has a faster recovery, an earlier return to normal activity. There's also a lesser chance of infections. And the most important part is, especially in elderly patients, diabetics, and those with brittle bones, especially elderly females, high HbA1c, the risk of life-threatening mediastinitis is avoided. There's also been noticed the patients have been noticed to have less blood loss and a lesser transfusion requirement. So this is how the procedure looks. That's a soft tissue retractor, and that's a Lima LAD graft which has been performed. It's basically the same procedure which is performed from the side. When it comes to minimal access approaches, I think it would be prudent to talk about the conduits for harvest. Normally, when we harvest veins, you would have observed that the incision is one huge long line on the leg, starting from the medial malleolus, extending all the way to the thigh. Then there were approaches with bridge vessel harvesting, and finally we have endoscopic vessel harvest. That can be used both for the saphenous vein and for the radial artery harvest. So if you look at the second picture, my pointer is not strong enough anyhow. The one on the right shows the open radial artery harvest, and the one on the left shows 2 tiny cuts on the wrist, which is used for the endoscopic radial artery harvest. And this is one of our patients who has had an open artery harvest, coming back with a huge hypertrophic car or skeloid. Especially for women, those who are obese, diabetic, an endoscopic vein harvest prevents that big cut on the leg, and the risk of wound infection and that whole thing opening up is avoided. I have a quick video of how this is performed. This is the saphenous vein. We basically use a 5 millimeter telescope, create a tunnel, and go all around the vein. And then we use another dissector to hook the vein. And finally, we use a bipolar diathermy to burn the branches, take the vein out, and proceed with the bypass surgery. So that's how a vein harvest is performed. The one on the right is an endoscopic radial artery harvest. Same principle. We take the radial artery out with its 2 concomitant veins. And this is the much clearer thing. You hook the radial artery, use the bipolar diathermy to burn the branches, and then take it out through those 2 tiny stab incisions. Coming to, my topic is basically just videos. Coming to minimal access bypass surgery, that's the incision on the left side of the chest. We use a harmonic scalpel to harvest the left internal mammary artery. What you can see over there, the forceps holding with the left hand, harmonic scalpel. We don't ligate the branches or clip them because the harmonic scalpel automatically seals them. Once that is performed, we go ahead with the bypass grafting. And this is the same image, the Lima LAD performed, and the telescope will go all the way to the top and show you the entire length of the Lima. People often have doubts whether it's possible to perform a saphenous vein graft. So that's the aorta, that's a saphenous vein graft performed proximally on the aorta, Lima LAD performed, and the distal has been performed to the OM. That's usually more or less how the scar looks after surgery. One or two chest tubes, one on the left side of the chest, one in the middle, in the mediastinum. The caveat with this is, this is heavily scrutinized, and a lot of people ask us whether it's actually as good as the regular surgery. So, yes, it is as good, provided the patient has got a good ejection fraction, the target vessels are good, and we have got discrete stenosis. I mean, it's as good as the regular operation. So routinely, 2 or 3 bypasses can be routinely performed through this approach. Even a Lima and a Rima harvest, so also a radial artery with the top end onto the aorta can be performed through this approach. And most of the patients are discharged on the 4th or the 5th postoperative day. This is what cannot be performed through this procedure. Sometimes you see an angiogram with very bad coronary artery disease. I don't know whether it's very clear, but over there you would see that plaque along the entire LAD. And that is something which, if you see something on the angiogram, we just go with the conventional stenotomy. You would see the plaque over there. It's like, it's definitely an endarterectomy candidate. And for these patients, we would rather try and do a total arterial bypass, take a Lima, Rima, do a Y anastomosis, go all around. You would see the Lima going to the diagonal sequential, and then the LAD, and you take the Rima, go to the OM and to the PDA. So arterial grafting is what we routinely perform. Patients less than 60 years of age, if they are not bad diabetics, we look at the HbA1c. If it's less than about 8, we take the Lima, Rima out. If not, we use the radial artery and do a top end onto the aorta. We usually prefer not to do a Lima radial Y because of the size mismatch. That's our group's individual practice. We are very wary of doing a Y because the radial artery is about 4 millimeters, the Lima is 2 millimeters, the initial runoff is not great. So Lima, Rima, Y is done routinely, but we do the radial separately. Coming to valve surgery, I think nearly all valvular surgery and definitely secondary ASDs should be performed through a thoracotomy. Stenotomy can be avoided in most of these patients. What are the exceptions? Valve surgery with a need for a bypass grafting. Complex valvular surgery, you're looking at root enlargements, you're looking at multiple valvular surgery, and ASGs with very abnormal venous return, PAPVCs, HAPVCs, and those kind of things. How can an aortic valve replacement be performed? You have the full stenotomy, and for minimal access, you've got 2 other approaches, the upper hemistenotomy and the right anterior thoracotomy. The upper hemistenotomy is basically a partial stenotomy. If you look at the top over there, you see the full stenotomy incision being marked out, and that's about a 5 centimeter incision through which we go ahead and do that. That's basically you need to just see the aorta to perform an aortic valve replacement. Here we have implanted what we call as a rapid deployment valve. It's a Percival valve. It's just like a TAVR valve. You just debride the aortic valve, take out all the calcium, put the valve in, balloon it in place. So this is used sometimes in patients who are extremely high risk. We want to reduce the cross-clamp time. The procedure is done in about 20 minutes because we don't have to actually take sutures and tie down knots. So this is a Percival rapid deployment valve, basically the same principle as a TAVR valve, and that's the incision at the end of the surgery. Right anterior thoracotomy is an incision in the second intercostal space on the right side. That's basically us working through that space. And you see the cross-clamp over here on the top. the cardioplegia going there. That's the aorta. We just cut it over there, suture the valve back in place. So this is all good when we have the run-of-the-mill aortic valve replacement, but unfortunately what we've seen most in our practice is elderly females who come to us have a small aortic annulus. And a lot of us as surgeons have been guilty, even I've been particularly guilty of putting 19-size valves in these patients in their mid-60s, and they come back in about 10 years, and you're looking at a redo/a TAVR. And there was one particular valve, I think the trifecta, which has been withdrawn right now. The trifecta was giving us excellent gradients in small aortic annuli, but the problem with the trifecta valve is it's got externally mounted leaflets. You do a TAVR, it's just going to block off the coronaries. So you've got to do a basilica over there. And so what we have done right now recently for most of our patients is when we get patients with a small aortic annulus, about 19 millimeters, we enlarge it, put a size valve which is about 2 times larger. So this is very easy to do a root enlargement called a VY root enlargement, which gives us about 4 sizes larger. We have gone 3 sizes. We have not even actually gone to the 4 sizes. This is a representative image. The last one we've done was, I think, a lady in her 60s who had a 15 annulus. We enlarged it and put a 21 bioprosthetic valve. So the larger valve makes sure that the valve lasts longer, and subsequent TAVR, when they come to it, is not problematic, good gradients for, and everyone's happy at the end of the day. This is a minimal access mitral valve replacement. I'll try and take it to the surgery. This is our vision through an endoscope. If you see here, the hook is actually looking at the ruptured cord on the P2. We mark out those edges, cut it with the scissors, and then reapproximate the edges. Most of our, not most, all of our valve replacements are stabilized with a ring because the annulus dilates. We want to bring down the annular size, and that's a ring over there. And we use a knot fastener called a core knot, which cuts down our clamp time. At the end of it, we would insufflate the whole thing and see whether there's a leak. So the valve looks pretty competent, and that's how most of our valve repairs are done. And the latest craze is robotic cardiac surgery. So this is the Da Vinci robot. These are the arms. We've got basically 4 arms. One is for the camera, one is for the atrial retractor, and right and left working arms. This is the actual size of the incision that's on the patient. The others are like laparoscopic ports. And I'll show you a video of a valve replacement that is being performed. This has been sped up about 5 times. Aorta, cross clamp being applied. You see the cardioplegia going in. And this is intraoperative T at the same time. This is a video which is sped up quite fast. You see the valve over here, heavily calcified posterior annulus. You take the valve sutures, a bioprosthetic valve going in, knot fastener, and that's the end of the procedure. It's not as fast as this. It takes us about an hour and a half to do the procedure. The setting up takes about another 2 hours. So initially, we have struggled quite a bit. We have spent about 8 or 9 hours trying to do the surgery, but we've cut down our times right now. So at the end of it, this is the incision on the patient, and they're discharged on the 2nd or the 3rd postoperative day. ASD closure through a minimal access approach. Again, aorta being cross-clamped, SVC being looped. We open up the right atrium, visualize the ASD. These are retraction sutures on the right atrium. Most of these patients are, who have failed. This is the ASD over here. That's the coronary sinus in the sucker above over there. Over here is the IVC. Here, I think we'll be lifting. Yeah, that's the pericardial patch going in there. We tie it down with the knot pusher and close the ASD off. This is something we started recently for children above 10 years of age. We try to avoid this incision down there below the breast because that area is still not developed. So we go through a right vertical axillary thoracotomy and do that because once the arm is down, the scar is totally hidden and it doesn't interfere with breast growth, especially in young females. This is a robotic ASD closure being performed. That's the right and the left arms. Proline suture being used here. I think it's being closed directly. And the one on the left is showing the de-airing of the left atrium just prior to tying the last knot. Beyond this, we also have aortic aneurysms and dissections. This is the patient, a professor of medicine actually, who came in with chest pain. I think it was misdiagnosed outside. Luckily, he came back and said, this is not going away. Somebody did a CT for him. They found a distal arch aneurysm with a hemothorax. So we did a debranching and landed a TVAR on him. Unfortunately, this gentleman was in mid-70s. I think while landing the TVAR, he had a cholesterol shower, and now he's dialysis dependent, but he's still around to tell his tale. We also do, it's not just minimal access surgery. We do the entire spectrum of arch surgeries and everything else as cardiac surgeons. We can't just call cardiac surgery as minimal access. Sometimes you've got to go really maximal access. This is a young lady in her mid-30s who had a chronic dissection, arch aneurysm, and this is the whole thing replaced, a Bental and a total arch replacement at the end of the procedure. This is a thoracoabdominal aneurysm. And what we're seeing right now is, we're seeing younger patients with very bad coronary artery disease. We're seeing younger patients with low ejection fraction. And what we do is, whatever we have done, we have tried multiple arterial grafts. We have tried a second arterial graft to the lateral wall. These patients keep coming back. Not immediately, probably 5 to 10 years down the line. And the place where I work in, most of our CABG patients are right now in their 40s or early 50s. Bad diabetics, undiagnosed diabetics, patients who are not compliant with medication, or just don't want to take medication, and they come to us and expect a miraculous cure. But these are vessels which are badly chewed up. We do 3 grafts, 4 grafts, multiple arterial, they come back. There's been a patient whom we took through with a low EF, I think 25%, put a balloon, did a surgery, sent him home, and he's back with us at 1 month, and I think now he's being listed for a heart transplant because he's not going anywhere. So we are seeing younger patients, and most of these patients whom we either stent or operate in the younger age group, coronary artery disease, are going to end up on the end-stage heart failure route. India being a country where the penetration of insurance is very little, LVADs is probably out of the question because the latest generation LVAD, the HeartMate 3, the total cost to the patient by the time he walks out of the hospital is about 1.05 crores. While the older generation, HeartMate 2 LVAD, is about 60 lakhs. So if you look at it, this is an easier option. I think it's about 15 to 18 lakhs for a heart transplantation, and the chronic immunosuppression that goes along with that. And finally, we have that spectrum of patients with Eisenmenger's who have a heart and lung transplant. Outcomes are not great. 5-year outcomes are about 50% with a heart and lung transplant. Heart transplant is about 10%. We ourselves have done about 3 in the last month or so. So I think cardiac surgery has reached a point, thanks to our friends in cardiology. We have to go by Thomas Alva Edison's words. There's a way to do it better. Find it. I think we're still on that path. We're getting there. And finally, this is, I think, what we should believe in. This is most important. It's not cardiology versus cardiac surgery. I think it should be a team effort. Thank you, everyone, for a patient listening.
Excellent presentation by Dr. Arul.
Thank you, sir.
Converting the conventional cardiac surgery techniques to, minimally invasive or minimally access cardiac surgery, which is now getting more acceptable by the public also.
Yes.
Because earlier the conventional surgery always used to frighten them, saying that the chest is open, widely like that, and it used to take a long, like 3 to 6 months to recover like that. But minimally access and minimally invasive. See, the minimally invasive means the first minimally invasive came in 1990s in the mid, when I was in Madras, At the time, we didn't had any stabilizer. To do the LAD stabilize, my 2 fingers were the stabilizer. And so my consultant used to do the anastomosis. Later in 1997, the Octopus 1 came to Madras. I was the first one to do with the Octopus 1, and it was there for 3 months. It is a huge structure. It's about, not like today's.
Yeah, not sleek.
It's about 5 kilos or more. Each arm coming from head end of the table, and it first started in 1997. So today is the 26 years. I have patients who undergone the minimal invasive in the sense a beating heart surgery, still living 23 years after that. So that gives a good result. The result with the off pump is very good. The question is, I would like to ask, recently there are a lot of discussion was going on regarding the minimally invasive. Recently also, last month there was a paper from Germany. What they say is whether you do a conventional big incision or a small incision with the port access, whatever may be, it's only a question of for first 2-3 months. After that, whether it is a conventionally opened large incision patient or whether there is no difference.
I think it's just the initial period.
It's initially first 1 or 2 months only makes the difference, saying that it's less pain and less days stay in the hospital and maybe infection rate. So many things we talk about. But the question is, again, the time it takes, the longer operating time, whenever you go for the minimal access, the operation time increases, which whether it is really good for the patient or not. And finally, the long-term result about any anastomosis done through the small incision. And the visibility is, even today, even with the robotic also, we have to stitch the anastomosis with our hand only, no other way. So all this has got so many things. So it's too early to tell whether all these, especially this coronary I am talking about, maybe valve, other things and all very good. Even the upper sternotomy, half sternotomy, heart aortic valve replacement I used to do in 1996 in railway hospitals. Then I have done a lot of cases at that time. Then this question of long-term patency of all these grafts, how it is still we have to.
No, so I think there's only one large study, the one by Megan from Canada. So that's the only paper that everyone goes by. And they do about 2 or 3 cases a week. So I think it depends on volume and your comfort factor. And we should be very cognizant of the fact that this is not meant for all the patients.
Yes. That's
so there are patients with very bad disease, and they've come to us many times and told us we want minimal access. And we've outright told them, no, this is not what is meant for you. So I think you as the clinician should be in a position to say what is good for you and what is not good for the patient.
Yes.
If the patient demands it and says, this is what I want, then I think he's free to go somewhere else. But I think, especially in coronary surgery, long-term outcomes are important.
Yes.
And if it's not discrete disease, not good targets, there's no point doing it for the sake of doing it.
Yes.
Because we have seen results of coronaries. Each bite is important. If you're doing it in a very badly diseased 1.25, 1.5 millimeter vessel with, plaques all over the place, it's not going to be a good outcome. Even with conventional surgery, it's not a good outcome. So you're just giving the surgery a bad name.
So what is your percentage of people undergoing with this thoracotomy?
Minimal access. So everyone comes and asks for it, and I think we do it for about 40% of patients.
40%.
Not for all of them. Like I said, half our patients are, very badly diseased. Their EF is to 30%. Their kidneys are, running at a creat of 1.8, 1.9, and some of them don't tolerate single lung ventilation because we do this most of it on the beating heart. So if their PFT is bad and things like that, and some of them have a body habitus which is not meant for this. I mean, it's the struggle sometimes. The easiest part is the mammary harvest and the Lima LAD, but if you're doing a proximal, if you can't visualize the aorta in a short person, in a person who's obese, it's minimal access for the patient, but maximal torture for the surgeon.
So, what do you say about you are quite experienced in that, doing in
the minimal,
through the minimal thoracotomy.
Yeah.
What do you think how much the time difference it may be? If you have done it through the...
Yeah, so initially, let me tell you, I mean, the mammary harvest through a conventional stenotomy is about 15-20 minutes for me.
Yes.
This one takes about 25-30 minutes because I've been doing it for quite some time, but it's still longer. And the anastomosis, you're basically the only one who can see it, along with your physician assistant. Not everybody can see it because, it's a tiny hole.
Yes.
So you've got to be very sure of the anastomosis, and if you can't replicate an anastomosis which is done in open surgery, then there's no point doing it. It's as simple as that. So probably if you take about 7 or 8 minutes for an open anastomosis, this takes about 15 minutes, twice the time. But the setup and everything else takes some more time because it's a smaller space, less displacement of the heart and things like that.
So anesthesia time goes...
Anesthesia time probably is up by an hour, minimum. By an hour minimum.
So these are all some of the disadvantages.
Yes, yes, but I think we have reached a point where it's like when we just first started doing off-pump surgery. People, when they first started doing off-pump surgery, it took a longer time because they were not used to it. Like I work with a surgeon who does on-pump and off-pump, my chief surgeon. And when he goes on-pump, he does 5 anastomosis in 30 minutes. So it's just about being more comfortable with what you're comfortable with. I mean, at this point of time, we have to try and innovate and progress. So it's going to take us some time for everyone to get onto it, but eventually it's like basically what happened with laparoscopic surgery, with cholecystectomy. People said, oh, they're just playing around, but now that's the gold standard. This might not be the gold standard, but I think it should be one of the things that should be offered to patients, especially selected patients who require 2 or 3 grafts.
For us, the coronary anastomosis cannot be done through the, like a laparoscopy.
No, it cannot. It's a visual anastomosis. Yes. And other things to mention that the robot that we have currently for CABGs, the Da Vinci robot, is not approved for CABGs. We can just take down the Lima and Rima with that.
That's all.
Yeah, we can't do an anastomosis. They've taken out the technology for the latest generation.
Thank you very much. Very good presentation.
Thank you.
Now any questions? Any questions?
Dr. Arul's very good presentation. I had the good opportunity of seeing the end products of your very good hands. Now also a presentation. I would just like to ask you, did you have to switch over to the regular sternotomy after having started with the minimal invasive, like they do laparoscopic cholecystectomy and then suddenly find that they have to open up? Is that,
so there are some situations, especially in coronary surgery. The 2 situations is, one is you can't find the left anterior descending artery. There's something called a left anterior which is buried deep into the muscle, intramyocardial LAD. That's a nightmare sometimes even in open surgery. And second thing is if you're doing the proximal anastomosis on the aorta, if it's badly calcified, we just don't know where to clamp that. So you'll cause strokes. So I think what we do in our patients is we do a CT scan for everyone, make sure that these things are not there, have a look at the angiogram, make sure that we don't have an intramyocardial LAD. If you're selective, I don't think it should happen, but probably in about 100 cases, it would happen about 2 or 3 times.
I'll just modify his answer a little bit. It's not only those reasons for which we go for the pump. Doing an off pump is we have to finally balance the blood pressure. when you lift the
No,
heart.
I asked about the minimal invasive versus the open, this thing, in certain cases. And as Doctor, you put it very nicely, it is only perhaps the first few months that makes a difference. He speaks as an experienced cardiothoracic surgeon. I speak as a recent person who has undergone a bypass myself. So I feel, being a general physician, I often observed that ultimately something tangible done for the patient gives him a lot more satisfaction rather than something very minimal or something very abstract. This may be psychological, but even we see in ordinary cases, something tangible has to be done. And if it is only, as he said, from his experience, it is only the few months, or perhaps a rare case that goes for osteomass.
I think it's reached a point where certain patients expect it, certain patients don't expect it, but I would certainly not disprove the validity of conventional surgery. I mean, it's what we have all learned. It is what, like we said, we do about 60-70% of it is still conventional. And and I think that should never go away, because there are certain patients who cannot receive a surgery through this form.
So you think the minimally access or minimally invasive, still it is not well exactly defined. What this means?
No, minimal access. Nobody knows that.
About the length of the incision,
no, minimal
or
access,
avoiding the CPB.
Yeah, nobody knows that. Like off-pump surgery is even considered minimally invasive because you don't use the heart-lung machine.
Yeah, that is the most important.
So there's no universal definition for minimal. It's not the length of the incision.
Yeah.
According to the STS, if you just avoid the heart-lung machine, it is minimally invasive.
So in fact, in our cardiac surgery, the most invasiveness is the going on cardiopulmonary bypass. And the blood flowing through the.
Yeah, that's surprising. That's surprisingly only in India, because when I was in the US, all coronary surgery is done on pump.
On pump.
On pump.
Yes.
It's all on pump.
On pump only.
And they have fantastic results.
Yes, yes.
It's only in India we do it off pump.
Off pump. To save some.
Yeah, let's not get into that.
I think we should conclude now. It's a great lecture, Dr. Arul.
Yes, sir.
I would rather conclude saying this. Technology has come to stay in medicine.
Yeah, yeah.
When Ranjan discovered the X-rays, people said doctors are no more required. And he proved to be false there, because so many doctors are around. But today I doubt that whether it's going to be truth. Because technology is going to take over, AI may take over. I really don't know whether doctors are going to dwindle in their numbers. But nonetheless, technology is going to stay over, rightly proved by your lecture and the OCT, the previous lecture. And I was. All these things have made probably the life much better than what it was earlier, when we were probably students and teachers.
I think change is constant in life.
Truth. Thank you very much.
Thank you, sir.
Bigger surgeons used to make big incisions.
Thank you. Thank you so much, sir, for the informative session. Now I would like to invite Dr. Narasimha Pai, Professor HOD, Department of Cardiology, KMC Mangaluru, to please hand a token of our appreciation to our Honorable Speaker, Dr. Arul Furtado. I would also like to invite Dr. Aril Kamath, sir, Professor, Department of Cardiology, KMC Mangalore, to please commemorate our honorable moderators and chairperson. Dr. Musa Kunni, Senior Cardiac Surgeon. Dr. Sidney D'Souza, Professor, Medicine, Yenapoya Hospital, Mangalore. Dr. Joe Verghese, Professor Medicine, Omega Hospital, Mangalore. I know. Dr. Sidney D'Souza, Professor Medicine, Yenapoya Specialty Hospital, Mangalore. and Dr. Sadananda Nayak, Professor Medicine, Alwas Hospital, Mudbidri. Thank you so much, sir.
Now, we'll move on to the next session. This is the final session of the CME. The topic of the final session is coronary calcium, its role in diagnosis, and its contemporary management. I would like to invite the speaker of the session, Dr. P.L.N. Kapardi, to the dais to speak about the topic. Dr. Kapardi is a consultant interventional cardiologist at CARE Hospital, Hyderabad. Dr. Kapardi is a proud alumni of the Postgraduate Institute of Medical Sciences, where he completed his interventional cardiology training. Dr. Kapardi has vast experience of 20 years in the field of interventional cardiology, and he has many feathers to his cap, one being the first CHIP PCI of a single surviving complex RCA lesion in South India. He is a regular faculty for many national and international conferences in USA, Europe, and Japan. Dr. Kapardi is also an investigator in many clinical trials and has published papers in reputed national and international journals. Thank you, sir. Now, I would like to invite the moderator of the session, Dr. Subramaniam, Head of Department, Cardiology, Srinivas Hospital, Mukha. Thank you, sir. Now, I would like to invite the honorable chairpersons of the session to kindly have a seat. Dr. Nityananda Chauta, Consultant Physician, KMC Mangaluru. Dr. J.C. Adiga, Professor Medicine, Chetan Hospital, Puttur. And Dr. Archit Bolur, Consultant Physician, KMC Mangaluru. Thank you, sirs.
Good afternoon, everybody. It is indeed a great honor for me for chairing this important session. I thank Dr. Narsimpai as well as his team and the Department of Cardiology for giving me this wonderful opportunity. And also, it's been a great honor to me for me being associated with Dr. P.L.N. Kapardi.
Thank you.
Who was my senior at PGI. When I was doing my MD, he was doing his DM cardiology. He's a great interventional cardiologist, all of us know it. He's done great work, particularly in the calcified lesions. I think he was probably the
CTO.
Yeah.
CTOs.
CTOs. He is the first interventionist in South India to do an orbital atherectomy. It's a new device in these calcified coronary lesions. Over to you, sir.
Thank you. My respect to the Dr. Subramanian and other dignitaries on the dais. And at the outset, I am thankful to Dr. Narsimpan for giving this opportunity to share the knowledge in this CME, prestigious CME program. So, as we know, the coronary calcium, its detection and prognostic value, and what is the comprehensive contemporary management of these coronary artery lesions, and how these impact the PCI outcomes. So, if you take the natural history of the coronary artery atherosclerosis, as we know, it will start as a plaques, and slowly it will grow, and lipid pools will there. Initially, the specks of microcalcification, ultimately they will coalesce, forms the pools and sheets, and both deep and superficial calcium in the wall, and ultimately they will protrude in the lumen and produce the calcific nodules, but repeated injury and again healing will become a stable plaques from the unstable state. This is a constant process. If you take the pathological point of view, and which is useful in intravascular imaging previously described by Dr. Namasundi, so these are the depending upon the axial distribution of calcium, and depending upon the superficiality and protrusion of the lumen, and depending on the thickness of the calcium arc, and depending upon the distribution focal and long, these are the different classifications of the calcium. And we can assess the volume of the calcium by means of intravascular imaging. These are all intravascular imaging images, diagrammatic depiction of the intravascular imaging of calcium distribution. Sorry. So, as we know, the calcium quantification by C2, this has a very good prognostic value, and this is measured as Augustin units. So, as the calcium 0 means usually it is a negative, and it is a classical a screening test we will do. One of the important risk factor along with the others, whether the patient is going to develop cardiovascular events or not. So, usually 0 score means 5 years risk score is very low, and 1 to 10 also it indicates a minimal atherosclerosis of coronary arteries, and this is also with low risk of cardiovascular events in next 5 years. And 11 to 100 means it is mild coronary atherosclerosis present, where there is a mild coronary stenosis and mild risk exists. Whereas 101 to 400 Augustin score means moderate calcium, indicating the atherosclerotic plaque burden, and the risk of next 5 years cardiovascular risk is moderate, and more than 400 is a ominous sign, which indicates a very high risk score and high risk of the cardiovascular events in future. You can see here the distribution of the calcium. This comes under actual to mild to moderate. This proximal lady, this is the commonest site of coronary atherosclerosis. And what are the clinical implications of the lesions with high calcium content? They are the most challenging and most likely impact adversely on both acute as well as long-term outcomes of the percutaneous intervention. And obstructive calcium increases the procedural complexity and prolonging the percutaneous intervention, angioplasties, and sometimes it will cause very difficult in delivery of the balloons as well as dilatation of the lesion, which is difficult, and the stent passages, stent expansions also very, very difficult in lesions with high calcium. And it is age and sex dependent, coronary calcium, and most common in males older than 70 years. And the incidence of calcium varies depending on the imaging modality, and it is underdiagnosed by means of angiogram, because almost 60% only angiogram can detect the calcium, remaining 40% we are unable to detect it by means of routine angiogram. And coronary calcification is common also with large plaque burdens and greater degree of lesion complexity, especially if it involves the coronary bifurcations as well as the total occlusions. And the Burantas et al., he find that these lesions of high coronary calcium undergoing PCI less likely to receive complete revascularization, and they are more likely to die subsequently because of the incomplete revascularization and associated comorbidities. And this is the pooled analysis of the acute in Horizon AMI trials, that angioplasty performed in moderately severe calcific lesions are also with, especially in acute coronary syndromes, they are also with a very high risk of stent thrombosis because of inadequate expansions, inadequate apposition of the stents, as well as high risk of ischemic target failure. That means high incidence of restenosis is very high in case of calcific lesions. So, and adverse clinical outcomes are observed, especially with the high calcium lesions, and which is partly related to comorbidities and increased technical complexity and incomplete work. That's why nowadays there are tools are coming for the calcium lesion preparations. Typically, these lesions are challenging to cross, especially standard devices, and less likely to respond to balloon dilatations. So unexpandable, undilatable, and uncrossable lesions are very high in calcium. And inevitably, inadequate preparations before stenting increase the risk of stent loss and devices losses, devices damages, and intraprocedural complications, and acute vessel occlusions, and ultimately leading to the emergency surgeries also. So with this background, these are the complex lesion subsets, especially long ostial angulated bifurcation venous graft lesions, as well as type C calcific lesions, and lesions containing thrombus, left main, and CTOs. So this calcium, not only a long segment, but also it can complicate all these types of the blocks. So if you take the assessment, usually these CT scan, just it will overestimate the calcium. You can see this is the angiogram, which you are unable to detect the calcium. At the same time, CT angio showing the calcium in the wall of the LAD. And angiogram underestimates. You see, this is the OM lesion where the calcium is not seen, but it poses a problem of stent uncrossability in spite of the guide extension catheter. Ultimately, we have to modify means of OPN balloon to overcome this difficulty. So these are the things which is repeated slide previously Dr. Ravasundi has revealed. So the CT scan, coronary angio, OCT and IVUS, these are the 4 imaging modalities for the this calcium. And CT scan, actually this linear distribution of the calcium it will assess, but the plaque, the calcium distribution and all these, it is very difficult to measure CT. And coronary angiogram, it is mild, moderate, severe, we can classify by means of mild means non-visible, moderate means during motion only seen, severe means during rest also you can see as a tram track calcium, you can see as a tram track calcium or a speckled calcium. Whereas OCT and imaging, I was previously beautifully that described by Dr. Ravasundi, that is intravascular imaging is a must to have to do in calcific lesions, because it is assessed, it is very useful in assessment of the volume of the calcium in terms of thickness, distribution as well as length, and arc or axial distribution of calcium you can see. So these are the points actually. So this IVUS and OCT detects the calcium, and you can quantify the calcium also by these methods compared to the CT scan as well as coronary angiogram. So this is the already described. You can assess by means of calcium score both by OCT as well as IVUS. From 0 to 4 points it was given. The maximum one given during the axial distribution angle, less than 180, 0, more than 180, 2 points, and thickness less than 0.5 means 0, more than 0.5 means 1 point, and calcium length less than 5 millimeters, 0, more than 5 means 1 point. So 0 to 1 means mild calcium, 1 to 2 to 3 means moderate, and 3 more than 4 is heavy calcium. Like that IVUS also, the same scoring system is there, and as the scoring is more, it is a heavy calcium where you have to use the aggressive tools for the modifying the calcific lesions. So this is the influence of calcium on stent expansion. As the calcium arc is more and more, thickness is more and more, length is more and more, then more points, then the stent expansion by means of OCT is less, and you have to use the aggressive tools for calcium modification so that stent expansion will occur and the latest stent complication will be minimized. So these are the pre-PCA, post-PCA follow-up. If you see the calcium by IVUS and OCT, almost both will do better in terms of the calcium detection and volume scoring, except the deep calcium where the IVUS is inferior to the OCT. So this is the algorithm how we have to manage the calcium. Once you see some calcium on fluoroscopy or angiogram, then we have to do the whether we have to differentiate the low risk calcium features or high risk calcium features by means of intravascular imaging. So this is the one where intravascular imaging is must actually how to do, because angiographically calcific lesions we are unable to, our assessment will be false actually. So lesion assessment of calcific lesions. So once the high risk calcium, you can quantify either it is a mild calcific, moderate calcium or severe calcium. Mild means you can use the routine non-compliant balloons, or cutting balloon or scoring balloon you can use, which are special balloons with less aggressive modification. Once moderate score is there, that is 1 to 2 means, so where you can use the non-compliant balloon or ultra high pressure balloons as well as the cutting and scoring balloon. Sometimes some operators will use intravascular ectopics also. But in severe calcium, that is score more than 2 to 3 means you have to both ablate the calcium. That means that protruding calcium you have to remove by means of ablative device, rotablation, orbital atherectomy or laser, then followed by the modification, plaque modification, either by means of NC balloon or by means of intravascular ectopics you have to use. And then after modification, then you have to see the IVUS OCT, whether proper modified the lesions and cuts are there, then followed by stent implantation and stent optimization, that is expansion apposition will be there by means of repeat intravascular imaging, that is IVUS and OCT. So the calcified lesions is one of the important subset along with the instant restenosis where intravascular imaging is must for the good outcomes, and at the same time prevent stent success and will be you will get. and it will prevent the stent failure. With this background, these are the toolboxes or material we should possess once you want to deal with the coronary calcium. Large sheaths, guiding catheters, guide extension catheters play a significant role, and special guide wires and micro catheters, and intravascular imaging is must, and calcium modifying tools I will describe, and complication management, especially SNAIDs should be there, especially when the device losses or devices stent losses will be there when we are dealing with the calcium lesions. And these are the different guiding extension catheters which are available: guide liner, telescope catheter, guide gilla, trap liner, where which is available from 5 French to 8 French, and with a diameter of internal diameter of 1.42, and then the length of 150 centimeters. The traditional guiding catheter is 100 centimeters. This guide extension is 150 centimeters, where you can guide in, that is a mother and child technique. You can put these guide extension catheters through the traditional guide. You can go into the coronary to increase the support so that you can modify the lesion very effectively. And these are the important slide where the calcium modification tools, that is balloons versus atherectomy devices. So atheroablation, at the same modifying the calcium plaque. So these are the score flex and angiosculpted balloon, where the balloon is woven by means of a wire, and these are the semi-compliant balloons, and ultimately they are available in between 2 to 4 millimeters and 2 to 3.5 millimeters. You can modify the calcium plaque very effectively, especially in mild to moderate calcium. You can do this angiosculpt as well as core flex. With the extension of guide extension, you can give the support to the balloon to the calcium lesions. And then the most important is the cutting balloon. The first generation is flextome. The second generation is a Wolverine, where the profile is low, and it is basically nylon non-compliant balloon with the microsurgical blades, which is available between 2 to 4 millimeters. And with the help of guide extension, we can deliver this balloon to the lesion, and then you can cut in the calcium lesion so that the compliance will be improved, and then subsequently you can dilate it. Then atheroablative devices, these three: rotational atherectomy, orbital atherectomy, of course laser. These three are the atheroablation, where you remove the volume of the calcium which is protruding into the lumen. The rotational atherectomy, as we know, it is a diamond-coated elliptical burr. Only front portion is covered with the diamond chips, and which is available in 1.25 to 2.5 millimeter burrs. And by means of rotation, mechanical rotation, it will ablate the calcium. And second one is orbital atherectomy, which is a diamond back with 360 degrees of the diamond burr, and the available in 1.25 millimeters crown, and it rotates around 80,000 speed as well as 1.2 RPM. It will rotate, and then it will ablate the calcium. And only advantage of orbital compared to rotational atherectomy is it is 6 French guiding compatible with a Viper wire, which is a hydrophilic wire, unlike a rotational atherectomy, which is a special steel wire. And apart from these, the laser also I will just describe. And this is the one newer one, the intravascular lithotripsy. That is nothing but a balloon with 2 emitters, which emits the electrical waves that convert into acoustic waves, which generate almost 50 atmospheric pressure, so that the calcium becomes fractured, and then the vessel wall compliance will improve. Non-compliant vessel becomes compliant, so that you can dilate the calcific lesions. And the balloons which are available in lithotripsy, which send the acoustic waves, is 2.5 to 4 millimeters, and you will emit almost pulses up to 80, and nowadays it is almost 120 pulses also you can emit with 10 cycles. And this is the another important is open NC ultra high pressure balloon, where it is a double layered balloon and non-compliant, and almost you can dilate up to 35 atmospheres, so that the calcium lesions, undilatable lesions will yield. And of course, this is the ELCA laser, coronary laser, where you can workhorse fire, you can pass the laser and you can ablate the tissue, especially calcium tissue protruding into lumen, and this is useful in the moderate to severe calcium. So these are the different properties where the one tool will score over the other. Suppose if it is uncrossability, the rotational atherectomy is more effective compared to orbital and laser. And of course, non-dilatable lesions, rotational orbital will remove more amount of the calcium bulk compared to the laser. And of course, eccentric calcium, the orbital will do better. And for rapid exchange, that means workhorse wire, laser catheter is more effective compared to rotational orbital, which needs special wires. And of course, 6-French compatible, 3 are better. Orbital will do better with 6-French guide. And under expanded, of course, laser, it is better compared to the others. And different difficulties, especially during debulking and modification of calcium, is sometimes the devices become damaged, especially the OCT catheters, balloons, stents, wires, guiding. These becomes damaged when you are dealing with the heavy calcium lesions. And sometimes device migrations also will occur, especially balloons and stents. Balloons may rupture and balloon catheter may stuck and may, this one also, it will detach also. And stents may sometimes dislodge. And balloon uncrossability and balloon undilatability, these two are the common difficulties in calcium lesions. And of course, stent under expansion. These three are the common difficulties encountered by the interventional cardiologist during the debulking and modifying the devices. So this is the practical approach. Simple focal calcific lesions, do imaging, select the atherectomy device. If the score is high, take the aggressive devices like rota, orbital, laser, or these IVL, and you optimize the stent. Suppose in complex calcific lesions, especially left main bifurcation, long tortuous bend lesions, SVGs, as well as combination of devices, that means a rotatripsy, orbital tripsy, or by means of the laser tripsy. That means you combine both IVL as well as the rotablation or orbital atherectomies. And suppose these techniques of balloon anchoring, inchworm techniques, these are useful, where balloon assisted advancement of guide extension you can do for modifying the lesions. So this is the post-ABG. It is a protected LAD. Circumflex has a jet-shaped curve, you can see. So without just we take the NC balloon by means of guide extension catheter, almost it reached up to the lesion. You see the bends, jet-shaped bends. So you systematically dilated these two bends and ultimately delivered the stent. You can see 2 stents we deployed this with the help of the guide extension catheter. And of course, having a successful result like this. So that means NC balloons as well as OPN balloons, here we use it for the getting a good outcome. Then this is a focal calcium 45 degrees, you can see by means of imaging, where less aggressive tools, we did means of after OCT, we did the flextome. This is a flextome, and you can see the cuts also here. Then followed by stenting, which optimizes with the maximum luminal gain. You can get that one result. And then sometimes this is a balloon undilatable lesion. You can see, you can appreciate. Here, the mid segment is calcified. And this is the, in spite of the OPN also, you are unable, still the waste is persisting. Then ultimately, with the help of angiosculpt, it was yielded and followed by stenting. This previous I have shown is a balloon undilatable and at the same time stent uncrossable. You can see in spite of the guide extension catheter also, we are unable to deliver the stent. Then with the means of OPC, OP and N balloon, the lesion yielded, followed by stenting subsequent is become easy. And here also very important, we got these distal right coronary artery, you can observe the coronary calculus, that means a protruding calcific nodule. This is another important difficult subset. You can see at the 6 o'clock one calcium nodule and 2 o'clock calcium nodule with a spicule you can observe. And ultimately with the help of guide extension catheters and then cutting balloon, we modified the lesion and we got a good result with a maximum luminal gain. And next coming to rotablator, in 1990-95 it was a very good thing, but later it disappeared. Again, recently there is a lot of surge with the rotablation. This advanced rotablation concept where you can put the RPM of around 1,60,000 RPM, and max rota concept is differential cutting by means of breathing as well as a wire bias, where the maximum ablation of the calcium you can achieve. And along with these, you have to use either rota cut or rota sculpt or rota shock. With these, the maximal luminal gain you can observe. And this you can observe, this is a simple straightforward calcium in LAD, and you can observe the calcium nodule in the OCT, and ultimately you modified after this rota ablation. You can see the rota cuts, then followed by OCT help, we optimize the stent and achieved the maximal luminal gain. So this left main, you can see distal bifurcation lesion. We did the 1.5 fiber, we ablated the calcium. You can observe the coronary calcium. Then subsequently, we did the stenting. This is another subset where you can see the not only distal left main, ostial LAD also have the tight lesion with a calcific lesion. And ultimately 1.5 by, we did the rotablation, followed by NC balloon dilatation and provisional stenting, achieved the good result. And this is another calcific shepherd. You can see how the curvatures are there. So here you have to take the undersize burr to prevent the coronary perforation. 1.25 you have taken, adequately we dilated, and ultimately we got a good result. And this is a calcific CTO post-ABG, and ultimately we exchanged it with means of the filter XT wire with the rota wire, and then after ablation we did the stent. But here what after rota ablation we did aggressive post-stent dilatation, ultimately resulted in a small aneurysm, you can see intramural hematoma, which we appreciate in CT also. So we should not, aggressive post-stent dilatation should not do after rota, very important. This is the lessons actually. And this is a type C LAD calcific lesion, you can observe where we did a half rota, so that in curvatures and what we'll do, if you do aggressive rota, coronary perforation occur. So half rota followed by rota cutting balloon. This is a cutting balloon, and ultimately we optimize the IVAS, getting a good result. This is a stuck burr with a severe calcium. Sometimes the stuck burr is one of the complications where after giving NTG, we remove the entire assembly. You observe just as an assembly after NTG, it given away. Then we pulled back after giving intracoronary NTG, and ultimately giving the good result. And this is a heavy calcium of calcium left vein as well as LAD, where inadequate lesion preparation, we did the rota of circumflex and rota of LAD. So inadequate preparation will give these complications, how we manage it, you see. So what, after putting the left main to LAD stent, while putting the circumflex stent, it become deformed, and ultimately we have to pull by means of guide extension catheter with a loop, and later the wire in the circumflex was stuck after removal because it went into abdominal surface of the left main to LAD stent, and with the help of the guide gilla, you can see guide gilla along with the loop snares, we removed these LMCA LAD stent along with the wire, and reduced stenting was done with a good result. So these are very common, especially dealing with calcium, these type of catastrophes. You should be patient enough to deal the complications. And this is the calcium bifurcation lesion, where with the means of OCT, almost 180 degrees of calcium is there, more than 180. So we did the IVL, and ultimately IVL cuts you can see, and then followed by stent optimized, and then we got a good result after lithotripsy. And this is a calcium circumflex OM bifurcation lesion, you can see, you can appreciate a bend lesion was there, and even with the help of guide extension also, we are unable to pass the IVL. These are some of the difficulties, and the IVL has ruptured, you can see. Then what we did with the help of guiding extension, we did the sculpt balloon, we have taken, modified the lesion, and we got a good result ultimately. You can appreciate. And this another shepherd crook, severe calcific shepherd crook lesion with calcium of proximal and mid segment. We did the IVL. because Bent's rota is relatively contraindicated, which will produce perforation, and ultimately we optimize the by means of post-tension dilatation with a good result. So this is a left LAD calcific ISR where we did the IVL, and this is the ideal subset where protruding calcific nodule is the cause, got good result, and this is a calcium SVG lesion in the OM with the means of lithotripsy. We modified the calcium with good result, and this is a LAD long segment heavy calcium lesion where we did the combination device, both rota as well as IVL, with a good result. You can see the rota followed by tripsy, which means IVL, having a good result. And this is a bifurcation circle lesion where we did the orbital. And very important is, unlike a rota where you have to do woodpecking movement, for orbital you have to go like a tortoise very slowly, 1 millimeter per second. And then after adequate modification, then this is the orbital seen as a fluoro. You can see very slowly we are ablating, especially the bends used to be very slow, otherwise we produce perforation because of wire bias. And ultimately, thing definitely complicated, about to occur perforation, I stopped. Then I took the guide extension and took the IVL, and safely I did and came out. So bends, if it is there, better crossability, take guide extension, do IVL, than aggressive rota and aggressive orbital, where the vessel perforations arrive because of the wire bias.
Thank you so much, sir, for the informative session. Now, I would like to invite Dr. Sidney D'Souza, Professor, Department of Medicine, Yenapoya Medical College, Mangalore, to please hand a token of our appreciation to our honorable speaker, Dr. P.L.N. Kapardi. I would now like to invite Dr. Pavan M.R., Consultant Physician, KMC Mangalore, to please commemorate our honorable moderator and chairpersons. The moderator is Dr. Subramaniam. Dr. Subramaniam, Head of Department Cardiology, Srinivas Hospital, Mukka. The chairpersons are Dr. Nityananda Chauta, Professor Medicine, KMC Mangalore, Dr. J.C. Adiga, Professor Medicine, Chetan Hospital, Puttur. And Dr. Archit Bolur, Consultant Physician, KMC Mangalore. Thank you so much, sir.
So for the last activity of the day, we will be conducting a quiz. It will be an open session. Everyone is free to participate. Once the question is asked, please raise your hand if you would like to answer. Me or my fellow colleagues will provide you with a mic. Dr. Manish Rai, our DRS, will be moderating the quiz for today.
Which folder? Beat workshop adu. Workshop? Beat workshop. ಆಗ ನಾನು ಹಾಕಿದ್ದಲ್ಲ. Sorry, quiz. So the rules of the quiz are anyone can participate in the quiz, and whoever gets the maximum points will be the winner. So, please let me know, Ditesh, please let me know when to stop in 20 minutes. By that time, how many questions we finish and who gets the maximum points, please will be the winner. And someone is taking down the scores, whoever gets the right answer. Okay, you're taking down the scores. So these are questions based on severity. So these are easy questions for 10 marks and slightly difficult ones for 20 marks, and then more difficult ones for 40 marks. And then there are clinical scenarios and drugs. So you can choose. Anyone? Pick a lucky number. Yes, anyone can participate. So anyone wants to try? for 10 marks or 20 marks? Or else I'll pick a lucky number. Okay, we'll start off with 1. What is the diagnosis? Easy one. Raise of hands. Who raises the hands first will get the first. Raise your hand. Okay. WPW. Give them the mic, please. WPW, that's correct. Correct answer. Which sided pathway, madam? Any idea?
This is monophasic R wave in V1. So probably it has to be, origin has to be LV. And as the axis is lead 1 and AVF, it shows left axis.
Correct. If it's a positive delta in lead V1, it's a left-sided pathway. So correct. 10 points to Chaitra for the first one. So next one. Anyone? Pick a lucky number. Anyone trying 20 points or 40 points? Number 2. Okay, we'll not go in sequence. We'll lose the fun. What is the diagnosis? Another easy one. No negative marks for wrong answers. You can guess. Raise of hands, please. Raise of hands. PGs, anyone? Over there? What could be the answer?
He's getting late. He want his laptop.
Oh, who?
Long QT.
Who said that? Okay, we'll give you that. That is hypokalemia and QT prolongation, so it works. Okay, no problem.
Madam, what is your name, please, just for documenting?
Yeah, Dr. Jyoti.
Okay, thank you.
Okay, that's 10 marks for that question.
Thank you.
Okay, now, anyone? Pick up a numbers. 28. Okay, that's clinical scenario. Okay, all the following are associated with sudden cardiac arrest except Brugada, Last syndrome, Hasigir, MAD syndrome, and idiopathic VT. Which one is not associated with sudden cardiac arrest? Raise of hands. So Brugada, okay, someone said I heard something. Idiopathic VT, correct. Raise your hand. Who is it? Anirudh. So, Brugada syndrome we all know. Last syndrome, Hasigir is nothing but idiopathic VF. So that, idiopathic VF or J-point elevation causing VF. MAD syndrome is mitral annular disjunction seen with MVP patients. Patients with MVP having sudden cardiac arrest. Whereas like what Dr. Jaiprakash sir said in the morning, idiopathic VTs do not cause sudden cardiac arrest at all. Good, that's 20 points for Anirudh. So he's leading the quiz now, race now. So next, 23. Okay, who said 23? Dhruv, you'll have to answer this now. Huh? Okay. What is this rhythm? Just have a look at his rhythm. This is a Holter tracing. What is this called as? See, you can see only P waves. There's a specific name for this rhythm. I'm looking for that. This is about 20 points. Anyone? In the link, huh? Okay. Yeah, what was this rhythm? There was 1:1 rhythm in the beginning, and suddenly you have an AV block. What is this called as? So from 1:1 to AV block. Anyone? So you can see it again. There's a sudden transition from 1:1 rhythm, completely 1:1, to a complete AV block. What's it called as? No one? No points for wrong answers, don't worry. No negative points. Anyone wants to try? It's called as? Yeah? Okay, it's called as paroxysmal AV block, wherein the conduction changes from absolutely 1:1 to complete AV block. Okay, next. 13, fine. So 28-year-old with chest pain. So which of the following is not a physiological variation? Small q in lead V1, V2, q in lead 3, tall amplitudes in precordial leads, T inversion in V1 to V6, which is not physiological. So this is his This is his ECG. Which of this is not a physiological change? So the options are small q in V1, V2, q in lead 3, whether that is physiological, tall T waves in precordial leads, and T inversion in V1 to V6, which is not a physiological change. Yes. Yes, madam, you want to try?
Small q in V1, V2.
No, that's not the answer. Anyone else?
So Q in lead 3.
Q?
In lead 3.
No. Apparently both of them are physiological changes. Then?
T inversion in V1.
Tall amplitudes in precordial leads, that again could be physiological, T waves. So we are left with the fourth one. T inversion in V4 to V6 is never physiological. You can have T inversions in up to V4 in juveniles. Up to the age of 14 years, T inversions up to V4 is normal. But beyond V4 is abnormal. So you can't have T inversions in V1 to V6. Okay, so nobody gets points for that. Okay, next one. No, beyond V4 is not. So only till juveniles you can have till V4. Anyone? 31. Drugs. Which of the following does not cause QT prolongation? Amiodarone, sotalol, ibutylite, lignocaine. Which one doesn't cause QT prolongation?
Sotalol.
Sotalol causes QT prolongation. Anyone? Lignocaine, correct. Who said that? Yes. 10. Does this one? RBEB and 2:1 A block. What does it suggest? Infrahygiene disease. So the next part of the question is, all of the following suggest intra and infrahygiene disease except RBEP, normal PR interval, slow escape rate, improvement in AV conduction with exercise. Which of this is not a feature of intrahygiene disease? Madam, do you want to answer that? So RBEP is a feature of infrahygiene disease, right? Correct. So slow escape rate again indicates infrahygiene disease. Now one thing about infrahygiene disease is it becomes worse during exercise. So because during exercise what happens? The sinus rate picks up to 100, 110. Whereas the infrahygiene system is stressed out. So it can't conduct so much. So now the patient's sinus rate is 75. At 75 it's conducting 2:1. If you make him walk or exercise, his sinus rate will go to 100. That time the block will become 3:1 or 4:1. From 2:1 it will become worse. So exercise always worsens the infrahygiene disease. So this is the wrong answer. Still will give madam the points, okay? 20 points for this answer. Okay, so next question. 16. What is the diagnosis? Ritesh, tell us when to stop, okay? What is the diagnosis? Yes? Very fantastic. This is pre-excited atrial fibrillation or WPW with atrial fibrillation. So the clue here is FBI, fast, broad, and irregular. It is a rapid tachycardia, it's a broad QRS, and it is irregular. So VTs are always regular tachycardias, whereas pre-excited AF is irregular tachycardias. And if you look closely, sometimes you'll find narrow beats also, which are completely conducted beats, okay? Okay, so that was for 20 points to Chaitra. Next, any number? Pick up a number, that's easy. 20. Localize the lesion in the culprit artery. Yeah, raise your hand, please. Proximal LAD, correct. So you have ST elevation in lead V1 along with others. Okay, that's another 20 points. 30 points. Okay. Next question. 30, 30. Okay, drugs. The odd statement about amiodarone is, IV amiodarone should be given slowly, diluted in 0.9% NS. Amiodarone has a half-life of 58 days. Although it causes QT prolongation, risk of torsades is low. In chronic use, adipose tissue and skeletal muscle accumulates large amount of the drug, which is the false statement. C, that is, although it causes QT prolongation, risk of, who said the answer, but? Huh? Okay. Okay. Unfortunately, there is a better answer than that. That is not the right answer. It is true that amiodarone causes QT prolongation, but there is something called as QT dispersion. QT dispersion is not very bad with amiodarone, so it doesn't cause torsades. So what is the right answer? Anyone? Half-life, again, is wrong. It's between 58 to 125. Option? D, no points for this. Huh? No, in chronic use, it actually gets accumulated in adipose tissue and muscles. There is no way of excreting amiodarone except for the gut. So the answer is A. So amiodarone should be given slowly. It should be given with dextrose, not with NS. Yeah, it should be given with 5% dextrose, because when you give amiodarone rapidly, it causes hypotension. The hypotension is because of a diluent, constituent in that, which becomes worse with NS. So always you give amiodarone in dextrose if you have to prevent hypotension during infusions. Okay, so nobody gets answers for that, points for that. Okay, next one. Pick up a number. 29. Okay. Adenosine, all are true except adenosine is cleared from circulation by cellular uptake, mainly by hepatocytes. Adenosine has a short half-life of 10 seconds, can cause bronchoconstriction. Dose is 0.1 to 0.5 mg per kg, which is the wrong statement. Anyone? Raise your hands. Yes, what? A. What? Okay, so it's not. How is it cleared? That's the right answer. It's cleared by RBCs uptake, not by hepatocytes. Okay? Correct. So 20 points there. No, 10 points, 10 points. Dr. Manisha. Okay, now we'll move on to next one. 18. Sydney sir's choice. What is the diagnosis? Middle row, boys. The girls have only been answering so far. Yeah, what is the diagnosis? Quickly. Make an attempt, nothing will happen. It's a tachycardia, right? I'll give you a cue. It's a tachycardia. VT or SVT? VT. Oh, so raise of hands. I've given you half the answer. What is it? Raise of hands. Who said VT? Yeah, okay, Anirudh. What VT? Can you be specific? Can you be more specific? It's a VT, correct. But what VT?
RVOT VT.
Who said no? It's not RVOT. This is a fascicular VT. It's a VT. It's coming from the LV, no? RBEB pattern. And it is very narrow. So you know it's a VT because AVR is upright. So, and then in SVTs, usually V6 won't be negative. If you have V6 which is deeply negative, then it's more likely in an RBEB or LBEB pattern, it's likely to be a VT. So this is a fascicular VT. Okay, next. 5. What is the diagnosis? Easy one. Raise your hand. Okay. Complete heart block. Infrahesian or Hessian disease?
Infrahesian, broad
Correct.
complex.
Because it's a slow escape rate and a wide QRS, LBEB escape. So it's a complete heart block, infrahesian disease. 10 points. Okay, next. 21. What is this? What is this? His bundle. No? Fantastic. This is a SAECG, signal average ECG. Okay? Okay, so all is true except signal average ECGs are used to predict ischemia, are used to detect late potentials. They suggest non-homogeneous depolarizations, and they use for post-MI risk stratification, which is the wrong statement. Yes?
A.
Correct. Signal average ECGs, so you get 50-50 points, okay? Divide by 2. Huh? So half the question is answered by your friend there. So signal average ECGs are used for detecting late potential. So this is you can see this part of the signal average ECG, right? The signal average ECG is a computation of 400 beats. So it's not a single ECG. It overlaps 400 beats and gives you a single ECG. And what it does is it sees whether there are late potentials. If there are late potentials, it indicates SCAR. It says delayed conduction in that zone, non-homogeneous conduction, which is a risk factor or predictor of arrhythmias. So that was for 40 points, 20 points each. Okay, next. We'll take last 3 questions and then we'll stop. Whoever wins, wins. 22. What is happening here? Okay, this is on the house. Whoever answers this will get 50 points. Okay? Not 40. Panucci. Yeah. Yeah.
VT?
That's part of the question. What is happening? See, okay, I'll give you a clue. The answer lies in this beat.
Yeah, there is a capture beat.
Where?
The point which you're showing, it's narrow, actually.
The point which I'm showing is a,
Yeah,
is a normal
sinus
beat.
beat.
Is
Yes,
a sinus
sinus
beat.
beat.
That means rest of it is abnormal.
Yes.
Then what is it? There's an
Is it paroxysmal VT?
no. See, if this is a sinus beat, you see this is narrow. This is a sinus beat. This is a sinus beat. But then you have 2 tachycardias which are different and different morphologies. What is it? And if you look closely, one more clue, you look at this. What is this?
Yeah, pacemaker.
What is happening?
Yeah,
What is
they,
it?
No.
What is it?
No, actually they're pacing at higher rate.
Correct. You're right.
Yeah.
What is it called as?
ATP,
anti-tachycardia pacing. So what is
yeah,
happening here is your patient is having a VT, ventricular tachycardia. You can see this capture beat. And this is the ICD trying to overdrive and terminate it. So this is an ICD pacing at a faster rate. That's why you can see the pacing spikes and trying to terminate the tachycardia. And in the end, the ICD is successful. So it brings it to sinus rhythm. So this is a ventricular tachycardia with an ATP, anti-tachycardia pacing. Okay? No points for that. Okay? Last 2 questions. Okay. Pick up. 10. What is this rhythm? Easy one. Yes. Okay.
Mobitz type 2 AV block.
Type 2 or type 1? Okay, this is type 1,
is-
okay? So no points for this. This is type 1, Wenke-Bach block.
Sorry, yeah.
So Wenke-Bach block, what is not true about this rhythm? So we'll still give you the points if you answer this. What is not true about Wenke-Bach? There's a progressive increase in PR interval before the drop beat. Maximal increment occurs in the last beat. Decremental increase in PR. And the encompassing pause is less than twice the RR interval, which is not true.
C.
Decremental increase in PR. No. The
D,
PR.
D.
Which one?
Then D it is.
No, it's not D. If you see, it is B. The maximal increment occurs in the last beat. Maximal increment, see if you see this, no? This is PR interval of 200. The next beat has a PR interval of 240. Then you will have 260. So the increment between this and this is 40 milliseconds. The increment between this and this will be 20 milliseconds. So it's a decremental increase. The increase keeps on reducing. The last beat will have the longest PR interval. Before the pause, we'll have the longest PR interval. But as it progresses, the amount of increment keeps on reducing. So between the first and second beat, it will be a 40 millisecond increment. Next 2 beats, it will be 20 millisecond. Next, it will be 10 millisecond increment. Okay? Okay, the last question. 3. So someone wants to end with an easy one. What is the rhythm? Raise your hand if you want points. Huh?
Junctional rhythm.
Yes, this is junctional rhythm with retrograde P waves. Okay? So we'll close here. So at this point, do we have the points?
I couldn't. Who answered last? Sir?
Last one.
Okay, Dr. Jyoti. Dr. Jyoti comes first with points of 70, and Chaitra comes second with points of 50.
Okay, congratulations. Oh? Price. Call sirs. Saurav, call sir to give.
We'd like to call you on the stage.
Sir, call prize. Padma Kamath sir. So, can we invite Dr. Padma Kamath sir to give away the prizes?
Congratulations to both of you.
Vote of thanks.
Thank you to the esteemed dignitaries and participants for attending the Cardiology CME 2023, conducted by the Department of Cardiology, KMC Mangaluru. Your presence and participation has definitely made this event a great success, and we are grateful for the same. Now, I invite Dr. Manish Rai, Consultant Electrophysiologist, KMC Mangaluru, to kindly come to the dais to address the gathering to give the vote of thanks.
So finally, we come to the final session of the day, the vote of thanks. And I'd like to congratulate Dr. Narsimpai for conducting a wonderful CME with very good attendance and very well organized, single-handedly, almost single-handedly with the help of Ditesh, who's been the silent figure behind the stage. So, I begin the vote of thanks by thanking the dignitaries who graced the occasion in the morning, Dr. H.S. Balal sir and Dr. Unnikrishnan and Dr. Dilip Naik. And also the speakers who traveled from various parts of the country, from Bangalore and from Kerala, and graced this occasion, made time for this. I'd also like to thank the college for allowing us to utilize the venue for this program. And I'd like to thank the cardiology department, the staff who've been, behind the stage, behind the scenes, and doing everything. Can we, felicitate them with a small memento? Can we invite the Savita and her team to come forward and receive a memento from Dr. Narsimpai? Team na orna kariri. Nikhil na team, still na team next. Okay, we'll also like to invite the Cath Lab team. Aslam next. Please come on stage. I'd also like to invite Mr. Aslam, the official photographer, to come on stage to receive a memento as a gesture. Bani. Aslam, bale. Arna photo de play. We'd also like to put on record our thanks to Alicia, Saurav, and Hatim for their wonderful comparing that they have done. Please come on stage. We'd also like to thank Dr. Ditesh, who's been silently working behind the scenes, helping sir in everything. Ditesh, come on stage, please. Yeah, for quiz coordinating. We'll also like to thank Rakesh, Dhruv, and the entire team of KMC for organizing this entire function. And finally, I'd like to thank all the delegates, the doctors and the students who have attended this and who've been with us since morning, and the moderators and the chairpersons, who made time, who made sure that the sessions went on time and with good participation from the crowd. And I'd like to thank everyone else who's attended the CME. Thank you, one and all. Thank you.